low resource settings demands more studies to be taken up at local level. This study is in concordance with other randomized controlled trials and meta-analysis and aims to bring a change in the current feeding guidelines after surgery in benefit of patients. It was a randomized controlled single-blinded prospective study carried out in obstetric gynecology department of Jhalava Medical College from August 20 to February 21. Assuming the prevalence to be 25% for cesarean section with a 90% power and 4% margin of error, sample size was calculated using WHO sample size calculator. After obtaining approval from Institutional Ethical Committee, 200 uncomplicated term patients who underwent cesarean under subarachnoid block were included, and standard protocols for giving spinal anesthesia were followed. The patients were included, those who underwent the cesarean section under regional anesthesia at more than 38 weeks of pregnancy without any complications like PIH, diabetes, anemia, or any intra-op complications like bowel or mental adhesions, surgeries, injury, and blood loss more than 1000 ml, etc. These were the ones included were those between the age of 18 to 35 years, uncomplicated, kept nil by mouth for more than 8 hours, and with an operative time between 30 to 60 minutes. After obtaining the written consent in the vernacular language, a pre-tested performer was prepared in accordance with the study objectives and was used to collect the information from patients. The time taken was 20 to 25 minutes after face-to-face interview with the patients. These patients were followed on an hourly basis for 24 hours and then 2 and 4 hourly till the day of suture removal. Random allocation into two groups was done, group A and B, A being the early feeding groups where sips of water was given at 2 hours after surgery, and group B where sips of water were given more than 24 hours after cesarean section. This was then followed by liquid diet and soft diet according to the patient tolerance, and bowel movements heard on auscultation. The parameters observed was time for passage of flatus, bowel movements, stool, mobilization, duration of IV fluid in hospital stay, and complications if any. These duration was recorded in hours after the surgery was completed. A statistical analysis was carried out using SPSS version 20 of Windows Package software. Qualitative data was compared using the chi-square test, and the quantitative data, like the durations in time, was compared using paired student t-test. Results in both groups had similar demographic characteristics like age parity, gravidity, nil by estimated blood loss, etc. And the variations in the previous study and our study was because of a difference in the ethnicity, time of beginning of the oral feeds in the early fed group, the type of the feed given, the mode of anesthesia, and presence or absence of intra complication. These were taken as confounding factors. The results were as follows: that all the parameters, quantitative or qualitative, had lesser time or duration in the early fed group as compared to the delayed fed group and were found to be statistically significant. The post-op complications other than nausea and vomiting were much less in group A as compared to group B, that is early compared to delayed feeding. Maternal satisfaction was also found to be more in the early fed group because of adequate rehydration and the calorie intake. The discussion was as follows: that our study was found in concordance with Devi et al. And Chanterson in terms of duration of hospital stay and the return of bowel movements, as well as the duration of IV fluids given. It was also found similar with the Nagaraj et al., Katpalia, and Nantasufa in average time for ambulation after the surgery. This was probably because of the rate of body protein depletion was reduced and the wound healing was improved in early fed group, thus leading to faster recovery and mobilization. Adequate rehydration and improvement in the calorie intake also helped in reducing the duration of hospital stay. The paralytic ileus was most dangerous complication, and it was much less in the early fed group compared to the conventional feeding, and the results were comparable and statistically significant with the studies done by Mehta et al., Nagaraj et al., Devi et al., and Chanderson. The proposed theory for paralytic ileus could be stimulation of the cephalic vagal response and the GIT hormones like nitric oxide, VIP, and substance P, and the direct topical stimulation. So it was that conclusion that early fed group were having better compliance and satisfaction rates and had lesser complications compared to late fed group. Limitations were there were rare adverse effects could not be observed because of the loss to follow-up after the hospital discharge. Sample size was less, so there could not be extrapolation of the results to larger population. It only included the uncomplicated low-risk cesarean section taken under spinal. Those taken under GA were excluded, so studies need to be done on that. The dietary texture of the oral intake done was also not fixed, so it needs further study. My conclusion is that in this era of post-operative surgical care, we need to challenge the traditions and principles untested in the scientific-based studies. Early fed group had both improved nutritive value and positive effect on GIT, where such stimulation may decrease the duration of post-op ileus. So it concludes that present study had faster return to the normal diet and in the early fed regimen. The patient in whom the early feeding was started had early return to the bowel movements, ambulation, lesser GI complications, and early discharge from hospital. These findings add to the already existing research on safety and benefits of early oral feeding and concludes that now there is enough evidence for the clinicians worldwide to safely implement early oral feeding in low-risk healthy mothers after cesarean section. These are the references. Thank you for listening.
Very nice, Ayushi. Otherwise, what were the, how much was the, you keep the duration for NBM after spinal or GA routinely at your setup?
Conventionally, at our place, it is 24 to 48 hours that they keep NBM after the surgery.
All spinal, like if the patient has to be done femur surgery, you keep 24 hours post-operatively NBM?
No, this was a specific for cesarean sections.
Okay.
After lower limb surgeries and all, they usually keep about 8 to 10 hours.
Okay, great. Thank you very much. Now let us move on to our next e-paper. It is from Dr. Ruchi Gupta.
Hello everyone. The title for my free paper is Prevention of Oxytocin-Induced Hypertension by Co-Administration of Different Doses of Phenylephrine with Oxytocin in Lower Segment Cesarean Section under Spinal Anesthesia, Randomized Comparative Study. Introduction. Hypotension following spinal anesthesia is an extremely commonest adverse event observed in patients undergoing lower segment cesarean section under subarachnoid block. Apart from sympathectomy and aortocaval compression, oxytocin is also responsible for maternal hypotension. Phenylephrine is a short-acting alpha-1 agonist, is now a preferred vasopressor for spinal-induced hypotension in the parturients because of its ability to maintain uteroplacental blood flow better than ephedrine. Aims and objectives. This study compared the effectiveness of prophylactic dose of 50 microgram and 75 microgram phenylephrine along with the oxytocin over 5 minutes at the time of extraction of baby to prevent oxytocin-induced hypotension during spinal anesthesia for cesarean section. Primary outcome measured was incidence of oxytocin-induced hypotension defined as a decrease in mean arterial pressure more than 25% of baseline. Secondary outcomes measured were rescue vasopressor requirement, magnitude of hemodynamic changes, and incidence of side effects. Material and methods. This prospective randomized double-blind case-control study was commenced after Institutional Ethical Committee clearance, in which total 420 patients were assigned, 140 to each group blindly using a computer-generated table of random numbers in opaque sealed envelopes. Group C include, that is a control group, which include the patients which received 10 ml solution, in which 3-unit oxytocin with normal saline diluted up to 10 ml over 5 minutes as infusion. Group PE 50 patients received 10 ml solution, which included 3 units of oxytocin with phenylephrine 50 microgram, diluted up to 10 ml with normal over 5 minutes as infusion. And group PE 75 included patients, those who received 10 ml solution, which included 3 units of oxytocin with phenylephrine 75 microgram, diluted up to 10 ml with normal saline over 5 minutes as infusion. Demographic data, block characteristic, and hemodynamic variables were recorded. Data were entered into MS Excel and analyzed using SPSS version 70. Categorical data were presented as number and compared using chi-square test, and continuous variable were presented as mean plus minus standard deviation and compared using ANOVA test, that is analysis of variance, and post hoc test with 1 Fahrenheit correction were also applied as per need. P-value less than 0.05 was considered as statistically significant. Results, motor block characteristics. We compared duration of analgesia, sensory and motor blocks. We compared mean delivery time in 3 groups. We compared mean heart rate in 3 groups, post-spinal block. We compared mean heart rate post-baby extraction in 3 groups. We compared systolic blood pressure in 3 groups and mean systolic blood pressure. We compared diastolic blood pressure in 3 groups and mean diastolic blood pressure. Comparison of incidence and duration of hypertension in 3 groups. Incidence of hypertension was statistically significant. Number of hypertensive episodes were also statistically significant, for which p-value is 0.000, and total number of patients received vasopressors is also statistically significant. Total number of dose required per patient is also statistically significant, and rescue dose requirement per patient is also statistically significant with p-value of less than 0.05, which is 0.0036. Comparison of other side effects in the 3 groups. These side effects were nausea and vomiting, shivering, inadequate uterine tone, bradycardia, headache, itching. Discussion. A previous study which was done by Gangadharaiya et al. In 2017, which compared the effects of co-administration of 2 different doses of phenylephrine. Doses were 50 microgram and 75 microgram on oxytocin-induced hypotension during cesarean section in the spinal anesthesia in 90 parturients, and found that co-administration of phenylephrine 75 microgram with oxytocin 3 international unit effectively reduces the incidence of oxytocin-induced hypotension compared to phenylephrine 50 microgram without any adverse effect. We presume that a larger sample size would clearly reflect even the subtle changes in the hemodynamic caused by oxytocin and would substantially help strengthen the literature. Hence, we conducted the study to compare the effectiveness of prophylactic infusion dose of 50 microgram of phenylephrine along with oxytocin to prevent oxytocin-induced hypotension during spinal anesthesia for cesarean section in 420 parturients in terms of incidence of hypotension and rescue vasopressor requirement. Conclusion, we concluded that the prophylactic co-administration of 75 microgram phenylephrine with oxytocin more effectively reduced the incidence of oxytocin-induced hypotension than 50 microgram phenylephrine in parturients during lower segment cesarean section and the spinal anesthesia without causing untoward side effects. Limitations of this study were, we assessed hemodynamic changes in neonatal outcome with non-invasive methods, advanced monitoring techniques such as invasive blood pressure monitoring and umbilical cord blood gas analysis may yield more reliable and precise outcomes. Blood pressure and heart rate were measured with 2 minutes interval, and the short acting effect of oxytocin on hemodynamic variable may have been underestimated. These are the references for our study. Thank you.
Hello, Ruchi.
Yes, ma'am. Hello.
Okay. Can you please, Madam Chairperson, Madam is online. So can you please show the slide? Her, please. Chairperson, Madam is online, I think. Dr. Pratibha Madam.
Yeah, good morning. Good
Welcome,
morning.
madam. Good morning.
Thank you so much. Good morning. Okay, so can I ask, is there anyone else? Can I ask question?
Yes, madam. Please.
Okay. Okay. So, what is the duration of action of phenylephrine? As you are giving bolus doses of phenylephrine and you are recording number of episodes of hypotension. So, what do you think? What is the duration of action of one dose of phenylephrine?
Onset of phenylephrine is 2 to 5 minutes if given IV.
Onset.
Yes, ma'am.
And it acts for how long?
Please, Ruchika, video and camera.
How much is the duration? Because you have calculated the episodes as well. You know, that means if you have given one dose, then after giving that dose, then you have that counted the number of episodes as well.
Yes,
So does it affect the number of episodes as well?
Yes, ma'am. Half-life is 2.5 to 3 hours. Elimination half-life is. So then cesarean section will completed by 25 to 30 minutes usually. So during surgery, we can observe this effect of phenylephrine. And
okay. So you think giving 50 prophylactic dose should take care of the hypotension throughout for next 20 to 25 minutes, right?
And it prevents the oxytocin-induced hypotension.
So how you can, was the spinal dose was equal in each group, or the length, height of the patients were similar in all the groups?
Yes, ma'am.
The range of height was similar in all the groups?
It was
in spinal dose?
Yes, ma'am.
Okay, and there was no significant value comes in when it comes to the sensory level of in all the groups?
Yes, ma'am. Yes, ma'am. Demographic data were statistically insignificant.
Okay. Okay. It's okay. That's it. Thank you.
Thank you.
Thank you, madam. Our next presenter is Dr. Mahesh Kanda. Ganesh Kanda.
Good afternoon, everyone. I am Dr. Kanda Ganesh, anesthesia resident, Kalyan Institute of Medical Sciences of Bhubaneswar. I am here to present comparison among different sets of anatomical measurements of face for choosing a proper size of oropharyngeal airway. Oropharyngeal risk of operator collapse increase in unconscious and anesthetized patients. So, proper selection of oropharyngeal airway will elevate the tongue and hypopharyngeal structures and relieve the obstruction. So, choosing is important. So, smaller airway can cause obstruction of the digital end, where larger ones can cause perilaryngeal injuries. So, estimation of traditionally three sets of anatomical landmarks has been chosen as reference criteria by different reference criteria. American Heart Association guidelines recommend use of distance between corner of mouth to angle of mandible as reference criteria, whereas European resuscitation guidelines recommend using distance between coaxial incisors to the angle of mandible as anatomical landmark, and textbook Miller advocates use of distance between corner of mouth to tip of earlobe as anatomical landmark between choosing proper size of oropharyngeal airway. Very few studies evaluate which of these measurements as per used for proper selection of proper airway. The present study designed to determine which of these guidelines results in airway providing an adequate ventilatory parameters. The primary objective is to compare among using a proper size of oropharyngeal airway and the base of space of ventilation, localizing the tip of OPA in relation to the epiglottis. Second airway is to measure the second objective is to measure the distance between the tip of oropharyngeal airway and the epiglottis with use of flexible fiber optic bronchoscope. Study during 2 years and is a comparative study. Sample size was 122 after static analysis, which was adjusted to 123 and divided into 3 groups, 41 each patients of 41 each based on the facial measurements. And these are my inclusion and exclusion criteria. After getting ethical clearance and CTRA approval, consent patients were recruited. Consent was taken after explaining the procedure in detail prior to the operation, and pre-anesthetic checkup was done, keeping in mind difficult airway guidelines. And arrival in the operation theater, lying the patient in supine position. All the 3 measurements are carried out and recorded using caliber and scale. And then the 3 different oropharyngeal airways are selected based on the measured distances. OPA was selected randomly by a concerned anesthetist. Anesthesia was induced, and after confirming effective back mask ventilation, vecuronium 0.5 1.1 mg per kg was administered to achieve complete muscle paralysis. To deliver a consistent ideal volume, we applied mechanical ventilation using the pressure control mode after evaluating the adequacy of manual ventilation. The previously selected OPA was then inserted using the standard OPA guidelines, instructional guidelines. Adequacy of mechanical ventilation was assessed for mechanical ventilation. Fresh gas flow of oxygen was set at 2 liters per minute. Peak inspiratory pressure at 15 centimeters of water. Respiratory rate at 14 breaths per minute. And mechanical ventilation was classified as adequate or inadequate based on the anti-ideal volume, anti-ideal carbon dioxide, and peak airway pressure. Inadequate ventilation was defined as the mean expiratory tidal volume from the 6th to 10th breath was less than 5 ml per kg. Following effective ventilation, the exact location of the tip of OPA in relation to the anatomical landmarks of oropharynx was noted using flexible fiber optic bronchoscope. Endoscopic view was classified as either clear, partial obstruction by the tongue, complete obstruction by the tongue, or passing beyond the epiglottis. The distance between OPA and epiglottis was measured using flexible fiber optic bronchoscope. After fiber optic bronchoscope, airway was removed and orotracheal intubation was carried out. The data was categorical variables was shown as frequency and percentage, and the data and continuous variables was presented as mean and standard deviation across all the study groups. Intergroup statistical comparison of distribution of statistical variables was tested using size square test or Fisher-X test. In the entire study, p-value of less than 0.05 was considered to be statistically significant and statistically significant. The above table showing distribution according to the ventilation, anatomical according to the ventilation, maxillary incisors to the angle of mandible, and corner of mouth, the tip of earlobe, complete adequate ventilation all the patients, whereas corner of mouth to angle of mandible show 2 patients with inadequate ventilation. The above table showing fiber optic grading of fiber optic view, whereas maxillary incisors to angle, none of the patients is partial obstruction or obstruction is present, or in 7 patients the epiglottis tip is passed beyond the epiglottis. Corner of mouth to angle of mandible, 38 patients so clear, and 3 patients it is partial obstruction as noted at the digital end. In corner of mouth to tip of earlobe, 40 patients have clear vision, and only 1 patient the tip is passing beyond the epiglottis, and the data is statistically significant. And choosing an appropriate size OPA is of paramount importance for maintaining adequate ventilation. Our study aims to establish the reference, which of the above mentioned reference criteria is proper indicator for choosing oropharyngeal airway. In the corner of mouth to angle of mandible group, mechanical ventilation appeared inadequate in 2 patients, and 1 of the 2 patients had partial obstruction of the distal end of the OPA. Out of the 41 patients, 3 patients had partial obstruction of the distal end of OPA, and none of the patients that end passed beyond the epiglottis. Presence of inadequate ventilation in 5% of the patients, and partial obstruction in 1.3% of the patients. This group this measurement is inappropriate for choosing oropharyngeal airway. In the mandible group, adequate ventilation was noted in all the patients. None of the patients had obstruction at the distal end, whereas with a mean distance of 0.5 centimeters from distal end to tip of OPA, in 17.1% cases, the OPA passed beyond the epiglottis tip or touching the epiglottis, increasing chances of injury to the perilaryngeal structure. So this measurement is not ideal for choosing the proper size of OPA according to our study. When the OPA was selected based on the corner of mouth to tip of earlobe, it resulted in adequate ventilation in all the patients. Fiber optic view was clear in 40%, in only 1 patient which passed beyond the epiglottis. The mean difference of distal end of OPA and epiglottis is around 1.64 centimeters, as the corner of mouth to tip of earlobe showed adequate ventilation in patients and clear view as seen in all patients except 1. Our study findings suggest that anatomical measurements of distance between corner of mouth to tip of earlobe should be taken as reference criteria for choosing. Our present study findings were particularly with in our present study we found out that group corner of mouth to tip of earlobe showed better ventilatory parameters and fiber optic as compared to other 2 groups. In conclusion, in our present study we conclude that oropharyngeal airway size, which is based upon the distal distance from the corner of mouth to the tip of earlobe, more advantageous than the other 2 reference criteria for choosing the oropharyngeal airway with regard to adequate ventilation and an acceptable fiber optic view. These are my references. Thank you.
Our both chairpersons are online. So I welcome Dr. Sharbari Sweka Madam, who is a professor and HOD Emergency Medicine and
Institute of Postgraduate Medical Education and Research.
Institute of
Kolkata. IPGMR Kolkata.
IPGMR Kolkata. Welcome, Madam.
Thank you.
And Dr. Pratibha Mahajan, madam, she is associate professor at Hamdard Institute of Medical Science, Delhi. Welcome, madam.
Thank you
Over
so
to you
much.
for question answer.
Dr. Ganesh, you have presented nicely. I wanted to ask you one question. What are the cases you have used this OPA? Dr. Ganesh.
Sharbari ma'am, Dr. Ganesh Kanda participant is not available with us,
Acha.
so we can move towards our next participant.
Sure, sure. Our next participant is Zaved Iqbal. Zaved, Dr. Zaved, please, you can start your presentation.
Good morning. Today I am.
Please put it on slideshow.
Today my study topic is a
recording
prospective double-blind randomized control study to assess the duration and quality of analgesia of ultrasound-guided transversus abdominal plane block with ropivacaine and two different doses of dexamethasone in patient with lower abdominal surgeries. Transversus abdominal plane block has been used for over 2 decades now for nerve block and anterior abdominal wall. It is known to produce analgesia in infraumbilical surgeries as a component of multimodal analgesia. Its efficacy is providing post-op analgesia is proven to be in many abdominal surgeries. This is to prolong the duration and quality of analgesia. Many adjuvants have been tried, but dexamethasone is described to have anti-inflammatory properties besides enhancing the analgesia effect of local anesthesia. Previous work describing peripheral nerve block underlying the dexamethasone given along with ropivacaine enhance its post-operative analgesia effect. Optimum dose of dexamethasone that should be given along with ropivacaine in TAP block to provide maximum relief from post-op pain without producing side effect or minimal side effect. So our aim of study is to assess the effect of 2 different doses of dexamethasone on analgesic effect and duration of TAP block in patient undergoing lower abdominal surgeries. I include patient of age group between 18 and AST physical status 1 and 2, patient undergoing lower abdominal surgeries, patient who refuse to participate are in the exclusion criteria and allergic to local anesthesia, patient having skin infection or BMI more than 30 kg per meter square, and any pre-existing neuropathy. Sample size can be calculated on a software based. Total sample size is 90, including the 10% dropout in each group, 30 in each group. Group allocation will be done in 3 groups. Group R is control group, in which 20 ml 0.25% ropivacaine with 2 ml normal saline can be used. DR4 20 ml 0.25% ropivacaine with 4 milligram dexamethasone in 2 ml. And DR8 group having 20 ml 0.25% ropivacaine with 8 milligram of dexamethasone. After institute ethical clearance, subject fulfilling the inclusion criteria enrolled to the study, and CTRI registration was done, informed and written consent obtained, patient assigned into one of the 3 groups by a software-based random number allocation. Random number for the patient was noted on the case record form. Thereafter, the patient underwent the proposed surgery under spinal anesthesia block, subarachnoid block. Post-operatively, with all aseptic precaution, TAP block was given bilaterally with aid of ultrasound. The prepared drug was handed over to the who is blind, performing the block. Then post-op analgesia was assessed by using visual analog score. Rescue analgesia of paracetamol 50 mg per kg body weight. If VAS score is more than 4, followed by tramadol 2 mg per kg body weight, if not relieved in 30 minutes. Total dose and number of the rescue analgesia administered and can be calculated. We see the demographic of the patients in each group are comparable as per age, height, and BMI. ANOVA test to compare the visual analog can be done between the three groups, and we calculate the median and interquartile range. VAS score at 2, 6, 12, and 24 hours among the three groups are DR4 and DR8 is shown in the above table. At 2 hours, median VAS score in group DR4 and DR8 was 1.5 and 2 respectively, and in group R it was 4. This differences of VAS score is statistically significant, highly significant. At 6 hours, the median VAS score in group DR4 and DR8 was 3, and group R it was 5. The difference of this VAS score is also highly significant. At 12 hours, the median VAS score of DR4 and 8 was 5 and 3 in the DR8. The difference of VAS score is highly significant. 24 hours, the median VAS score in group DR4 and 8 was 4 and 3 respectively, and in group R it was 5. The differences of VAS score is highly significant. So we conclude the 2.25% ropivacaine and 0.25% ropivacaine with 4 mg and 8 mg dexamethasone in tab block provide post-op analgesia in patient undergoing LSCS. Post-op analgesia with ropivacaine alone lasts for 6 hours, whereas ropivacaine with dexamethasone in tab block provide prolonged analgesia of superior quality. Addition of dexamethasone to ropivacaine in tab block has added benefit of opioid sparing. So final conclusion, the duration and quality of post-op analgesia in superior with the addition of 8 mg dexamethasone with 0.25% ropivacaine in tab block. Our limitation of studies conducted in a single center, homogeneous study population for students aged 18 to 39 years and belonging to ASF physical states 2 undergoing elective or emergency cesarean section. The study includes only ASF physical status 2 patients, therefore its applicability in patients with systemic illness, obesity and elderly need to be investigated. These are my references. Thank you.
Okay. Thank you, Dr. Javed. The next speaker is Dr. Nitin Bovan.
Good morning, ma'am. Question answer session?
No, the previous speaker was not present. Okay.
This presentation is pre-recorded.
So have you, I have a question to Dr. Javed.
Yes,
did you allow the patient to have VAS score up to 5? And what did you do in those cases? Did you allow VAS score 5 up to 5 in patients?
No, ma'am. More than 4. I am giving the rescue analgesia with the tramadol 2 mg.
But your control group is showing, you have shown that in your control group, your patients suffer VAS score 5.
But then we replace with the paracetamol 15 mg per kg body weight. We are giving paracetamol, paracetamol, and if the patient need again the analgesia, then we replace it with tramadol. If the VAS score is more than 4, when we measure the VAS score, if the VAS score is more than 4, we can give the rescue analgesia then, and we'll note the timing for that.
Okay, thank you.
Yes,
the next speaker is Nitin Bovan. Nitin Bovan.
Okay.
Yeah. Okay.
Unfinished?
Pratibha madam, would you like to ask some questions?
Just wanted to ask, what is the mechanism of DEXA which increases the analgesic effect of any drug? Do you know the mechanism?
Yes, ma'am.
Because it is well proven. Sorry, I cannot hear that. You're not audible. I think you are. You have to unmute yourself, Dr. Javed.
Yes, ma'am. Please repeat the question. Actually, I'm in duty. That's why sorry for that.
Okay, it's okay. So, do you know the mechanism by which dexamethasone increases the analgesic effect of any drug?
Okay, ma'am. There are two, three hypotheses for that, ma'am. Once the dexamethasone act as a vasoconstrictor, it act like a epinephrine with the local anesthetic. It causes vasoconstriction to decrease the absorption of the local anesthetic. Second mechanism, it directly act as a on the nociceptive receptors to decrease the analgesic effect. Third, dexamethasone also act as an anti-inflammatory, ma'am. So it But the exact mechanism is not unclear, but there are 2-3 hypotheses according to the studies.
These hypotheses for all, huh?
Yes,
Even
ma'am.
for other effects as well. Okay. Thank you so much. Thanks.
Thank you, ma'am.
Go.
Thank you.
Thank you. Ma'am, go ahead.
So can I go to the next speaker?
Yes.
Yes, the next speaker is Dr. Nitin Bovan. Dr. Nitin, please start your presentation.
Hi all, myself and Dr. Nitin Bovan. I'm here to present my paper on comparison of hemodynamic parameters during intra-period of two drug combination protocol and protocol ketamine and protocol fentanyl for total intravenous anesthesia. So total intravenous anesthesia is the modified form of general anesthesia where induction as well as maintenance of anesthesia is done by intravenous agents alone without using any inflation agent. It can be effective alternative to general anesthesia when the rapid recovery from anesthesia is preserved, and the depth is maintained by either by continuous infusion or by intermittent bolus. Propofol is often considered as a drug of choice for short ambulatory procedure because of its rapid recovery and low incidence of post-operative nausea and vomiting. Ketamine is a potent analgesic and anesthetic in subanesthetic doses when used with propofol for total intravenous anesthesia. It causes less degree of myocardial and respiratory depression. Ketamine also causes some degree of sympathetic stimulation, which counters the cardiovascular effects of propofol, and the marked disadvantage is psychomimetic hemorrhage phenomenon. Fentanyl, on the other hand, is a synthetic opioid which has rapid onset and short duration of action. The problem with fentanyl is that it may exacerbate the drop in blood pressure and the effects of propofol cardiovascular system. Only few studies comparing ketamine and fentanyl as adjunct to propofol for short general anesthesia procedure have been carried out in Indian adult population, and none was found in this locality of this tertiary center located in Tiruvalla, Pathanamthitta district of Kerala. Aims and objective. The aim of the study was to compare and evaluate hemodynamic parameters and quality of surgical anesthesia in the intraoperative period of two drug combination using propofol ketamine and propofol fentanyl for total intravenous anesthesia. Note that it was a randomized double-blind study conducted in patients undergoing short surgical procedures in the Department of Anesthesia in Pushpari Institute of Medical Science. It's a tertiary center located in Pathanamthitta, Kerala, and study was conducted from July 2020 to June 2021 after obtaining institutional approval of and CTR registration. Sample size was calculated using the difference between systolic blood pressure for group 1 and 2 in the previous study done by Pavardi et al. Of Nagpur Medical College, and was published in the International Journal of Research in Medical Science in 2015. And sample size was obtained 41 in each group using the formula noted below. Inclusion criteria include patients aged between 20 and 60 years, ASA 1 and 2, patient undergoing short surgical procedures. Exclusion criteria include age less than 20 or greater than 60, ASA 2, hypersensitivity, and unwilling patients. Patient plan for the elective procedure will be approached prior to surgery, and written from consent will be obtained. Pre-anesthetic checkup was done day prior to surgery. Informed anesthesia consent was taken and was kept nil for oral for 8 hours. Pre-medicated with tabradine 150 mg, metaclopramide 10 mg, alprazolam 0.2 mg on night prior to surgery as well as 2 hours prior to surgery. IV access was obtained. Vital parameters was monitored prior to surgery using pulse oximetry, NABP, and continuous ECG. Pre-oxygenated for 3 minutes. Group A will receive ketamine 0.5 mg over 2 minutes followed by propofol 1 ml over 3 seconds until the endpoint of induction. Loss of verbal response was taken at the endpoint of induction. Group B will receive 1.5 microgram per kilogram fentanyl followed by injection propofol 1 ml over 3 seconds till the endpoint of induction. Respiratory rate saturation was recorded at regular intervals. Total dose of propofol 25 mg was given, and the patient became light during anesthesia. And this was the result. Demographics was not significant in both groups. Heart rate was significant. Comparison of heart rate was significant during 1, 3, and 5 minutes. Systolic baby showed significant difference in 3, 5, 10, and 15 minutes. Similar trend was observed in the diastolic as well as mean arterial pressure. Coming to the discussion part, patients in both groups did not differ significantly with respect to demographic area. Distribution as well as SSI was similar in both groups. Pre-induction pulse rate, systolic BP, diastolic BP, respiratory rate, and arterial saturation was comparable with no statistically significant difference. Evidence shows that ketofol selection has more benefits of cardiovascular stability, air preservation in procedure selection with counterbalance the effects of each drug. We identified ketofol as an effective sedative, and only tachycardia was the complication observed. A study was similar to the study conducted by Tosman et al. The mean pulse rate at 135 minutes in the beginning of surgery was more in propofol ketamine group and was statistically significant. Conversely, hypotension and bradycardia was obtained in patients with phenol sedation. It seems that ketofol acts by deactivating the side effects and preserving the sedative effects. In study conducted by QT and et al., hypotension was occurred in 38% and in propofol fentanyl group with compared with 14% in propofol ketamine group, and similar findings are observed in our study. In group 1, we found statistically significant change in the intraoperative mean blood pressure at 1, 3 and 5 minutes. Similar trend was shown in 10 and 15 minutes, whereas group 2 showed decrease in the systolic BP after induction. Similar trend was shown in diastolic as well as mean arterial pressure. Concluding the fact that group A has more hemodynamic stability when compared with other group. Ketofol has a major role in reducing the post-induction hypotension as well as causing less adverse respiratory events. Tosman et al. Compared propofol ketamine with the propofol fentanyl combination for deep sedation of analgesia and concluded that comfort was better with propofol ketamine. Conclusion: our study concluded that propofol ketamine combination provided better hemodynamic stability compared to the propofol fentanyl group, and propofol ketamine combination reduces the incidence of postoperative sedation and nausea vomiting. In line with our study undertaken with Messenger et al. Breathing in raw air, ketamine was safe than fentanyl as an adjunct to propofol when given in titrated dose. When compared with fentanyl propofol, ketamine propofol caused substantially fewer intra-sedation events at all levels of severity while having same efficacy and recovery profile. There are other studies report that combination of fentanyl with propofol depressed hemodynamics, but the combination with the ketamine and propofol resulted in stable hemodynamics. These are consistent with our studies too. And these are my performances. Thank you.
Okay, thank you, Dr. Nitin. I'm requesting Dr. Pratibha to talk to Dr. Nitin.
Thank you, ma'am. I just wanted to know in the ketamine group, the analgesia was taken care by only the ketamine part only, 0.5 milligram. It was taken care by ketamine, or are you giving some? Have given some other analgesic to the patients,
No,
or
no,
just
no,
ketamine?
Only ketamine.
Okay, so 0.5 milligram per kg, the analgesic effect of this ketamine was enough as an analgesic effect for those surgeries?
Yeah. For short duration surgeries, 0.5 mg per ketamine, 0.5 mg was enough.
So what type of surgeries you have chosen for?
Madam, we mainly did in gynecological procedures like D&C, fractional curettage.
Okay.
Procedures lasting for about 20 minutes.
Just 20 minutes. Okay, and how you decided that the dose 0.5 ketamine is equivalent to 1.5 microgram of fentanyl? Just a random dose.
Analgesic dose was taken from literature.
Okay. Okay.
And have you seen any incidents of nausea, vomiting after these procedures? And what was, in which group it was more?
Nausea vomiting was more in fentanyl group because of opioids effects on amniotic system. With fentanyl group, nausea and vomiting was common, and ketamine group hadn't any post-operative nausea vomiting.
So what was the result in your study?
In my study, hemodynamic stability was more with ketamine group, as fentanyl group had depressed hemodynamics, and fentanyl group also had side effects like postoperative nausea, vomiting, and moreover, pain on injection was common in fentanyl group.
So what
Okay,
about
thank you.
post-op analgesia? Okay, thank you.
Ma'am, our previous participant, Dr. Ganesh Kanda, is here with us. So you can ask him questions.
Last, बाद में करो. Last,
Okay.
huh? I will take him last.
Okay.
Our next participant is Umadevi Maniam. Dr. Umadevi Maniam, you can start your presentation.
Hello everyone, this is Dr. Uma, anesthesia PG from AIIMS Bhopal. Today I would like to present my research topic, the efficacy of lower thoracic erector spinal plane block in patients undergoing lumbosacral spine surgery. And my guide was Dr. Jayaprakash Sharma. And now we'll go into our topic. As we all know, lumbar surgeries were more invasive and with severe postoperative pain, for which systemic analgesics, epidural, paravertebral blocks have been tried. And the adverse effects and the complications comes to our concern. To study the efficacy of perioperative lower thoracic erector spinal plane block for perioperative analgesia and lumbosacral spine surgery was our main aim. And the objectives were effect of erector spinal block on perioperative opioid sparing, postoperative NRS scores for first 24 hours, and time of first rescue analgesia. And it was a single-centered prospective study conducted in our department over a period of 18 months, that is from May 2019 to October 2020. And with the help of a statistician, we divided our study population into 2 groups, each containing 30, and which includes patients belonging to ASA grade 1 to 3, between 18 to 65 years of age and of either sex, scheduled for elective or emergency lumbosacral spine surgery. And we excluded the patients based on the refusal, infections or tumors at the site of block, polytrauma, allergic to local anesthetic, coagulation, sepsis, pregnancy, pre-existing physical or mental disorders. The patients were allocated into 2 groups, GA and GA plus ESP. And this group allocation was done by the consultant in charge of the OT on that particular day. And in GA group, patients received standard general anesthesia, while GA plus ESP group patients received erector spinal plane block prior to the general anesthesia. And with the standard monitoring like non-invasive blood pressure, ECG, pulse oximetry, capnogram, and urine output, general anesthesia was conducted. And on the other group of patients who received GA plus ESP, erector spinal block was prior to GA. In this, under all aseptic precautions, prior to conducting the block, a consent was taken and explained everything to the patient. And patient lying on prone position under all aseptic precautions. The high frequency linear probe was placed longitudinally 3 centimeters lateral to the vertebral column at the T12 level. And under USG, T transverse process was identified. And ultrasound needle was passed craniocaudally, tip of the transverse process. Then it was slightly withdrawn, and hydrodissection was done to detect the plane. And the drug levobupivacaine 0.25%, 15 to 20 ml was injected between the erector spinal muscle and the transverse process. And the spread of the drug was elicited craniocaudally. And the same procedure was repeated on the other side, and followed by which the sensory deficit was elicited on the posterior dermatomes, and then general anesthesia was given for the patient. And in the intraoperative period, analgesia was given based upon the intraop hemodynamic monitoring. If there is any rise in the heart rate or BP or both by more than 20% of the baseline, injection fentanyl 1 to 2 micrograms per kg was given. And in the postoperative period, we recorded the NRS scores at 1, 2, 6, 12, and 24 hours after the surgery. And if NRS scores were more than 3, first IV paracetamol 1 gram was given, and time of first systemic rescue analgesia was noted when paracetamol was given. And if the patient's pain score still persisted more than 3 by 10, even after 1 hour after giving PCM, then injection tramadol 100 mg given slow IV. And based on the comparison of the outcome parameters between GA and GA plus ESP, intrafentanyl use is more among patients of GA group, that is 20 out of 30, whereas it was 5 by 30 in GA plus ESP. And postoperative tramadol use was also higher in GA group, which was 22 by 30. 6/30 in GA plus ESP. And the time for first rescue analgesia was earlier in GA group, that was about 2 hours, and which was 8 hours in the GA plus ESP group. And as we see here in the graph, NRS scores in the GA plus ESP groups at all the time points measured were lower than 3, while the NRS scores in the GA group were almost always more than 3 in all the time points measured. And erector spinae plane block is an interfacial plane block where local anesthetic is injected deep to erector spinae muscle and superficial to the transverse process. And the drug diffuses anteriorly and act on dorsal and ventral rami of spinal nerves, and craniocaudal spread also occurs, involving 5 to 6 dermatomes. So opioid sparing effect was identified in the intraoperative period, which was 83% in GA plus ESP group, whereas it was 33% in GA group. And postoperative period, tramadol sparing was also more in case of GA plus ESP while compared to GA group. And post-operative NRS scores, as said earlier, it was almost always lower than 3. Only 5 patients had higher scores, mostly might be due to the extensiveness of the surgery and long duration of the procedure. And the time for first rescue analgesia was later in case of the GA plus ESP group, based upon the extensiveness of the surgery and based on the, so the opioid consumption was more in the major surgery groups where there is a posterior decompression with the pedicle screw fixation, while it was lower when compared to the microdiscectomies and the laminoplasties. So hemodynamic parameters are also almost lower at all the time points, but not a hemodynamic instability. And postoperative mobilization and hospital stay were not significantly related with that of ESP block, because it was purely based upon the surgeon's decision. And also due to the various diversity of the surgical procedure performed, operating team, and the etiology and surgical complications, there was no meaningful conclusion in the day of first mobilization and also length of hospital stay. And there were no complications observed in our study. And so the conclusion is that superior perioperative analgesia and opioid sparing effect was observed with erector. And in future, many randomized controlled trials can be done using catheters in situ rather than a single shot injections for better outcome profile. And this study was conducted after getting ethics clearance and also obtaining consent from all the patients. Thank you.
Thank you, Dr. Uma Devi. Dr. Pratibha, please.
Yes. Uma, very well presented. Slides were very good. The only thing you missed were references. Always mention references in the end.
The title of my presentation is Comparative Evaluation of Visual Analog Scale.
I can, is the, okay. So, Uma, what is the design of your study? I will see the design of the perspective, blinding, whatever. Can you describe it? What is the design of your study?
Actually, my study.
Diameter.
Hello, am I audible?
Yeah, you are.
Yes, ma'am.
I think there's mixing of two. Okay, continue,
ma'am.
Yes.
Actually, we got a sample size of 60 and tried for actual randomization, ma'am. But due to some issues with the CTRI registration, so we had to go without like actual randomization procedure. So the consultant in charge of the OT took the decision like whether to include the patient in GA group or in the block group.
But this is not the way you randomize the patient, first thing.
So actually, this is not a proper randomization study, ma'am.
Yeah, yes. And what about blinding?
Blinding, actually, patient is blinded, ma'am. And also
how patient is blinded?
We have taken
yes. But GA is instituted after giving a spinal plane block, right? So was the patient blinded?
No, ma'am, sorry. Okay. Not the patient, but the parameters who had taken in the OT, the PG who is there and the resident who is monitoring the case. Actually, the person who gave the block is different, and the parameters who took all these parameters intra-op were different, ma'am.
Intra-op or post-op?
Both, ma'am. Actually, block was given by myself. And intra-op and the post-op, the person who is in charge, who is posted in that particular OT, took care of noting the NRS scores in the post-op and also intra-op opioid requirement and also in the post-op requirement.
So without aware of that patient has been given block. Good.
Yes, ma'am.
Okay, your time is up. Thank you so much, ma'am. Do you want to ask something? Over to you, ma'am.
Yeah. Dr. Neeraj Gautam, our next presenter.
I'm requesting to
Hello,
all
everyone.
participants that whenever your question answer session is going on, then keep your camera turn on.
Hello, everyone. The title of my presentation is Comparative Evaluation of Visual Analog Scale and Pupillary Diameter for Post-Operative Pain as an Observational Study. The background of my study is pain is defined as an unpleasant sensory and emotional experience associated with actual or potential tissue damage, or described in terms of such damage. The objective understanding of pain guides about the effectiveness of various post-operative pain management strategies. The measurement of pain by VAS is dependent on the individual's cognitive and emotional ability. Pupillary dilation has been successfully used to measure pain in quantitative terms. The present study was conducted.
Dr. Neeraj is not here with us, so we are moving towards our next participant, Dr. Nivedita Gurukulle.
Dr. Nivedita Gurukulle.
Good morning, ma'am. Good morning, everyone. I am Dr. Nivedita from Safdarjung Hospital. I will be presenting a paper on comparison of norepinephrine bolus with prophylactic infusion for the management of maternal hypotension during cesarean section under spinal anesthesia. Method for cesarean section is associated with hypotension in an up to 60 to 70% of the patient. Prolonged hypotension will lead to decreased uteroplacental blood flow and fetal acidosis. Ephedrine has low onset of action, relatively long duration, which makes the titration difficult. Due to ephedrine's low onset of action, fetal tachycardia may appear. If it is coexisting with oxygen deficit, it may lead to fetal acidosis. Phenylepinephrine has been chosen as the drug of choice for prevention and treatment of spinal-induced hypertension, but it is associated with receptor-mediated bradycardia. Norepinephrine has been suggested as an alternative to phenylephrine because it has both alpha and beta agonistic activity. Aim is to compare norepinephrine bolus and prophylactic norepinephrine infusion for the management of maternal hypotension under spinal anesthesia during cesarean delivery. Primary objective was to compare maternal blood pressure after spinal anesthesia using prophylactic intravenous infusion of norepinephrine and norepinephrine bolus. Secondary objective was to compare fetal acid-based status using umbilical artery blood gases in two groups to compare interval in two groups. There was a paucity of literature both for norepinephrine as prophylactic infusion bolus for maternal hypertension after spinal anesthesia during cesarean section in Indian population. The type of study was prospective interventional randomized comparative study. Full-term pregnant women undergoing cesarean delivery were recruited. Study venue was Safdarjung Hospital, Department of Anesthesia and Intensive Care Unit. Inclusion criteria were as a grade 1 and grade 2 patient undergoing elective or emergency cesarean section under subarachnoid block, height between 150 to 170 centimeter, BMI less than 30 kg per meter square, singleton pregnancy. Exclusion criteria were patients with significant coagulopathy and other contraindications for spinal anesthesia, patient with pregnancy-induced hypertension, essential hypertension, patient with history of significant systemic infection over the lumbar region of the spine. Randomization was done using computer-generated table of random numbers placed in sealed opaque envelopes. Block randomization technique was used. Even numbers were placed in group 1 and odd numbers were placed in group 2. Sample size estimation was done taking as a Nagan-Ketal as a reference values as a with a 99% of power of study and 5% of level as a significance. Formula used is this. Methodology pre-anesthetic evaluation was done. Informed consent taken from the patient, pre-medicated with injection ranitidine 50 mg and metoclopramide 10 mg IV. Baseline vitals noted. 18 gauge IV cannula was secured, preloaded with 500 ml of finger cracked solution, 7 ml per kg per minute, then started. Subarachnoid block was given using bupivacaine heavy ml with 10 microgram of fentanyl. Group 1 started with norepinephrine infusions prophylactically. After subarachnoid block at the rate of 30 ml per hour. Group 2 norepinephrine infusion bolus was given when systolic blood pressure less than 80% of the baseline. Each ml contained 5 microgram of norepinephrine. Heart rate, blood pressure, and saturation was noted every 2-minute interval till the delivery of the baby. Umbilical artery blood collected and sent for the analysis. Apgar score at 1, 5, 10 minute of interval was noted. Oxytocin and fluid were given as per the institutional protocol. Parameters noted were time of intrathecal injection, level of block achieved, time of starting of infusion, and vitals at 2-minute interval, time of skin, intra-incision, time of delivery, and infusion stop. Score at 1, 5, and 10 minutes of interval, umbilical artery, pH, PO2, PCO2 values, and total volume of infusion given, number of boluses, incidence of bradycardia, nausea, vomiting, side effects, if any, were noted, time of surgery, finishing of surgery was noted. Statistical analysis was done using statistical package for social science latest version. Categorical variable were presented in number and percentage. Continuous variable were presented in mean and median. Normality was test was done. If not common, non-parametric tests were used. Quantitative variables were compared using unweighted t-test and man-weight t-test. Qualitative variables were compared using chi-square test and Fisher-Extra. Consider significant if it is less than 0.05. Results. All the demographic variables were comparable between two groups. Change in heart rate over the time was not significant between two groups, whereas change in blood pressure was over the time was significant between two groups, especially at that time interval of 4 and 6 minutes. Incidence of hypotension in group 1 was 10% and group 2 was 100%. And boluses required in group 2 was significantly high, whereas in group 1 it was very less. Total volume of drug used was in group 1 was 6.4 ml and in group 2 was 1.4 ml. In group 1 was 6.7% and group 2 was 3.3%. In parameters like umbilical artery blood gas analysis and Apgar score at 1, 5, 10 minutes of interval were comparable between two groups. There was no acidosis and there was no incidence of Apgar score less than 7 at any interval. These are the graph. The bar graph represent percentage of hypotension and line graph represent change in blood pressure over the time in two groups. Our study found that maximum hypotension was in bolus group and infusion group, which was comparable to it was a study in which hypotension was 17% in infusion group and 66% in bolus group. Then et al. And Hasnin et al. Conducted a study on different doses of infusion, found a similar result as our study. Incidence of bradycardia 6.6% in group 1, 3.3% in group 2, which was comparable to Chen et al. And Hasnin et al. And Hagan et al. Study. Even umbilical artery blood gas analysis and Apgar score were comparable among these groups. To conclude, prophylactic norepinephrine infusion is better at maintaining blood pressure near or more than 80% of the baseline compared to bolus group, in which all of them required rescue boluses. Thank you.
Thank you, Dr. Nivedita. Asking you one question, what is, how did you, was it a blinded study?
No, ma'am,
If it is that, how did you blind the study?
No, ma'am, it was not a blinded study because even though it was blinded, a person would get to know because we are giving in norepinephrine infusion and boluses.
Okay. So over to Dr. Pratibha. You can please
Thank
take
you,
this
ma'am.
session.
Yeah. So, according to your conclusion, as per your study, infusion is better than bolus, right? But the dose, if you calculate the dose,
Yes, ma'am.
the dose administered was high in infusion as compared to bolus. Am I right? Is that so? Yeah, Nivedita, are you listening? Hello? Are you there?
Yes, ma'am. Yes, ma'am. Yes, ma'am.
So if you compare those, so the drug required is more in case of infusion. Do you want to comment on it?
Yes,
So,
ma'am. Hello,
so
ma'am.
maybe that may be the reason why.
Yes, ma'am. Hello.
Hello, yeah.
Hello.
Yeah, are you listening?
Hello.
Hello, Nivedita? Are you getting my point? Nivedita, are you there?
Internet connection is having problem. Her connection is not proper. Internet
Okay.
connection.
That may
Okay, fine.
be your point. Hello.
Yes, Dr. Nivedita.
Okay, let's move to the next. Should we move to the next participant?
So our next participant is Dr. Geeta M. Dr. Geeta M.
Good morning. Good morning. Dr. Geeta M. I'd like to thank Isacon for providing an opportunity to present my paper on the comparison of effect of clonidine versus dexamethasone as an adjuvant to 0.25% bupivacaine for wound infiltration to provide analgesia in cesarean section. I would like to thank my guide, Dr. Prasad CGS Sir, HOD of the Department of Anesthesiology, ESI Medical College, Rajajinagar, Bangalore. Introduction. The ideal postoperative analgesic regimen should provide effective analgesia but minimally invasive, cost-effective with minimal side effects. Surgical site wound infiltration has an edge over other methods of analgesia in terms of lesser side effects and is simple to perform. Clonidine is an alpha-2 agonist, most commonly used adjuvant to bupivacaine in peripheral nerve block and wound infiltration as a part of multimodal analgesia, but clonidine is associated with many side effects. Recently, dexamethasone, a long-acting glucocorticoid, has proven its effectiveness as an adjuvant to local anesthetics in brachial plexus block. It produces vasoconstriction and reduces absorption of local anesthetics and thereby prolongs the duration of action of local anesthetics, increases the activity of inhibitory potassium channels on nociceptive C fibers, thus decreasing C fiber activity and good anti-inflammatory action. Studies recommending dexamethasone as an adjuvant to bupivacaine in wound infiltration for postoperative analgesia are sparse, so hence the present study was undertaken. Primary objective of study is to compare the duration analgesia between dexamethasone and clonidine group following wound infiltration as an adjuvant to 0.25% bupivacaine for cesarean sections. Secondary objectives are to assess side effects like nausea, vomiting, and sedation due to dexamethasone and clonidine. These are my inclusion and exclusion criteria. Our study is a prospective randomized double-blinded study based on the previous study conducted by Bernard et al. And the total sample size was calculated to be 56, 28 in each group. After taking ethical committee clearance and informed written valid consent from the patients, the 60 patients were randomized into two groups, BC and BD group. Received 30 ml of bupivacaine 0.25%, 5 mg per ml plus clonidine 3 micrograms per kg, 30 patients. Group BD received 30 ml of bupivacaine 0.25%, 5 mg per ml plus dexamethasone 8 mg in 2 ml. The anesthetist who gave the drug was unaware of the combination. Preoperatively, ECG, NIBP, and SpO2 basal monitors were recorded. Under standard aseptic precautions, L3, L4 or L4, L5 interspace in left lateral position using 25 gauge queen case needle LP was done and hyperbaric drug of 0.5% to ml was injected. Pulse rate, BP, systolic BP, diastolic BP, mean arterial pressure, SpO2 are monitored at basal level at the time of subarachnoid block and 5 minutes intraoperatively till the end of surgery. At the beginning of wound closure, 30 ml of study drug was infiltrated into skin and subcutaneous planes at wound site. Post-operatively, pain was assessed using visual analog scale and readings between 0 to 10 every hour till the time of first rescue analgesia. Rescue analgesia was given if VAS scores more than 3 at the time of first rescue analgesia, and total number of rescue analgesia required in a day was recorded. Duration of analgesia is defined as time from wound infiltration to the time the patient remains with the first rescue analgesia. And injection tramadol 50 mg slow IV was given as a rescue analgesia. Hypotension is defined as fallen mean arterial pressure more than 20% from baseline and treated with crystalloids and ephedrine. Bradycardia is heart rate less than 60 beats per minute, and it was treated with atropine 0.6 mg IV. Adverse effects were noted and treated accordingly. Patient was monitored for 24 hours post-operatively. Statistical analysis was done using IBM SPSS 22 version software. Demographic parameters like age, weight, height, and sex, duration of surgery were comparable between both the groups. And in both the groups, there was no incidence of hypotension and bradycardia. The duration of analgesia, duration of postoperative analgesia in dexamethasone group was more, and it was statistically more significant compared to the clonidine group. The total tramadol consumption in the first 24 hours was more in clonidine group compared to dexamethasone group. Clonidine as an alpha-2 adrenergic agonist was initially used for its antihypertensive properties because of the large expression of alpha-2 receptors in CNS and the dorsal horn of the spine. The interest of drug as a centrally mediated sedative and analgesic. Peripheral analgesic action of clonidine is attributed to its property which enhances the release of enkephalin-like substances and inhibits the release of norepinephrine from pre-junctional alpha-2 adrenoreceptors in the periphery. But clonidine has many side effects. And but dexamethasone it has been used as an adjuvant in brachial plexus block to prolong the analgesic effect of the local anesthetic. In a study done by Jean-Marc et al. In 1997, they used different doses of clonidine, that is at 30, 90, and 300 micrograms in brachial novocaine, and concluded that a dose more than 300 microgram has severe systemic side effects. In 2013, Bharti et al. Observed that clonidine at a dose of 3 micrograms per kg when used either IV or by wound infiltration in patients undergoing open cholecystectomy under general anesthesia provided effective postoperative analgesia, but they also found that the incidence of adverse effects was less with wound infiltration. In our study, we have used clonidine at a dose of 3 micrograms per kg for wound infiltration. We did not observe any systemic adverse effects. Nataraj et al. In 2017 used clonidine at a dose of 3 micrograms per kg as adjuvant to 0.25% bupivacaine for wound infiltration following C-section, and they found that it prolongs the duration of analgesia and reduces opioid consumption without adverse effects. In our study, we used clonidine alone in the dose of 3 micrograms per kg for wound infiltration. Following C-section, it provided effective prolongation of duration of analgesia. Arish et al. Conducted a study with 38 ml of 0.25% bupivacaine plus 8 mg of dexamethasone and 38 ml of 0.25% bupivacaine plus 0.9% normal saline on 50 patients undergoing upper limb surgeries using the supraclavicular block. They found that addition of dexamethasone to bupivacaine effectively prolonged the duration of sensory motor block and analgesia with no side effects. Even in our study, we used dexamethasone 8 mg along with 30 ml bupivacaine, and it showed effective prolongation of duration of analgesia without side effects. So conclusion is dexamethasone is more effective than clonidine as an adjuvant to bupivacaine for wound infiltration in patients undergoing elective cesarean section under spinal anesthesia in prolonging the duration of analgesia without any side effects. These are my references. Thank you.
Thank you, Dr. Geeta. Nice presentation. Over to Dr. Pratibha.
Nicely presented, Geeta. Did you give bupivacaine? Did you added fentanyl with bupivacaine also? Is this the practice in your institute? What is the practice in your institute? Yeah. It was plain bupivacaine or with fentanyl as well. Was it plain bupivacaine or did you add this thing, fentanyl as well?
Fentanyl also.
Okay. Also, I missed that. I'm sorry. Okay. So, what is the incidence of bradycardia in patients who were given clonidine as infiltration?
We did not notice any bradycardia, ma'am.
Not even a single patient?
For wound infiltration.
Okay, good. That's over to you, ma'am.
Okay. Thank you, Dr. Geeta. Nice presentation. We are going over to the next presenter, Dr. Rafia Khan.
Yes, ma'am. Good morning. Good morning, everyone. Isacon from ESI Hospital, New Delhi. The topic of my today's presentation is comparative evaluation of time for orotracheal intubation using non-handle mounted video laryngoscope versus handle mounted video laryngoscope in patients undergoing elective surgery. As you all know that airway management is one of the most important skills in the field of anesthesia. Macintosh laryngoscope has always been a gold standard for definitive airway management. In recent years, video laryngoscopes have gained in popularity, and in our study, we have used one handle-mounted video laryngoscope, that is CMAC video laryngoscope, and handle-mounted video laryngoscope, that is MEC video laryngoscope. These are the two video laryngoscopes we have used in our study. After carefully searching recent literature on the online sources, we did not find any published study comparing non-handle mounted video laryngoscope and handle mounted video laryngoscope in India, although similar studies have been conducted around the world. Currently, there is a lack of clinical research contrasting various video laryngoscopes in India, so the present study was conducted in adult Indian population for the comparison of the two video laryngoscopes. Our study aimed to find out if there was any difference in time taken for orotracheal intubation between the two video laryngoscopes and used in patients undergoing elective surgeries requiring general anesthesia. CMAC video laryngoscope consists of three basic parts, namely laryngoscope, an electronic module, and a separate 7-inch monitor. It also consists of a lithium-ion battery with a built-in 2-hour power capacity. It has reusable metal Macintosh blade ranging from size 2 to 4, in addition to a deep for difficult airway in adult patients. It has slim blades and slanted edges to avoid tissue damage. The contact area of the blade of this video laryngoscope is significantly low as compared to the classic Macintosh blade, and this helps in making more space for lifting up the epiglottis. This is a CMAC video laryngoscope. MEC video laryngoscope consists of 2.5 inches LCD screen attached to a portable handle. It contains a light source with a small camera present at the tip of the blade, which is powered by a battery within the handle, and therefore it works as a portable unit, and separate power source and cables are not required. It contains transparent, sterile, single-use blades ranging from sizes 2 to 4 and a MEC X-ray for use in difficult airways. This is a MEC video laryngoscope. The research study was conducted in the Department of Anesthesiology, ESI Hospital, New Delhi. After the approval of ethical committee of the institution, a total of 60 patients were enrolled for the study, and informed consent was obtained from all patients. It's a prospective randomized study. We divided the patient into two groups, Group CM and Group MG. Each group consisted of 30 patients. Group CM, where orotracheal intubation was done with the help of CMAC video laryngoscope, and Group MG, where orotracheal intubation was done with the help of MEC video laryngoscope. We included the patients who had ASA grade 1 and 2, aged between 18 to 65 years age, patients undergoing elective surgeries requiring general anesthesia and orotracheal intubation. We excluded the patient who refused to participate in the study, patients who had predictors of difficult airway, cervical spine instability, BMI of more than 30 kg per meter square, patients who had risk of gastric aspiration, edentulous patients, and patients who had artificial denture. Patients fulfilling the inclusion criteria and giving informed consent to participate in the study were enrolled. Randomization took place with 60 sealed numbered opaque slips, of which 30 coded for Group CM and 30 coded for Group MG. All slips were kept in a box, and the video laryngoscope to be used was determined after the slip was randomly picked up by a fellow anesthesiologist who was unaware of the study. In both the groups, after induction of general anesthesia, video laryngoscopy was performed depending upon the randomization with either of the two video laryngoscopes. Video laryngoscope was introduced into the mouth, and the tip of the blade was advanced towards the epiglottis till the valvula. Orotracheal intubation was performed using endotracheal tube of appropriate size after ensuring that the glottis was in the center of the LCD screen. And for orotracheal intubation in seconds was noted. This is a laryngoscopic view as seen on the screen of CMAC video laryngoscope. On the other side, you can see the laryngoscopic view while the process of intubation on the screen of CMAC video laryngoscope. Time to intubate the trachea was started from picking up the laryngoscope till the successful placement of endotracheal tube, which was confirmed by auscultation of the breast and presence of square wave capnography on the monitor. If more than one intubation attempt was required, time from insertion of the laryngoscope for the first intubation attempt until the confirmation of successful intubation by capnography was considered to be the total intubation time. Both the study groups are recorded. In each group, tracheal intubation was considered as a failure if not accomplished within 3 attempts, and alternate devices were used for endotracheal intubation. Results reveal a statistically significant difference in the mean intubation time between the CMAC and the mid-neck video laryngoscope with a p-value of less than 0.001. The main benefit of the video laryngoscope is that the camera and the plate tip make the alignment of the oral, pharyngeal, and laryngeal axes redundant and speeds up the time of intubation. Comparing the two video laryngoscopes, we get that in CMAC video laryngoscope, there is presence of built-in software that initiates the pre-warming of the optical system by the camera light, and hence no cases of failed intubation were recorded during the study due to fogging of the camera lens. In case of mid-neck video laryngoscope, there is presence of anti-fog system, which is a hydrophilic coating on the optical surface to avoid condensation on the light source. Still, cases of failed intubation were recorded during the study due to fogging of the camera lens, resulting in poor visibility. The blade design of the CMAC video laryngoscope resembles standard Macintosh blade, which resulted in faster time to intubate the trachea without the need of stellate. Presence of a significant anterior bend in the blade of the mid-neck video laryngoscope necessitated the need of a tracheal tube with a stellate for intubation, and the removal time of the stellate was assumed to be an important contributing factor to slow the mean time for orotracheal intubation. Limitations to the study included that the intubating anesthesiologist could not be blinded to the randomization of the video laryngoscope used in the study, and this may have caused bias in the mind of the anesthesiologist if they had a preference towards a particular device. To conclude, I would like to say that although mid-neck video laryngoscope is a lightweight device, portable, and had various advantages over CMAC video laryngoscope, yet CMAC video laryngoscope allowed a significantly faster intubation time when compared with the mid-neck video laryngoscope. Mid-neck video laryngoscope has greater proximity of the display screen to the plate for a better hand-eye coordination, yet proper training is required for the better use of the video laryngoscope. One needs to gain experience in the technique that is needed for intubation with the mid-neck video laryngoscope. These are my references for the study, and thank you so much for patiently listening to me.
Okay. Thank you, Dr. Rafia. Nice presentation. Who has done this procedure? Procedures, Dr. Rafia.
Please unmute yourself, Rafia.
Good morning, ma'am. Ma'am, the procedure was done. Most of the cases were done by my professor and HOD, but few of the cases were also done by my senior consultants.
Okay. Do you do your endotracheal intubations regularly with the help of video laryngoscope?
Ma'am, since COVID time, we have been regularly using CMAC video laryngoscope. But prior to that, in difficult intubations, we used to have video laryngoscopes. We have both of them in our department.
Okay. So over to Dr. Pratibha, please.
Okay.
Morning, ma'am.
So as ma'am asked about the who perform all the intubation, so you need to mention the not the HOD, the experience of the
yes,
the years of experience.
Yes, ma'am.
The learning curve is it should be equal for both for Makrad and for.
We had this criteria of 5 years experience with both the video laryngoscopes. I'm so sorry I did not mention this thing. So all my senior consultants and my HOD sir, all of them, they had more than 5 years of experience, because it's been more than 5-6 years we've been using these video laryngoscopes in our department.
Okay, so with CMAC, you used this thing intubation, this bougie or some intubation aid with McGrath, not with CMAC.
No, not at all, ma'am. With McGrath, we used stellate because it has a significant anterior bend. So we tried initially without stellate, but it didn't happen, and that is why we had more time taken for intubation for that McGrath. But we did not require any particular aid for CMAC video laryngoscope.
That's what it is indicated, right?
Yes, ma'am.
Okay, thank you.
Thank you, ma'am.
Okay. Thank you, Dr. Rafia.
Thank you so much, ma'am.
Our next presenter is Dr. Shalini.
Dr. Shalini is here with us.
Yes. Please.
Hello everyone, I am Dr. Shalini Angalia, postgraduate trainee from Isacon Medical College, Kolkata. Today I am going to present my topic, ROX index validity in predicting early the need for invasive mechanical ventilation in COVID-19. So ROX index is the ratio of pulse oximetry divided by a fraction of inspired oxygen to respiratory rate. It is a simple calculation using 3 clinical variables which helps to determine a patient's degree of hypoxemic respiratory failure, which is of particular importance in COVID-19. The aims of my study were, the primary aim was to calculate ROX index and to validate in predicting early the need for invasive mechanical ventilation in COVID-19 patients on therapy or BiPAP. The secondary aim was to calculate the percentage of patients who failed HFNC and were needed to progress to intubation for further ventilatory support. My study was retrospective and observational, and it was conducted in COVID-19 critical care unit of Isacon Medical College over a period of 3 months on a sample size of 70 patients with laboratory confirmed COVID-19 on HFNO or BiPAP. The data that was collected were medical history, age, sex, comorbidities, COVID-19 infection clinical classification was done into or severe. Radiological findings were noted, and ROX index was measured at 2, 6, and 12 hours post high flow nasal cannula initiation and thereafter 12 hours. Laboratory biomarkers were noted. So on initiation of high flow nasal cannula, a ROX index was measured, and the predictors of high flow nasal cannula success included the following, and the predictors of high flow nasal cannula failures included the following. So according to my statistics, the collected data was put into a Microsoft Excel worksheet, and based upon the distribution, the data was presented as either mean or median. Frequencies and percentages were used to present nominal variables. An ROC curve was used to determine the most accurate cutoff point for prediction of intubation. A p-value less than 0.05 was considered significant. The results were, the study was included in 70 patients with mean age being 53 years old, and the clinical characteristics of patients were age, sex, and comorbidities. So among my participants of 70, moderate cases were 45 and severe cases were 25. Among the moderate patients, 38 patients required intubation, and among severe cases, 97 patients required intubation. Now, this is the ROX index management guidelines for high flow nasal cannula. So this is a graph depicting 2 groups, the first group being on HFNT and the second group being on high flow nasal therapy, which had to be progressed to invasive mechanical ventilation. A ROC curve was done, which predicted the need for using IMV. An accurate cutoff point was determined. So clinicians could use the ROX index to assess progress in COVID-19 patients, and it is a useful predictor of HFNC in COVID-19 respiratory failure. So I conclude that ROX index is a simple non-invasive tool for predicting discontinuation of HFNT and could be used in assessment of progress and risk of intubation in COVID-19 patients. The limitations that my study is retrospective and single center nature. These are my references. Thank you.
Good morning, ma'am. Good morning. Thank you, Dr. Shalini. Your presentation is very good. Nice slides. Over to Dr. You please.
Good morning, Shalini. Very nicely concluded, very nice retrospective study. And I totally agree with you that the ROX index do help in predicting the severity and all. But still, what do you comment upon that is solely ROX index? Can you predict this intubation criteria or the severity or the other criteria like how age, obesity, diabetes, or other radiological parameters do affect your decision in or the severity course
so
of the
other
patient?
criteria do affect my decision, the present status of the patient, the respiratory rate, and if the patient is able to maintain the saturation or not. Clinically, I have to assess the patient also. So ROX index was just a simple bedside calculation that was helping me to progress.
So it could be one of the parameters that could help besides considering other parameters.
Yes, ma'am.
Okay. Yeah. You want to add something?
Do you want to add any more points?
No, ma'am. No.
Okay. Only you have who was on HFNT, or you have written on your first slides
Yeah.
both the BiPAP patient, both the patients on BiPAP as well as HFNT you have chosen.
Ma'am,
But your
critical
results
phase, yeah.
results were showing a little different.
Ma'am, in my critical care unit, only those patients were admitted who were severe, moderate, and were already on high flow nasal cannula or on BiPAP. So, patients who were on BiPAP, we had, if they deteriorated, we had gone for intubation, and also that was the same case for patients on high flow nasal cannula. So both groups were included, both patients on BiPAP and on nasal cannula. Sorry, nasal therapy.
Okay. Okay. Thank you, Dr. Shalini.
Thank you, ma'am.
Our next presenter is Dr. Saminathan SV. Yeah.
Good morning. My topic is comparison of preoperative ultrasound guided facial iliaca block versus femoral nerve block for proximal femur fractures before positioning for spinal anesthesia, an observational study. Introduction. The fractures of the proximal femur, including fracture of neck of femur, intertrochanteric and subtrochanteric fractures, are a common orthopedic emergency, especially in the geriatric population. These fractures are extremely painful and associated with significant morbidity and mortality. Regional anesthesia is preferred during surgery in these patients. However, the severe pain associated with these injuries makes appropriate positioning difficult for regional anesthesia, thus altering their overall success rate. Pain can be detrimental in this group of patients as it causes tachycardia and hypertension due to enhanced catecholamine release. Opioids have been the main modality for conventional pain management, which are known to have serious systemic side effects. To overcome this problem, various nerve blocks have been tried. They help in proper patient positioning by providing preoperative analgesia. Aim to compare the facial iliaca block with the femoral nerve block using ultrasound to assess the overall efficacy for patients with proximal femur fractures during positioning for spinal anesthesia. Inclusion criteria: age group 18 to 80 years, patients with proximal femur fractures ASA 1 and 2. Exclusion criteria: coagulopathies, patients with head injury, known CAD, ischemic heart disease. Materials and methods: institutional ethical committee approval obtained. The patients were divided into two groups by convenience non-probability sampling. Group FIB receiving facial iliaca block with 30 ml of 0.25% bupivacaine. Group FNB receiving femoral nerve block with 30 ml of 0.25% bupivacaine. Depending on the allotted group, patients were given the block under the guidance of ultrasound in the preoperative area by an experienced anesthesiologist with more than 2 years experience. Femoral nerve block. Under ultrasound guidance, the femoral artery was identified. The femoral nerve was recognized as a hyperechoic structure, which is triangular in shape and located lateral to femoral artery. An insulated 22 gauge needle was inserted and positioned by the side of femoral artery. A small volume of local anesthetic was injected after locating the needle tip in a negative aspiration for blood. After distribution of local anesthetic was seen, the rest of the drug volume was injected. The ultrasound image showing femoral artery, femoral nerve, and the needle tip. Facial iliaca block. Lateral to the femoral nerve, the psoas muscle was located. It is covered by iliacus fascia, which is deep to fascia lata. After introducing the needle, a double pop was felt until the needle had reached a position between fascia iliaca and psoas muscle. Similar to the technique stated above, 1 ml of local anesthetic solution was injected after negative aspiration for blood. After spread of the drug was seen under the fascia iliaca, remaining drug was injected. The ultrasound image showing fascia iliaca block. Femoral artery, iliopsoas muscle, fascia iliaca, and the needle path and the needle tip between fascia iliaca and iliopsoas. Parameters observed: visual analog scale score, pre-block, post-block. Patients were made to sit for spinal anesthesia 15 minutes after block. Other parameters observed: time to achieve VAS score below 4, comfort of sitting during spinal, block performance score. On such chart, 45 patients are selected for study, 5 patients are excluded. Remaining 40 patients, 20 patients allocated to femoral nerve block group, 20 patients allocated to fascia iliaca block group. Statistics: all the data collected were tabulated with the Microsoft Excel, and statistical significance was calculated with SPSS software. The significance was calculated using student t-test, chi-square test, and p-value of less than 0.05 was considered significant. Observation and results: demographic profile, age and sex is comparable between FNB group and FIB group. Time to achieve VAS score below 4. It is 3.8 in FNB group, whereas it is 4.5 in FIB group, of which p-value is significant. Trend of VAS score. At baseline 1 minute, 2 minutes, 3 minutes, 4 minutes, 5 minutes, 10 minutes, and 15 minutes after the block. VAS score at 3, 4, and 5 minutes are respectively 4.4, 3.3, 2.2 in FNB group, whereas it is 5.1, 4.1, 2.9 in FIB group. P-values are significant for the above 3 parameters. Patient comfort score: 0, uncomfortable; 1, moderate discomfort, difficult to sit; 2, mild discomfort, able to sit; 3, comfortable, mild pain; 4 is comfortable, no pain. 10 patients in group FNB and 2 patients in group FIB have patient comfort score less than or equal to 2. 10 patients in group FNB and 18 patients in group FIB have patient comfort score more than 2. P-values are significant for the above 2 parameters. Block performance score: 3 parameters. Identifying anatomical structures. Unable to identify is 0. Able to identify structures with difficulty is 1. Identify structures easily is 2. Ease of passing needle to the target. Unable to pass through is 0. Able to pass through after difficulty is 1. Easily able to pass through is 2. Spread of drug in the space. No spread is 0. Some spread of drug noted is 1. Adequate drug spread is 2. 9 patients in FNB group and 3 patients in FIB group have block performance score less than or equal to 3. 11 patients in FNB group and 17 patients in FIB group have block performance score more than 3. P-values are significant for the above 2 parameters. Discussion. Our study demonstrates that the onset of femoral nerve block was earlier than that of facial block. A statistically significant difference was seen in the p-value of time to achieve VAS score below 4 between the 2 groups. A statistically significant difference was seen in the p-value of VAS score at 3, 4, and 5 minutes after the block. However, facial block scores over femoral nerve block in comfortness of patient during positioning for spinal and ease of performance of block. Statistically significant difference was seen in the patient comfort score and block performance score between the 2 groups. Conclusion: facial block is better than femoral nerve block for positioning of patients with femur fractures or spinal anesthesia. However, onset of action is faster femoral nerve block when compared to facial block. These are my references. Thank you.
Dr. Saminathan is also here with us.
Yeah. Dr. Saminathan, you have presented nicely. Over to Dr. Pratibha. Please.
Good morning, Swaminathan.
Good morning.
So, okay. So you have, if given options that you can give either of the block and you have ultrasound and all facilities, which block will you prefer?
Facial block.
Facial block. Why? Because the sitting position is better in patients are more comfortable in sitting position.
Yes, ma'am.
Okay. And if there is a time constraint?
What, ma'am?
If there is, I mean, if surgeons are sitting on your head and if there is some time constraint, then you prefer femoral nerve block.
It is shorter in femoral nerve block.
Okay. So don't you think that this is a very subjective assessment of scoring of patient comfort?
Yeah, patient comfort.
Who assess?
What, ma'am?
Who assess that table? You mentioned one table, and that's patient comfort.
The person who is not involved in the giving blocks, the other person assess that.
Oh, okay, that patient comfort. Okay, over to you, ma'am.
Okay, thank you very much. Thank you.
Now we are taking our previous participant, Ganesh Kanda, question answer session.
But Dr. Neeraj Gautam still no.
After this, we have
Okay.
Please, Dr. Ganesh Kanda.
Hello, good morning, everyone.
Good morning. Good morning, Dr. Ganesh. What was his
Your
subject?
study. Ma'am, my subject
What was your study?
Ma'am, my study was to compare the external facial measurements for choosing a proper size of OPA, oropharyngeal airway.
Yeah, yeah. So my question was, what were the cases
Ma'am, all the
where you have
yes, ma'am. All the ASA 1 and 2 patients we aged between 18 and 70 years of age who are undergoing elective surgery under general anesthesia, ma'am.
at what time exactly? At what time you have used this OPA? And
Ma'am,
what
after taking the patient into the OT, making the patient lie in supine position, then we will take OPA measurements, ma'am. All the 3 OPA measurements will be taken, and after induction, then one of it is selected randomly, and then the study is done using that airway, ma'am.
So why did you use OPA? And at exactly at what time of induction or you have chosen to put the OPA?
Ma'am, after induction and after complete muscle paralysis, ma'am. We have given Vecronium 1.1 mg per kg, and we have waited for 3 minutes. Then we, after confirming the complete muscle paralysis, then we have inserted the OPA, ma'am, and ventilated the patient using pressure control mode with the fixed pressure and respiratory rate. And we have seen for the adequacy of ventilation, and after confirming the
So
adequacy
your
of the
study was only to measure the length of the OPA, the size
No,
of the
ma'am.
OPA?
Ma'am, our study was to identify which facial measurement. We have taken 3 references, ma'am, for facial measurements with 3 guidelines, and we have compared these guidelines. Which of these guidelines is better to choose the OPA, ma'am, based on the adequacy of ventilation and fiber optic view.
Okay. Okay, over to Dr. Pratibha. If you have...
Thank you. How did you exactly measure the distance between epiglottis and the oropharyngeal airway by this fiber optic view?
When we
You mentioned 1.64 centimeter, right?
Yes, ma'am. Yes,
So
ma'am.
from how did you get that value?
Ma'am, after passing the fiber optic through the lumen of the airway, when we see the distal tip of the at the distal end of the OPA, when we see the tip of the fiber optic, ma'am, we pasted a tape above the flange of the OPA, ma'am. Above the flange on the fiber optic, we have placed a tape, and then we further passed it till the end of the till the tip of the epiglottis, and then we have placed one more tip, ma'am. After removing the fiber optic, we have measured the distance between these two.
Tape?
Yes, ma'am.
I'm not getting, I'm sorry. How did you measure the distance? I mean, tape, you have put the tape on the fiber optic.
Yes, ma'am. Over the fiber optic, ma'am. Over the fiber optic.
Fiber optic is a marker of distance. As a marker of distance, just the tip reaches the oropharyngeal airway. At that time, at that point, as a marker, is then when it reaches epiglottis, another marker.
On
So
the okay,
distance can
the
yes, ma'am. Yes, ma'am.
okay,
Yes, ma'am.
okay, fine. Outside the mouth, okay.
Yes, ma'am. Yes, ma'am.
Okay. Oh,
yes,
thank you.
Okay, ma'am. Thank you, ma'am.
We our participant Dr. Neeraj Gautam, so we cannot take his presentation.
Okay. So he is absent. It cannot be taken. Okay.
Play the video. We are having his
Yes, we can show
his presentation. Yes.
Okay. Please present Dr. Neeraj Gautam's video.
Hello, everyone. The title of my presentation is Comparative Evaluation of Visual Analog Scale and Pupillary Diameter for Post-Operative Pain as an Observational Study. The background of my study is pain is defined as an unpleasant sensory and emotional experience associated with actual or potential tissue damage or described in terms of such damage. The objective understanding of pain guides about the effectiveness of various post-operative pain management strategies, the measurement of pain by VAS as is dependent on the individual's cognitive and emotional ability. Pupillary dilation has been successfully used to measure pain in quantitative terms. The present study was conducted to study the correlation between visual analog scale and pupillary diameter for evaluation of post-operative pain. The objectives of my study are to study the correlation between visual analog scale and pupillary diameter for evaluation of post-operative. The methodology of my study is the study population. A total of 85 patients were evaluated for 18 months based on VAS and pupillometer. Study design was observational study. Visual analog scale was explained to patient. Pupillary diameter of both the eyes was recorded before the start of procedure using handheld portable infrared dynamic pupillometer, and post-operatively assessment for pain was done using VAS scale at 6 hours, 12 hours, 18 hours, 24 hours post-operative period. Pupillary diameter of both the eyes were done simultaneously at all the follow-up intervals. The inclusion criteria and the exclusion criteria of my study were patients scheduled to undergo lower abdominal surgical procedures under general anesthesia. Age were 18 to 65 years, ASA grade 1, 2, and 3. These were the inclusion criteria. Now the exclusion criteria are declined consent from patients, patients with epidural catheter in situ for post-operative pain, patients having iris, retina, or cornea-related disease, patients having any pre-operative pain treated with opioids, patients having psychiatric diseases, patient unable to understand VAS score. The results of my studies are mean VAS score at baseline 6 hours, 12 hours, 18 hours, 24 hours post-operative intervals were 0, 4.88 plus minus 0.88, 3.39 plus minus 0.86, 2.19 plus minus 0.66, 1.40 plus minus 0.49 respectively. At all the time intervals, mean change was significant statistically, which is seen as less value of 0.001. The mean change in average pupillary diameter was 0.59 plus minus 0.64, 0.44 plus minus 0.54, 0.22 plus minus 0.34, and 0.07 plus minus 0.22 mm respectively, showing a significant change from baseline. On overall evaluation, mean pupillary diameter showed a significant incremental trend with increasing VAS score. The value was 0.00. Conclusion: the findings of present current study showed that absolute pupillary diameter as compared to change in pupillary diameter were better correlated with VAS scores. Pupillary diameter showed a tendency to show enlargement with increasing VAS, thus showing that it could be objective measurement of pain severity rather than perception-based other scoring.
Okay.
Thank you.
Thank you. Actually, I was late, so my heartiest thanks to the organizing chairperson, Dr. Rashish Diwan sir, and scientific chairperson, Dr. Tarlika P. Doctor, for inviting me to this esteemed conference, Isacon 2021, as the chairperson. Thank you all. Thank you all the organizers. And I thank Dr. Pratibha also for being with me.
Thank you so much, ma'am. And thanks for the organizing committee for making me the part of this mega academic event. Thank you so much.
Thank you, Dr.
It was
Sarbari,
nicely
madam.
conducted.
Yeah, and thank you, Dr. Pratibha, madam, for chairing the session. Conclude the e-paper session. Thank you very much, madam. Our next session is on pediatric anesthesia. The chairpersons with us are Dr. Muhammad Abdul E.K., consultant anesthetist and pain specialist, KIMS Al-Sifa Hospital, Kerala. Dr. Kamal Anil Gandhi, associate professor. Yeah. And Dr. Srinivasanthi N. And we have with us live Dr. Pradnya Sawant, madam. Ma'am, you are there? Dr. Pradnya, madam, please unmute yourself. Hello, Dr. Pradnya Madam. I think we have lost connection with her. Dr. Pradnya Sawant Madam is from Mumbai. Her topic is on hypothermia in children, physiology, adverse effect, and prevention. She is the Chief of Department of Pediatric Anesthesia, Wadia Hospital for Children, Mumbai. She has worked as Fellow in Pediatric Anesthesia, RCH, Melbourne, Australia. She is founder and past president of Indian Association of Pediatric Anesthesiologists. She is the founder member of All India Difficult Airway Association. And she has been invited as a speaker at various state and national and international conferences. She has published Pediatric Anesthesia Quick Reference Guide, 3rd edition, and she has written many chapters in books. Welcome, Dr. Pradnya, madam.
Yes, am I audible?
Yes, madam. Now you are audible.
Okay, okay. Thanks for my kind introduction, and let me thank you, ISA committee, Dr. Rashesh Divan and Tarlika, and my all dear friends from Ahmedabad. They are quite near and dear to me. Actually, it should have been, I should have come there. You know, this is my like a second hometown after Mumbai, but because of the COVID, it was not possible, and we just missed meeting all friends. So, okay, so over to my lecture, and I'll share my screen.
Madam, we also request you to chair the session also. Thank you, ma'am.
Chair also.
Yes, ma'am.
Okay, okay. Okay. So, are my slides visible? Hello?
Yes, yes, madam. It is very much visible.
Okay, so shall I proceed? Okay. Okay. So good morning, everyone. And this is the first presentation of this session. And my topic is hypothermia in children, physiology, adverse effects, and prevention. Actually, this is a very important topic in pediatric anesthesia as well as in adult anesthesia. Because it causes a lot of adverse effect during anesthesia, and it can sometimes have a lethal effects, and that is why the all anesthesiologists, especially pediatric anesthesiologists, must know how to tackle these problems intra and the post operatively. Well, now the adaptation to the extremes of temperature you can see in the animal kingdom, like they can survive in a very ice cold and they can survive in a very hot temperature without having their all gadgets what human beings are. But that never happens with the human adaptation, because the humans are essentially tropical animal, and they cannot deal with even the mild cold. Okay, so the successful survival requires two simultaneous events for the human being. One is the generating the sufficient body heat by burning the appropriate. You have to consume a proper food so that the heat is maintained in the body, and preventing the loss of the heat by the suitable clothing and the shelter. Only these human beings can do this by wearing the clothing and going to the shelter. Otherwise, I think among the human beings, those who are able to move, okay, that I'll come to later on, okay, what happens. So this is for a protection. We do a lot of things. We can put on AC, or we can put on warm clothes, and that we can maintain our temperature in the. But then what happens? Hypothermia. What is a hypothermia? So the importance of the regulation was in the last century, it was diagnosed that it causes a lot of significant difference in the neonatal mortality, especially because with the different body temperature and the body in 1907. A lot of research he has done, and he has said that, okay, because the hypothermia, previously nobody knew, what is happening, why the neonates are, dying intraoperatively. So this was the major cause, and it is preventable actually. Okay, so the lack of professional alertness of anesthesia providers, sometimes we do not know why the child is not coming out of the anesthesia. So nowadays, a lot of papers have come out or say evidence-based regarding the consequences and the treatment of the perioperative hypothermia. A lot of investigations and a lot of measurements are being taken to prevent this. Okay. Now let us go for the physiology, like a thermoregulation. So I was searching to simplify the, to reflex, and this is, I find it very complicated, and I find it very boring also to tell you. So I have just simplified it, saying that, you have an afferent. I think for basic physiology, we have some afferent input so that something is happening to the sensitive to the skin. that whether it is very hot or whether it is afferent input, that sensations go to the hypothalamus, it is processed, and the efferent process, this is like a sensory and the motor, and this it is the center. Okay, so the body responds to the thermal deviation via the efferent mechanism that increases the metabolic heat production or alters the environmental heat loss. So how it is done? So whenever the temperature it increases the temperature, the muscles, sweat glands, and the muscles of the skin arteriolar wall, means basically vessels. Usually these things are in the actions, okay, not muscles. So muscle, what will happen? They reduce the activity, especially whenever there is an increase when in a hot season, where sweat glands. So you have a vasodilation, you start sweating. So similarly, whenever there is a less temperature, like in a winter season, same procedure, muscle gland and these sweat glands and the skin, the skin becomes dehydrated, sweat glands become shrunken in a cold weather, and the muscles start shivering, so that they generate the heat. This is how the temperature mechanism works. So basically these three things are over. So what happens in the basically is the physiology. So like especially like in hypothermia, whenever there is a cold exposure, the thermosensitive end organs mainly are the cutaneous. And so the blood temperature, then the lateral thalamus and the direct vasoconstrictor effect you have, and what affects, one is the involuntary muscle, which I told you, shivering. Endocrinology, the secretions are less. The autonomic nervous system comes into the actions. The extramedullary stimulation of the voluntary skeletal muscle, have a lot of heat conservation and adaptive behavioral response. You take positions, like especially in a winter, you close your body like in a fetal position, so that you conserve the heat. You don't want to expose your body to the larger surface area to the cold. So now how do you classify hypothermia? Hypothermia you classify as a normal temperature, is 37 degrees centigrade. So if it is less than, it is 35, between 30 to 35 to 30 to 35 degrees centigrade, it is called as a moderate, and less than 30 to 38 between, it is called a severe. So less than that 28 is a quite, you have a lethal effects, and that we will see. Okay. So the thermal balance is maintained in the body by the heat production and the heat loss. So heat production is by the metabolism, already I said, the glucose metabolism, so energy is produced or heat is produced. And the second mechanism is the shivering. So shivering, muscle movements are there, you start shivering and the body heat is generated. How the heat loss is there? Whenever the temperature, you have a conduction, convection, radiation, and evaporation, which I will tell you with the details. So now heat loss. So what happens, especially for the neonates, what happens the conduction, convection? So convection means it is depends on the surrounding airflow and the current. So if the airflow and the current is very low, so the body surface area starts cooling in. Evaporation is what? It is the water from the skin and respiratory tract. So that is the evaporation. That is also heat loss. Conduction is in contact with the body. So whatever the surface area comes in the contact with the body, so exchange of heat directly occurs. So that is the conduction. And radiation, if the heat starts radiating, because your body also starts surrounding to the structure. So these four mechanisms, basic mechanisms are there, and they all are in action continuously unless we don't realize them. Okay. So now the pattern of hypothermia, what happens under anesthesia? So this is a normal watch. I told you what these four mechanisms, but under anesthesia, what happens? Usually the core temperature is constricted, right? This is not on the periphery. The periphery maintains are quite warm, right? It is 37 degrees centigrade, and the skin is 28 to 32, and the periphery is 31 to 35. Okay. So what happens after giving the anesthesia? The vasodilatation occurs, and the core temperature starts expanding. Okay. So the most anesthesia are the vasodilators, the cool room temperature, that is AC, when you are doing the cold IV fluids and the cold irrigation of the fluids and the evaporation. So what happens? Vasodilatation, if you see the core temperatures, this thing starts dilating, start expanding, and then suddenly there is a heat loss. So it is involuntary heat loss. You cannot prevent it, whatever, and you cannot, you can prevent it, but you need to prevent it, because you must know this, the basic mechanisms, hypothermia. Okay. So now there are in two phases the transfer occur. One is the transfer from the body to the skin surface. So the core to the skin, So heat is transferred, that is a phase one, skin to the periphery, and from the heat to the environment. So there are the two phases. So these two phases actually you have to control it by which I am going to tell you later on. Okay. So now what are the systemic effects of the hypothermia? A lot of systemic effects are there. Like in a CVS, whenever there is a hypothermia, the child becomes a very bradycardic, hypotension, ventricular arrhythmias, and the temperature less than the 20. Usually they don't respond even into the shock or with defibrillation. It's quite a scary even though 28. Okay. In the respiratory system, you can have a respiratory arrest. The oxygen dissociation comes to the change is there. The oxygen peripheries start becoming very cold, and you cannot have a saturation on the monitor because the absolute periphery colds are there. Blood increase the blood viscosity and the platelet count, acid base balance, increase solubility of the blood gases and acidosis. So most of the drugs they stop metabolizing, and the drugs are there, the stores in the body in the blood like that. Decrease in the GFR, no urine output at 20 degrees centigrade. Endocrine, decrease adrenaline and noradrenaline, and the hyperglycemia are there. A prolonged metabolism of the all anesthetic drugs, this is very prime important. So whenever there is a hypothermia, the IV drugs will not function. Okay, any IV drugs, that will take very long time to act. Just remember while resuscitation. But you have got some benefits also, because that will protect the brain against the hypoxia and the ischemia. So continue the CPR. That is why it is always said, child who is a hypothermic or any patient, that continuous CPR should be given till they are warm. Okay, you should not leave the CPR. Now, main things which important things, it affects all the body, but basically the defibrillation is usually unsuccessful less than 30 degrees centigrade. Just remember, metabolic rate is very low. It decreases 6% per degree of the centigrade of the drop. Okay. Now what happens in the ECG? So there is a Osborne wave. What is that? That is correlate with the degree of hypoxia. So yes, it occurs the Osborne wave. Actually, we should be able to diagnosis. So which leads are more sensitive? The inferior and the lateral leads are more sensitive. Okay, it is pathognomonic to hypoxia. You have a lot of other diagnoses, but whenever the child is under anesthesia, you can see these type of waves are seen. Okay. Now the Swiss staging system is there, like ST1, ST2, ST3, ST4, and that causes the clinical symptom that depends on the classical tropical typical core temperature. So that also same thing they have mentioned, what to do in when what the temperature is and what you should be done. Okay. Now most of the time the neonates are affected quite high. Okay, immediately the affection, and why the neonates gets affected. So one is that they don't have much muscle mass, and there is a muscle mass and insulation of the fat is very less. It's the skin and directly sometimes the bone. Second thing is anatomically large head. So immediately with the skin, sometimes they are quite, the hairs are less. So that cover is lost. So the large body surface area, and sometimes most of the time they keep open. So this is directly the dissipation heat in the
Madam, please, Pradya madam, please unmute yourself. We are not able to hear you, madam. Unmute yourself.
Ma'am, please.
Okay. Okay.
Yes, madam. Now you are audible.
Okay. So neonatal consideration, then the immature thermoregulatory center, that is one of the basic mechanism, because they cannot compensate, whatever the happening in the surrounding. Now, it is a physiological absent shivering mechanism. The muscle mass is quite less, so it's a bigger problem in these children. So basically, all these factors that put the neonates in quite a high risk. Okay. Now in neonatal hypothermia, what basically happens? All this pulmonary vasoconstriction, accumulation of the lactic acid, anaerobic metabolism, they have a hypoxemia, and sometimes they have a left to right shunt, and they go in the hypoglycemia very fast. So that is why you have to be very careful in this type of children. Now there are some potential candidates, like you see this large head is there. Okay, these children are already they are compromised state in a central nervous system, huge oxidative. Hello.
Sorry to stop screen sharing, madam. Please.
Tell me.
Screen sharing is off. We cannot see your slides.
Okay.
From your Zoom, yeah. Start screen sharing. Green button will be there. Yes, ma'am. Now it is visible.
Okay, so previous slide, did you see? This slide you have seen. Okay. Hello.
Yes, madam.
Yeah.
Previous to that, madam.
This one.
Yes. This was the last. Yes, madam.
Yeah, this was the last. So basically they go in the severe hypoxemia and the hypoglycemia. The crux of this entire theme is the these two children, hypoglycemic and the hypothermic and hypoxemic. Basically, these two things that can occur. Now there are some potential candidates are like those who are with a large head. They are already compromised. Children with a very cerebral, so they become both hypothermic and less cerebral tissue. So the prolonged these children usually they don't come out of anesthesia well. Similarly, huge sacrococcygeal teratomas or encephalocele or exposed bowels like a gastroschisis or burns, because there is no skin insulation. So these patients can go in hypothermia very fast. So you have to be very careful with these patients. Okay. Now, other surgical factors, surgeons those who don't operate very occasionally, what they keep on pouring the solutions of betadine or something, or spirit, especially alcohol, and that pick a patient. So those usually the pediatric surgeons, they know very well that they don't have to soak the below, or if it is soaked, that child draw sheet is removed. Okay, the child should not be kept in a pool of spirit or solutions. Again, then abdominal and thoracic huge surgeries or newborns, very important. Prolonged exposure to the viscera, prolonged surgeries, abdominal surgery. They have to keep on intermittently, keep warm drapes or warm mops on that. Irrigation of the body cavities of the cold fluid. Child becomes very immediately becomes a hypothermic. Now, how do you prevent this? You prevent by the pre-op, intra-op, and the post-op management. You have some protocol. You can have by active warming and the passive warming. So what is the pre-operatively you should do? So whenever the neonate or major surgeries are there, you adjust the ambient OT temperature around the 24 before any patient arrives in the theater. Transport them in an incubator, heating lamp or servo. Keep them in a warm, keep them covered, and wrap the child. This is like a heating mattress is there. Everything is kept ready. Means once the child is inside, you should not be wasting the time at all to induce the child. Everything like drugs and everything should be noted. So that as soon as I said, that is a phase 1, between the score to temperature score to skin occurs within the 10 minutes. Okay. So the rest in the 10 minutes. So in the first 15 minutes only the child becomes a hypothermic. So you have to be very careful, keep everything ready, head cover, both these things. So you can cover with the plastic or warm gamges. Everything should be, things. Now, everything has their own consequences. Like the heating mattress, you see to it that the temperature is proper and it is not overheated, because the causes of the burns are quite high. Okay, that's a major complication. Any heating devices, you have to be careful not to be directly in contact with the patient. Again, I told you, don't soak the child unnecessarily. Properly clean and don't keep it in a child under wet. Drapes. Drapes, plastic. After that, you can see the plastic drapes are there. Only the exposed part. And intermittently, the surgeon should, the lot of adhesions are there. It takes quite a long time. Covering up the exposed bowels intermittently, irrigating the lot with the warm washing. And for us, the infusion of the warm IV fluid should be better. Now, post-operatively, what the extubation, after the extubation, keep them in a warm infrared heater. This is like this, give the proper oxygen because still they are in a hypothermic, and give the warm, this thing properly warm in these children in the recovery. So unless and until their parameters are good, you should not be sending. Otherwise, if you have a very good, NICU, directly you can shift the, NICU, and again, the children who are not getting extubated. Now what happens then? Sometimes the children are not, getting, they don't become apneic. Okay, they become cold. They are not awake. So you cannot send these children in the recovery. So what you need to do, rewarming. Actually, this rewarming, it should not be the post-operatively. This should be the ongoing process intraoperatively. But sometimes it happens that intraoperatively, when the lot of blood loss is there and you keep on pushing the blood and the fluid, so children become so what you do, you have to do external active external warming and active core warming. This is passive is already there. Passively you just keep a warm air, warm blower or blankets. But this is basically these two things will properly warm the babies. So force air blanket, external heat pads or radiant heat resources, hot packs, and the electrical blankets, which I told you last, these are. But be careful, don't become directly you should cover something then. Now IV fluid should be warm here between 40 to 42 degree. Actually 37 is quite sufficient, but here you require a higher deep temperature. So IV medications will not function if the temperature is below 30. So HMV filter you can use. If mean arterial pressure is around 60 and if it is not maintained, you have to start a dopamine to maintain the cardiac output. So here are the some gadgets. And nowadays you get a lot of good gadgets, to provide the inline. This is like a, put your IV lines inside and set the temperature, which is quite a good one. Okay. Now, temperature changes in the neuraxial anesthesia. Of course, yes, it happens because autonomic thermoregulation is impaired during the regional anesthesia, resulting intraoperative core temperature. So usually, actually, what happens when the temperature is lower in the regional anesthesia, the brain, it blocks the thermal input to block from the blocked region. So the thermal center is not sensitized properly. So the vasoconstriction and the shivering thresholds are also reduced by the adjuvant drugs. So there is always a change. So not that, on even spinal epidural, except peripheral like blocks and all, spinal and epidural, they do temperature, they drop temperature. So don't think that in a neuraxial anesthesia, there is no drop. Okay. Now monitoring of the temperature, you have a surface and you have a core temperature. Actually, the surface temperature for a small procedure, it is okay. But for the major procedures, you must have a core temperature because that is the most important one for us. Now, means in most of the procedures, nasopharyngeal, ideally the esophageal should be there. But if esophageal surgeries are, oral surgeries are there, either you can use a nasopharyngeal or the rectal. But sometimes what happens for the rectal stools or say nasopharyngeal mucus, the temperature doesn't give you properly. So you can intermittently take a skin temperature by, putting the skin probe, or say simple thermometer is also you can use. Okay. So these are the two convenient things. The tympanic and the bladder are inconvenient things. So you can have this continuous monitor or intermittent monitoring by, simple thermometer. So where you have to insert, you have to see to it that it logs inserts in a nasopharyngeal and properly in the esophageal. Otherwise, intermittent lacking, that will not give you, proper temperature. Okay. Now, equipments, what are you have a traditional mercury in the glass, that is a slow and the cumbersome, and you have a thermistor. You can have a, thermistor like a probes, like a continuous temperature monitor and the surface temperature. And these things are for the neonate and major surgery is a must. Without that, you should not be doing, major surgeries of the neonate. This I have already talked about the Osborne wave, what happens intraoperatively, and this is the classical Osborne. So when you see this starts wave, you see to it that that definitely the child is going into hypothermia if you don't have thermistor or temperature probes. Now, what you should do investigations. So post-operatively, you should do electrolytes and urea, because that allugalic renal failure can be there because of consequences of low cardiac output and rhabdomyolysis. Hyperkalemia may be severe. So you can see the hyperkalemic waves on the ECG or the T waves. A full blood count, you must do the glucose, especially in the neonate, coagulation factors, arterial blood gases for the acidosis. Well, thyroid function will not give you the proper. That will give you, if any hypothyroid or hyperthyroid changes are there. Okay. Now, post anesthesia shivering is another potential serious complication is there, because that increases the oxygen consumption. Okay, and this is quite deleterious in the already who is a compromised state of respiratory or cardiovascular or neonatal surgery. Okay, so this becomes a very problematic, especially in the neonates. So post-operative shivering, actually, even in adults, we treat it quite. What happens that increases intracranial pressure as well as intraocular pressure, and it aggravates the wound pain by severe incisions. So what is the treatment? Treatment is basically you warm them. Usually we warm with a surface or something like that. Drugs, what you should give is like a clonidine. That is, I think, quite best, but you cannot give it in the neonates. The tramadol, dexmedetomidine nowadays is a very good drug to reduce this post-operative shivering. And the Maxalf, whether in adult patients we can give, but definitely it is not very advisable in the small children. Okay, so in very small children, in the neonate, you need not give this thing. That is active warming, active rewarming is very much essential. Okay. Now, what are the complications? These are complications which I have said. These are basically they are extension of the physiology. Okay, like hypoglycemia, bleeding, DIC, acidosis, shock, respiratory. But most complications is the cardiac arrest and the death. Okay, that can happen if the child continuously drops the temperature. So you should not be reaching to this death. You should be at the first level only. You should be start taking measures when before the child comes from the into the theater. Okay, so now in the summary, I say that hypothermia is common occurrence in the unwarranted surgical surgical cases associated with the significant morbidity and the mortality. Okay, so actually we don't see, but a lot of complications occur because just this one thing which is not taken properly. Okay. Important part of it is monitoring system in the pediatric anesthesia, especially neonates. Maintenance of the pre-operative, perioperative normothermia is a prime important for the better outcome of the pediatric patients. A uniform implementation of the evidence-based guidelines can be expected to reduce the adverse outcome and improve the patient satisfaction. So because even the elder children also, when they feel very hypothermic, post-operatively, that's not a very good feeling, post-operatively. And children, they don't come immediately. Those children who are going to come repeatedly for the surgery, that's not a very good experience in the patients. So you have to see to it that the children are warm perioperatively, and their outcome will be always good, especially in the neonate. The mortality is very much, drastically, nearly 30% mortality is reduced in the neonate. I think thanks very much. This is a short but very important topic for me. Thank you very much.
Thank you, madam, for excellent presentation, Dharmya, and giving very useful tips for day-to-day practice. Our next speaker is Dr. Indu Sen, madam. Dr. Indu Sen, madam, is a professor of anesthesia and intensive care at PGIMR at Chandigarh, and she is a faculty since 2001, core faculty in pediatric anesthesia DM course and airway management and acute pain management. She has fellowship award in pediatric anesthesia, best presentation awards, ESPA Singapore. She has membership of 15 scientific societies. She is executive member of IAPA, Chandigarh City Branch, ISSP, Pedistars Simulation, IRC, BCLS, and all other reputed societies. She is instructor, and she has mentorship experience of 25 PG trainees. She has 25 international and 51 national publications. Welcome, madam. Over to you, Indu, madam.
A very good morning to all of you. I bring greetings from Chandigarh. This is the outline of my talk. We'll discuss about the definition, the different types of shock, how to recognize, and their perioperative management. Similarly, what are the indications for blood transfusion? What are the concerns, certain special scenarios, and what is new in this field? When a patient is in shock, it's not only that there's a reduced ability to meet the metabolic demands, but there is a failure in removing the metabolic products. So they start accumulating, and then there is the waste products, they cause more harm to the patient. Shock has been divided into different categories, but what is important to remember is that when a patient presents with one type of shock, it's not only the one type of presentation, they will have elements of other types also. For example, in septic shock, the patient will be hypovolemic also. There will be underlying cardiac disorders. Remember that kids are not miniature adults. There are anatomical, physiological, as well as the pharmacological differences. When we assess, we should follow line of sight approach and examine them thoroughly. There are certain patients, few patients, which give us a direct clue that, okay, this is going to be a critical scenario. But then certain elective procedures have they can be the complex surgeries and where the patients deteriorate intraoperatively, or in the post-operative period, extra vigilance is required. So we need to identify the different red flags which are there so that we are better prepared to manage these patients. And attempts have been made to identify the risk factors where the blood transfusion will be required. So how to recognize shock? There are certain clinical symptoms like cold extremities, rapid fatigue pulse, and increased capillary refill time. These are the good indicators of shock. Remember that hypotension is not a good indicator of shock, because by the time 25 to 35% of the blood loss has occurred, the blood pressure is maintained because kids have an ability to increase the systemic vascular resistance in response to hypovolemia. So once the blood pressure starts falling, this is an indication, this is a warning sign. Management of these patients demands for teamwork at all the stages of management. They need to be thoroughly prepared and then taken up for the surgical procedure. We need to know how the baby was behaving before being wheeled into the operation theater, what fluids have been given, whether any inotropes are being given, and whether it is a refractory shock, or whether the child was on any ECMO therapy or requires any such therapy. So we need to know the full details. Allowable blood loss should be calculated, which is we multiply estimated blood volume with the hematocrit initial minus hematocrit target divided by the hematocrit initial. So, but remember that this is the one trigger for blood transfusion. We need to have a good clinical judgment to find out whether the transfusion is required for a particular patient or not. For that, we need to do the meticulous monitoring in these patients. Besides the routine monitoring, the specialized monitoring like estimation of electrolytes and serial blood gas estimations, then in the surgery-specific procedures like evoked potentials, transcranial Doppler, or TEE may need to be done. Regarding the assessment of appropriateness of blood transfusion, even in this is a recent publication of 2021, it was found in this study that up to 40% the transfusion was inappropriate. And the mortality did not vary in the patients who received blood transfusion compared to those who did not receive it. So definitive guidelines need to be formed, and for last 2 decades, attempts have been made to make the different patient blood management programs, and they follow a multi-pronged approach to improve the patient outcome. Preoperative optimization followed by proper decisions are taken to transfuse blood so that the outcome is good. Similarly, in the intraoperative period, again, acute normovolumic hemodilution is followed, and then restrictive transfusion thresholds have been identified. Point of care testing plays a great role in the management of these patients for a better outcome. Similarly, if we look into the various pediatric textbooks, the guidelines are there for transfusion of the whole blood or the blood products. They have been changing over the period of years and according to the availability in a particular setup. Transfusion of blood cells for patients less than 4 months is different compared to those older than 4 months. Why? Because they are immature systems are there. And then again, the blood volumes are also different in these 2 age groups. Similarly, for platelets, it has been found that accurate transfusion value, the trigger is 50,000 to 1 lakh microliters of platelets. At least this much is required if you want our patient to undergo a major surgery. But there are variations, there are exceptions are there. Say a patient has to undergo splenectomy, a big spleen is there. We cannot expect the high platelet count in that patient, and this patient requires perioperative transfusion of platelets, despite the fact they may get platelets before surgery also. Judicious fluid therapy is an important component of perioperative management of complex surgeries. But I won't be going into the details of the type of the fluid which need to be administered, as well as the indications, because this topic was very well covered by Dr. Anila Malde in yesterday's pediatric session. Just remember that we need to give fluids for different therapies, like deficit need to be covered, maintenance, and then the replacement. For all this, we need a good intravenous access, and this becomes a challenging job, especially if patient has been hospitalized for a long period and multiple punctures has been done. But we do have aids available, and at many times in the OT scenario, under the OT lights and with magnified cameras, we are able to secure an IV access. And if you secure an IV access, remember to send a sample for analysis, recent sample for blood gas analysis. And capillary is a good method, but you should know from where to take the sample so that there is no necrotizing, no tissue damage occurs, or we don't do harm to the patient. If we fail in getting a peripheral intravenous access, intraosseous route can be chosen, and different size of needles are available for children. Remember that we should not be injuring the growth plate. For this very reason, the proximal humerus is not the chosen site for children less than 18 years of age. Similarly, for central venous access, we can use the external jugular, internal jugular, or femoral vein, or even the subclavian has been chosen, and ultrasound plays a great role in cannulation in very small babies. If this is not available, landmark techniques can be used, and even umbilical vein has been used for the resuscitation. And Surgical cut down sites are saphenous and the brachiocephalous vein. All these techniques to learn in small 1 kg, 1.5 kg baby who is already sick is difficult. So for learning purposes, various simulation workshops can be attended, but it is difficult that they are quite expensive and you cannot keep on the high fidelity models. Good realism is there. But then within our OT scenario, we can make our own models where the practice can be done. And not only the task management, but we can learn the team dynamics, we can learn the shared decision making so that we are better prepared in a critical scenario. Point of care testing is a good tool and it gives us time to time, it will give us an indication that there is something wrong with the patient, and immediately you do the intervention, some drug is given, the response can be seen, and accordingly the management can be continued. Perioperative monitoring has to be meticulous, and not only the invasive techniques, even the non-invasive, the newer modalities like MSIMO give us a very good indication about the fluid status of the patient. How much fluid? The different formulas have been followed, the famous Holiday-Segal formula, and then alternate formulas are available. But in the shock scenario, this is what we administer crystalloids in aliquots of 20 ml per kg. If the baby is if the patient is a neonate or a sick cardiac patient, we may have to choose 5 to 10 ml per kg aliquots, and then further fluid administration is done under monitoring. This is another formula, German formula, where rule of 10 is followed. Acute intraoperative hemorrhage is a dreadful complication, and we need to be remember that not only the overt but the covert bleeding can be there, which is hidden under the drapes. So we have to be vigilant. And these patients may require massive blood transfusion. The special guidelines are there to define the patients who require massive blood transfusion, like loss of more than 50% of the total blood volume in 3 hours or more total blood volume in 24 hours. And these are certain examples where the massive blood transfusion may be required. These are the complex surgical procedures. In these scenarios, we need to activate the critical bleeding protocol. And this includes calling for help and availability of various blood products and facility for the investigations at frequent time intervals. Regarding the administration of blood, we can give the whole blood, or the better we can give the components. Different components can be given. And the advantage of the component is that the single blood unit can be used for multiple patients. And we administer whatever is required by the patient. So this will restrict the transfusion, and as well as the risk associated to it. Either the pediatric aliquots can be used, or a simple monojet syringe can be used for the administration of blood in these patients. But when we use a syringe, we can withdraw the amount of blood which is required, but it is to be administered within 24 hours. In our institute, we do get different blood components, and the special screening is there, like immunohematology lab is there for testing for the newborns. In spite of all this, the blood transfusion is a lot of complications have been associated with the blood transfusion. And these are few of them. Hypocalcemia need to be managed, when we are transfusing more massive blood to the patient. Similarly, we have to be vigilant about hyperkalemia, hypothermia, and then transfusion associated various graft versus host disease or TRALI. If a reaction is suspected, it needs to be managed immediately, stop the transfusion and do the symptomatic management and inform the blood bank. And all these patients who are critically ill, they need to be subsequently assessed also because there will be secondary damage. So they need to be monitored in an ICU setup. And don't forget to keep a record, not only for the medical legal purposes, but for the discussion purpose also, and the subsequent management of the patient. Coming to certain special scenarios, neonates, it has been it was suggested that if we transfuse them before surgery, the outcome may be better, but it was found in recent studies also, and the children who received preoperative transfusion, prophylactic transfusion, the morbidity as well as the mortality was higher. Though there may be a limitation to this study that the children who were given blood might be more sick. But anyway, this was a propensity score matched analysis using a national database. So good clinical judgment is required for the transfusion of blood, especially when the hemoglobin is between 5 to 7. Less than 5, the guidelines are clear-cut that we do transfuse, but at the borderline stages, especially when shock symptoms are not there, we have to be vigilant. Burn is an acute trauma, and there are special formula are available for transfusing fluid to these patients. Resuscitation has to go hand in hand along with the assessment. And there are many causes attributed for anemia in these patients. Even in these patients, it was found that restrictive transfusion policy is better than the liberal management of the blood transfusion. And this is a consensus statement for transfusion algorithm of severely injured children who underwent who had severe injury, and both for hemodynamically stable as well as the unstable patients, the guidelines have been laid down. And even the authors have tried to formulate a massive transfusion protocol using a Broslow-based color-coded scale is available. It is said that the packed red blood cells 20 ml per kg, fresh frozen plasma 10 ml per kg, and 5 ml per kg of platelets. So the products should be given in this order: 1, 2, 3. For cardiac patients, different guidelines are available. And those who go on bypass, again, at different stages, what investigation should be done, how they should be managed, the special protocols are available. So we should have, can follow these protocols or have our institution specific protocols. So what is new in this field? The pathogen reduction and use of adjuvant treatments, such as fibrinogen concentrates. But what has been seen in the recent, whatever limited studies have been done, that the requirement increases when we use this kind of products. So to be done in this field. So what do we learn? Perioperative management of children in shock demands for a thorough planning, preoperative preparation, well-equipped setup, and a multidisciplinary approach. Practice guidelines as well as algorithms, they are the useful tools to better manage these critically ill patients, but we must keep ourselves updated and formulate area-specific protocols. However, in actual scenarios, this is the judgment as well as the vigilance of the attending team, which plays a great role. Blood should be used judiciously, give the right product time to the right patient for the right indications. Continuous surveillance of the existing setups and critical evaluation of the untoward outcomes should be done for future safety recommendations. Thank you very much.
Thank you, Madam, for a very insightful lecture about managing shock in pediatric patients and blood transfusion guidelines. Thank you, Madam. Our next speaker is Dr. Vrushali Ponde. She is director at Children's Anesthesia Services.
Have an
Mumbai.
interesting.
She is program head at WFSS Children Anesthesia Services ISA and Pediatric Regional Anesthesia Fellowship Mumbai. She is in Education Committee of WFSA Pediatric Anesthesia. She is lead ESPA Education and ex-secretary of Asian Society of Pediatric Anesthesiologists. She has done ORA and CAS Pediatric Regional Anesthesia 6 months fellowship, works as a regional anesthesiologist and pediatric anesthesiologist in various institutions of Mumbai. She is a sitar player and performs regularly as a student of Halim Academy of Sitar. She has 3 editions on illustrated manual of USG regional anesthesia in children, in adults and children, and has presented Indian perspectives on regional anesthesia in various countries. We welcome you, madam.
We have an interesting social fabric, you see. We take normality for granted. Superb in everything. Superb in academics, superb in sports, and if it is a girl, we want her to be an epitome of femininity, a career woman. We want everything absolutely spick and span. With a social fabric which takes normality as absolute norm, we do come across, of course, physically deformed children. And when they are presented to us for anesthesia, there are certain challenges which we need to overcome. Well, when people ask, what do you do when we have physical abnormalities or mental abnormalities for that matter, the answer is simply whatever it takes to do a best, or rather a safe and an efficacious regional anesthetic technique. So the agenda for spine and trunk anomalies, and see what we do with them: upper extremities, the lower extremities, the head and the necks, and then we have physical deformities along with mental disabilities, and we are going to dwell a little on the pain management and the postoperative aspect of them. Well, children come in different sizes and shape. They could be even 700 grammars, they could be huge, such as 110, or they could be deformed, as I just said. So let's come to a foot surgery for a difficult spine. If it is a unilateral surgery, of course, we can go to the sciatics and the femorals. But if the surgery requires a central neuroaxial block, then it can be a challenge. One could depend upon the MRI if it is possible. One could depend upon an X-ray and gauge which spine is actually amenable for intervention. Or if we have an ultrasound, then one could really pick up the most available space, and not only that, but the direction which is most likely to aid you to get into the spinal or the epidural space. And we are going to dwell in this particular aspect for a little bit time. Let's get into the absolute crux of this issue, which is as follows. We need to understand the spine as such completely to understand what it can be used as. So the spinal architecture, marvelous as it is as follows. Of course, you see the transverse process when you come from the lateral towards the medial. So these are the transverse processes, and these are the facets. These are the spines. In between are here the laminas. So these are the laminas. So once we have laminae here, you can actually, in between the two laminae, you see the space through which the ultrasound is going to travel inside and show you the posterior dural complex, the intrathecal space, and the anterior dural complex. So let's see what probe position shall actually just said. So these are the transverse processes, these are the facets, and I'm going to show you the laminas now. And in between the two laminas, the space, and these are the, yes, this is how the probe shall be kept. We see the transverse process, we see the facet. Now the probe tilts inside, actually tilts inside. The ultrasound beam is taken inside this way, in between the two laminas, and we get a parasagittal interlaminar view as such. And let's decipher the scan now. So this is the posterior and this is the anterior. You can see that this is a curvilinear probe because our patient that we are discussing is an adolescent. So this is the posterior and this is the anterior. This is the skin subcutaneous tissue, the erector spinae muscles. You will see one lamina. You would see another lamina. In between the two laminas, we see a window. Come again here. Lamina, a shadow, lamina, a shadow, casted white. In between the two shadow is a window. So this is the window. We see the posterior dural complex, the anterior dural complex, and the vertebral body. And this is the intrathecal space. So if we need to really work real time, then we need this scan. If you want an aided block, then you can see a transverse scan at two spines or pick up the space in between the two spines, mark the space and go from there. It will also give you at what depth approximately you will hit the dura or the ligamentum flavum. I may just say here that it's very difficult to say where the dura ends and where the ligamentum flavum really ends and the space in between them. Slightly difficult to decipher in grown-ups. So the LOR, of course, works, and there are two experts that are required, one to give LOR, one to elicit the LOR and one to show the spine as such. So yes, I admit it is a tedious job, but it can very well be done. A real-time work is possible, but an aided work is something that really we all are more used to. So now coming to this particular placement, I'm going to share some more practical tips. Suppose if you really want to put in I have just removed the drapes so that it can be seen very well. So and the probe has to be prepared. I've just draped the probe totally. You can use even a camera cover. So for the transverse scan that I just mentioned, it is as follows. This is the soft tissue. Had it been a spine, which is in this particular scan, you won't see anything. So these are the spines and that's the laminae. That's it. You don't see anything. It's a total acoustic shadow. In between the two spines, when there are soft tissues, then what you see is the soft tissue shadow. And now you can see the entire intrathecal space or the spinal cord. And here you see the epidural space and the posterior dura. This is the intrathecal space and this is these are the transverse processes. However, as I told you, if it has to be a real-time guided job, then we need this kind of an ergonomics. Practical tip, you need betadine as a gel, or you could use any other, maybe even sterilium can be your gel. And once you hit the spine, or once you hit the dura, you need to wait because this is an anti-gravity work. You need to patiently wait for the CSF to come up. Say a scoliotic spine for a hip, and you might need a well-placed epidural, and that too with a central core disease, very much prone to malignant hypothermias. So thought process is something similar, but here we relied upon the C-arm and we relied upon the drug spread, a TIVA and an epidural, a well-placed epidural guided by the C-arm, and finally a Omnipac dye, which is injected to understand that the roots are actually getting draped and we are safe to go ahead. Do we really work with children with meningomyelocele and central neuroaxis if the indication is fitting? Otherwise, it's a relative contraindication. I must add in here for the bony architecture and how to pick it up through the probe again. So this is something that we don't work into, and remind yourself of the scan that I just showed some time back. You need to see the entire bony architecture and only then intervene, otherwise don't intervene at all. So we had done a series of cases like that, and we showed that yes, we can be safe in spite of this being a contraindication. Regionals are possible if we know how to decipher and if we know how to pick up that space safe. Well, coming to lumbar epidural in caudal directions, especially for this particular case, and I'm so glad that we don't see such cases not too frequently at all these days, and we can actually keep the bevel facing caudal and simply go in the lumbar region, the lowest possible lumbar region, and have that kind of caudal space. Again, here we had put in a dye to see that here is the epidural spread, and here is the spread along the roots, the dye taken up around the roots. If you come across discolorations, that's also an anomaly. If you come across a dimple, that's also an anomaly. Ask yourself if it's a tethered cord. Ask yourself if you can really give a caudal. And before you put in the needle here, if you can scan and demonstrate to yourself that there is nothing like a tethered cord. If there is a cyst, it's a benign cyst just occupying some subcutaneous area, and then you can still intervene, go ahead and intervene. Otherwise, my suggestion is don't. So all this is actually a food for thought when it comes to central neuroaxial blocks especially. Now coming to absent sacrums, yes, there are certain caudal regression syndromes where there is no sacrum at all, and the spine can get very, very challenging. So if there is again a fitting, let me repeat this word, fitting indication. Otherwise, if it's a unilateral work, if it's not a cavity invading abdomen work, or if it is bilateral foot or something like that, then yes, you need an epidural, and that is the time where you can think of all this. So this was one patient we had. This was another, again, bilateral uretary implant, extremely painful surgery. So we could go from the lumbar epidural and thread towards the caudal space. So we picked up a couple of cases and made a case series. Congenital hypoplastic lung. Here the anomaly is not skeletal. Here the anomaly is of lung. So well, we do combine a regional anesthesia with minimum general anesthesia as such, and get going along with it. Difficulty airway, what we do is we do what it takes to first secure the airway and then go ahead with a regional technique. Coming to congenital deformities in upper extremity, the commonest one in children is not the shoulder or not the humerus, but a radial club hand, an extremely common anomaly. Here, the anomaly is rather interesting if you really look deep into it. Interesting for us, but not interesting, of course, for the patient. And the radius is absent. So the musculature which would have arisen from the radius is absent. Since the musculature itself is deformed, the end motor response is that a muscle twitch, and hence the end motor response is abnormal. So you might get a flicker or a twitch, and of course it does work, mind you, because the tissues here are pretty supple and the local anesthetic does percolate. But the winner here is, of course, the ultrasound, because you actually see the skin, the subcutaneous tissue, if it is an infraclavicular block, the pectoralis major, minor, and the whole neurovascular bundle as such. So we realize that we are more efficacious. We are giving successful blocks, more successful blocks with ultrasound in this particular anomalies. And having said that, let me tell you, congenital anomalies don't come alone. Sometimes they come together. Suppose if you have a scoliotic spine and a radial club hand, it may still become a bit difficult for you to think of infraclavicular here. Of course, you can think of axillary. Why not? But axillary is not a good space to put catheters if you wish to keep catheters. But then come to intraclavicular at that time. Put in, and don't do this without an ultrasound. Otherwise, go for a simple axillary block and finish it off. So it's not just anomalies, it's probably the surgical area that is worked into, and then which block is the safest and yet will cover the surgical area should be the thought process when you pick up blocks. So this is how we get going with anomalies of upper extremity. We have put dyes and we have told ourselves whether we should go with intraclavicular catheters, whether they should be stimulating intraclavicular catheters. But then we realized that even if under a simply, yes, we can use the word simple here, because now it is pretty simple to use ultrasound, and we don't then need any other gadget when we want to keep continuous catheters. We've put, in fact, dyes, and we've seen that so this is how the Tuohy needle would work. We would put it near the lateral cord or the posterior cord, and the result is almost one and the same. Well, coming to interscalene blocks in these particular cases, such as Pringle shoulders, these cases have really made me think a lot. They do a clavicular osteotomy. The innervation is, of course, an interscalene block. Then they would come very extensively, work on the scapula, release all the muscles, pull the scapula down, and then fix it there. So there is an extensive back work out there. If you put a paravertebral catheter, it's going to come in their way. If you're going to put a thoracic, surgically congruent catheter, epidural, it is still going to come in their way, because they take a straight midline incision. So we need to go a little lower down and thread the catheter a little more higher up. So that is how you can, that is how you can actually think about which block would work the best in the given situation. Coming to lower extremity anomalies, arthrogryposis is one of the anomalies which were almost a googly to us, because yes, you can finish this case off in a caudal epidural, let me tell you, because the spine is most of the times going to be normal. Arthrogryposis here, it is something to do with the joint contractors due to the infections that have happened intrauterine. So the child doesn't grow well, the muscles don't grow well, the joints don't grow well, and hence the joints are stiff. So you won't see the ankle movement. If it is a PNS, you will not see the end motor responses, which is the flexion and the extension at the ankle, or the inversion or the eversion at the ankle joint, or the movement of the fingers again. It is not shown. But then has ultrasound solved the problem? No, because here the muscles themselves are fibrous. Transverse sections, they are going to look like nerves. So I was flummoxed whether this is the nerve, this is the nerve, this is the nerve. Again, we took a series of AGMC cases and we realized that it's very difficult to decipher the nerves here. So we went to the good old central neuroaxial blocks. So I tell you, there is no dictum here, in the sense, if the modern pediatric regional anesthesia is saying go as peripheral as you can and spare the central neuroaxis, there will come a case and they'll tell you that probably the better way here is to go to the central neuroaxis and spare the peripherals. So this is how the thought processes are. If you can see a nerve, then catheters can be very well placed around the nerves. Perineural catheters, very, very feasible. Wherever you see a nerve, you can put a catheter if, again, the indication is that fitting is what I would want to stress. And here is the catheter coming along the sciatic nerve through a Tuohy needle. This is what we are trying to share with you. Another abnormality, osteogenesis imperfecta. I wouldn't really want a peripheral nerve stimulator really stimulating the muscles which would then nag around the bones. So we would, if at all, we would really go for a central neuroaxial blocks with gentleness that you will understand once you deal with them, or a peripheral block so that you do not have to move these children more. So ultrasound guided femoral block would be the best, or a fascia iliaca compartment would be the best if you're dealing with the femur. Now coming to other congenital anomalies such as sensitivity to pain. So they can chew their lips up, it is that severe, or they fall, they bruise, and they really injure themselves a lot. So the challenge here is whether to put a regional anesthetic or regional analgesic blocks, not even very surgical dense blocks in these particular cases. This is more of a thinking aloud done in front of you, because I've not found my own answers here. But I guess there are certain other mediators of injuries other than pain, which are really curbed by regional blocks. And hence, I guess we should keep regional blocks even in these children. Well, cerebral palsies and regional anesthesia, what we realize is, yes, we can definitely go ahead, put regional anesthesia here. It gives a plethora of benefits. Of course, analgesia, number one. Number two, it is going to reduce the muscle spasms, which are very inherent to spastic CPs as such. Number three, it is going to help you fine-tune the postoperative analgesia in a way no other agent is going to help you. You can put continuous infusions. You can go to ropivacaines or bupivacaines. You can add fentanyls or clonidines. I am a little worried about clonidine here. If at all an epidural additive is added, we use fentanyl here. So if we have put a Baxter pump or an infusion pump, mostly a Baxter pump, we can add boluses, if at all required, when there is a clinically relevant and significant pain in spite of infusions. Having said this, it's very easy for us to say that yes, you put an infusion and this is going to take care of all the postoperative pain in say lower extremity work or a hip work in a cerebral palsy child. It's far from the truth because assessment of pain itself is very difficult in them. So what really helps us is the primary caretaker who understands. In fact, there is a good parental pain score where actually we ask them to just tell us whether they grown more, especially in the non-communicative spastic cerebral palsy, whether they grown more, or they're clinging more, they're eating well, they're sleeping well, their expressions are similar, and anything more than 6 is pain. So what according to me is very important is understand the anomaly and see what that anomaly is actually affecting your block with. So is it the motor response that is going to be a problem? Is it the trajectory of the needle that is going to be a problem? Are you not able to find out what should be a puncture point? So understand what the difficulty is. Then choose the block which you're most used to and it is most relevant to the surgical technique as such. Then choose your modality as per your availability and as per what is available or as per your expertise. And then have your anesthesia plan in accordance to what regional block you have chosen. So not that I have answered all the questions to my own self for giving this topic to me. It was a great topic to speak on, and I hope I have given the due respect to this.
Thank you, madam, for giving excellent overview of less practiced regional anesthesia in pediatrics. Thanks a lot. Our next speaker is Dr. Avula Murlidhar. He is a professor at Nilofer Hospital.
Rahul Murlidhar from Hyderabad.
Yes, sir. Welcome you, sir. Dr. Murlidhar is at Nilofer Hospital, Osmania Medical College, Hyderabad. He has 14 years of exclusive pediatric anesthesia experience, and he is a trainer at WFSA Safe Pediatric Anesthesia, and he is a PPLS trainer at ASPA and regular faculty in pediatric anesthesia conferences, workshops, CME and webinars in India. He has many awards to his account, and he is honorary pediatric anesthesia fellowship by Indian Association of Pediatric Anesthesia, and he has 7 original pediatric anesthesia research papers and publications and 9 pediatric anesthesia paper presentations in various conferences. Welcome you, sir, and over to you.
Rahul Murlidhar from Hyderabad. Today our topic is DAY in pediatrics. It's a technique of GA, uses combination of agents given exclusively by the IV route without the use of inhalation agents, including nitrous oxide. What are the indications for DAY in pediatric cases? The absolute indication is related to malignant hyperthermia and neuromuscular diseases and history of PONV, and there is a previous history of emergence delirium and acute and chronic reactive airways, fear of face mask, minimization of allergy risk. What are the surgical indications, especially shared airway procedures and airway surgeries? In surgeries where evoke potential monitoring is important, especially scoliotic surgery and neurosurgical procedures, middle ear surgeries, which produces PONV risk, example strabismus, and procedures at remote site areas, and short procedures like radiodiagnostic and cystoscopies and muscle biopsies, etc. What are the advantages of DAY in pediatrics? It reduces airway reactivity, laryngospasm, bronchospasm, improved ciliary function, bronchodilation, preserved hypoxic pulmonary vasoconstriction, reduced emergency delirium, reduced PONV, avoids expansion of gas cavities, used in neuromuscular disease, core myopathies, reliable delivery in airway procedures, and it is the optimal technique for neuroanesthesia. There is no interference with your titratable, easy of delivery by a pump, and maintenance of spontaneous ventilation for remote site anesthesia. No face mask over face, no vapor atmospheric pollution, and associated with reduced costs. What are the disadvantages of TIVA in pediatrics? Risk of bacterial contamination, need for venous access, pain on injection, it is associated with metabolic lactic acidosis. And it needs specialized equipments like infusion pumps. And there is potential of disconnection. And there is a risk of awareness, lack of EEG monitoring, and no current ability to monitor blood concentration. And caution in prolonged procedures or in obese patients due to long context-sensitive half-life propofol, it may lead to delayed recovery. And environmental effect of plastic waste and waste of propofol. Disposables may be costly, unmonitored sedation at home leads to death. What are the contraindications for TIVA? Propofol should be avoided in patients with mitochondrial disease because children with these disorders may be higher risk of developing propofol-related infusion syndrome. Should be avoided in those with medium chain acyl-CoA dehydrogenase deficiency thought to predispose patients to developing arrhythmias. Why TIVA is unpopular technique in pediatrics? Inhalational technique is well established, convenient. IV is not necessary for induction. It gives good muscle relaxation. Spontaneous ventilation is well maintained in inhalational technique. But TIVA is a new technique. Slow recovery with TIVA. IV is often covers by drapes in small children, and rarely it causes propofol-related infusion syndrome. Let's discuss about pharmacokinetics and pharmacodynamics. Calculation of the dose for a drug where PK disposition can be described using one compartment model with first order elimination can be readily calculated. Loading dose is equal to volume of distribution multiplied by maintenance dose is equal to clearance is multiplied by target concentration. The target concentration is the concentration desired at the effect site. The target concentration depends on the desired effect. This will differ with age, pathology, drug interactions, and stimulus. A remifentanil target of 2 to 3 microgram per liter is adequate for laparoscopy, 6 to 8 microgram for laparotomy, 10 to 12 for to ablate the stress response associated with cardiac surgery. A propofol concentration of 2 to 3 milligram per liter is an appropriate target for sedation, and 4 to 6 is adequate for anesthesia. The target effect set propofol concentration for both the loss and return of consciousness in children is 2 and 1.8 respectively, or similar to those reported in adults. The relation between drug concentration and the effect is commonly described by the Hill equation. What are the differences between adult and pediatric propofol pharmacokinetic parameters? Here, the apparent volume of distribution of propofol in the chain is twice that of the adult, and the clearance of propofol in younger children is twice that of the adult, and elimination is also much more rapid. Growth and development have an impact on drug pharmacokinetics and dynamics. The most enzyme systems responsible for metabolic clearance are immature at birth and mature within the first few years of life. Clearance through the renal system is also immature at birth. Clearance is a major determinant of drug infusion rate at steady state. Clearance of remifentanil per kilogram is highest in neonates and decreases with age to reach adult rates in adolescents. Loading dose is dependent on volume of distribution rather than clearance. Maintenance dose depends on clearance. And loading dose is influenced by both body composition and the drug characteristics. Children require larger loading dose of both propofol and remifentanil due to larger volume of distribution than healthy adults. What is context-sensitive half-time? The time taken for the drug concentration to reduce by half once an infusion is stopped. CSST is a specific drug. CSST for a specific drug will vary depending on the length of the infusion. In the case of propofol, the slope of context-sensitive half-life with time increases from adults to children to infants, full-term, and then preterm neonates, with preterm neonates having the greatest half-life of all age groups except remifentanil. Because remifentanil half-time becomes context-insensitive almost immediately after initiation of infusion because its elimination is rapid and complete. The capacity of red cell plasma, tissue esterase enzyme systems are enormous. For very lipid-soluble drugs such as fentanyl and propofol, V3 is very large. Distribution from V1 to V3 is associated with a very slow rate distribution from V3 to V1. Propofol CSST varies between approximately 3 minutes for shorter duration and 18 minutes for 12 hours duration. This is because elimination is quite rapid compared with the rate of redistribution. What are the ideal drugs? Important characteristics of an ideal drug is small volume of distribution, rapid metabolism, high clearance rate, short CSST, propofol, remfentanil, and all fentanyl are the examples. What are the different regimes? With propofol, we can add any OPI, and also we can add ketamine, and with ketamine, we can add benzoyl. So all above regimes, dexmedetomidine can be added to the above combinations. Let's discuss about the propofol, which is the principal drug for induction maintenance. Having short T of high clearance rate and small volume of distribution, it is 98%. But rarely we see propofol-related infusion syndrome in prolonged infusions, well documented in critically ill children. It causes severe metabolic acidosis, rhabdomyolysis, hyperkalemia, and cardiovascular collapse. Prolonged fasting increases the risk. Propofol should not exceed 4 mg per kg per hour for period greater than 48 hours. We should monitor at that stage APG, serum lactate, creatine kinase, electrolytes, and liver and kidney functions. The Burgada-like ECG pattern is a sign of cardiac electrical impact that predict the imminent cardiac death in propofol-related infusion syndrome. What are those ECG changes? Incomplete right bundle branch block at ST segment elevations in anterior precordial lead. This is the pattern of Burgada-like ECG pattern. It predicts imminent cardiac death. Propofol dose requirements in children younger than 3 years of age group. Here you see the infusion rates are expressed in milligrams per kilogram per hour. Less than 3 years, there is a difference. For short duration period of infusions, this infusion rate is much higher than the age of 3 years. But as the infusion duration increases, this infusion rate almost becomes equal in all age groups. What is propofol sparing effect? The concurrent administration of opioids in children has a significant propofol sparing effect while providing analgesia and stress control. Advantages of this synergism minimize concerns about PRAS during prolonged surgeries and sedations. Remifentanil provides the most effective propofol sparing effect. Alternative techniques of analgesia must well be established before the remifentanil is discontinued. Other opioids also effective. Let's discuss about remifentanil, which is an important drug. It is highly potent, ultra-fast-acting titratable opioid with very short CSST that has a unique synergistic effect with propofol. It is rapidly metabolized due to non-specific plasma and disease short T of 1.3 minutes, high clearance rate 2.5 liters per kg per hour, small V per kg. High clearance in younger children require higher infusion rates. Greater volume of distribution in children reduces peak concentration after a bolus dosing. As a rule of thumb, children less than 5 years or less than 20 kg will require up to twice the dose of remifentanil to produce the same clinical effect as older children and adults. Minto model is used for remifentanil. Concurrent co-administration of midazolam reduces the propofol dose for induction, and it is also having amnesic effect. The addition of midazolam to propofol infusion improves hemodynamic stability but delays the recovery when compared to propofol alone. Ketamine is popular in pediatric anesthesia due to its hypnotic and analgesic properties and its cardiac stability. Plasma concentration associated with anesthesia is approximately 3 microgram per ml, and return of concentration usually occurs at concentration less than 0.4 microgram per ml. It is very lipid soluble with rapid distribution, and the onset of anesthesia after IV ketamine approximately 30 seconds. The T of KO was estimated 11 seconds. Ketamine and propofol, ketofol in 1:1 ratio is being used in emergency departments with great success. The context says to half time of ketamine increases with the duration of infusion, resulting in recovery. See the adverse events when you will see propofol alone. These adverse events will reduced with the combination of ketofol. Let's discuss with dexmedetomidine. It's a selective alpha-2 receptor agonist. It causes sedation, anxiety, and analgesic effects without respiratory depression. This is important. And concerns about dexmedetomidine is bradycardia and hypertension. This article shows 1 to 4 years, dex doses of 1 and 2 microgram produces similar high rate satisfactory sedation. In children 5 to 8 years, 2 microgram per kg having the satisfactory sedation. In this meta-analysis, low-dose dexmedetomidine demonstrated better hemodynamic stability with shorter recovery time than high-dose dexmedetomidine. What are the potential problems with drug delivery from intravenous anesthesia pumps. IV cannula may disconnection of infusion tubing from the pump power failure, occlusion of IV cannula, occlusion of alarm because of small cannula, long infusion tubing, backtracking of propofol into the intravenous fluid infusion, drug disparity between settings, and wrong drug programmed into the pump. These are all the complications we'll see in this system. Parameter sets are commonly termed as models named after the author who reported them. This parameter estimates are different for each parameter set. Covariate influences that contribute to variability to the parameters such as the severity of illness, weight, or age. Manual infusion regimens for children. For example, if you take remifentanil, loading dose will be 0.5 microgram per kg per minute for 3 minutes. Maintenance dose is 0.25 microgram per kg per minute, that is half of the loading dose. This produces blood concentrations of 6 to 9 nanogram per ml. So what is smart pump? Smart pump or target control infusion are example of sophisticated delivery system that may be directed at either plasma or effect set concentration. Computerized pumps are considerable advance over earlier manual techniques for children that targeted only the plasma concentration of the drug. This is the pump what we'll use. When a fixed infusion rate is started, the blood concentration will increase, but almost simultaneously the distribution of the drug to the fast compartment and elimination will begin. Remifentanil is an exception. It has extremely rapid esterase clearance, and elimination of this drug is far greater than the redistribution from the central compartment. 3-compartment model with an additional compartment is used to describe the concentration in the effect compartment. This 3-compartment here see that V1 is the central compartment which includes the blood, V2 is the peripheral compartment with well-perfused organs and tissues. This is the fast compartment. V3 is the peripheral compartment, more poorly perfused tissues such as fat. Here the drug inside central, it goes rapidly to V2 and slowly to V3, and same rate distribution also occurs in the same way. A loading dose can start to fill the central compartment and ideally should attempt to create an effect site concentration at a specific drug concentration without overshoot. The rate of infusion should decrease in a stepwise manner to maintain a constant effect site concentration until a steady state is reached. The drug delivered into the central compartment continuously describes the peripheral compartments while it is also continuously eliminated. Here, the context-sensitive half time of the propofol also differs depending on the model. The Gilco model uses age-appropriate QO values. This results in the shortest predicted CSST for all infusion durations. This has a clinical importance as it predicts shorter recovery time for a given target concentration. Depth of anesthesia monitoring is important mainly by EEG, BIS, entropy, and spectral edge frequency. Clinical sense rather than processed EEG are currently required for depth anesthesia assessment in infants and neonates. The future ability for point of care propofol assay using either breath or plasma may be useful to reduce awareness complication. Let's go for clinical examples. Spontaneously breathing diagnostic process for radiological investigation. Propofol is enough for these procedures. Slow titrated IV injection with propofol to 3 mg per kg with lidocaine, aiming to maintain spontaneous ventilation, well maintained rate target of 4 to 6 microgram per ml in the absence of opioids. Pressure supported respirations is generally maintained on PSCO. In the absence of pressure supported ventilation, PSCO will increase. So for airway procedures, here inhalation or IVR injection, titrate bolus doses of propofol and remifentanil bolus 1 microgram per kg per minute is effective to dampen the airway reactivity. Minto model can be used. The margin between awake and apneic patient becomes narrower with age. The addition of 0.5 to 1 microgram per kg bolus of dexmedetomidine widens this margin. Topical anesthesia of the airway is vitally important in these procedures. Minimize oxygen flow levels based on SpO2 if laser is being used. Transcutaneous carbon dioxide monitoring is useful for this airway procedures. An accessory monitor of respiratory rates such as hand and abdominal ECG impedance can be very useful. The procedures with an electrical tube, especially ENT procedures. Intubation can be performed once desired CP or CE has been achieved after a bolus dose administered. After giving bolus dose, there may be chances of apnea. Most stimulating part of the procedure is often mouth gag placement. So at that time, propofol can be increased. The procedures with an LMA, especially orthopedic and peripheral surgical procedures. Here, children will maintain spontaneous respirations with the BIS score in the 40 to 60 range and a remifentanil infusion of 0.1 to 0.2 microgram per kg per minute, or an effect concentration of 3 microgram per ml/c in addition to normal inflammatory blocks. The remifentanil infusion or target concentration can also be reduced to assess the block function. Neonate having combined anesthesia with blocks. Here we have to concern that propofol may cause neuronal apoptosis and other degenerative changes in the developing brain of a human neonate that is GABA mediated. Dexmedetomidine, remifentanil may be alternative options. IV premedication glycopyrrolate, dexmedetomidine and remifentanil is the different regime used in neonates. Dexmedetomidine infusion 1 microgram per kg per hour can be started, titrated up down 50% of starting dose is needed. Remifentanil 0.1 microgram per kg per minute can be titrated, maximum increase 0.5 microgram per kg per minute. Airway management may require ETT or LMA to maintain the normocopnia in neonates. Cystoscopy like small procedures, diagnostic procedures, duration may be 5 to 30 minutes. Gas induction IV cannula, ketofol or propofol remifentanil can be used with supplemented with caudal block or local filtration. Top tips for total intravenous anesthesia. Distraction techniques and assistance facilitate to secure IV access, reliable IV access, visible infusions or concurrent fluid infusion and reflex valves are important. Infusion line dead space should be especially minimized in children. To avoid pain on induction with propofol, add lidocaine. Propofol alone will not provide good surgical conditions. Opioid and other adjuvants or good regional blockade will limit the required dose of propofol. Inhalation induction is not a contraindication to TIVA use. Processed EEG monitoring is a useful adjunct to aid titration of TIVA. Continue using clinical judgment and do not rely only on the infusion pump. We conclude with accessible technique with advantages for the children in terms of facilitation of specific surgical procedures, optimizing surgical conditions and reducing post-operative complications. May be advantageous to develop expertise as a part of pediatric anesthetic practice. Familiarity with the technique is required when inhalational agents are contraindicated. There is no single standard method for using TIVA in pediatrics. We hope this provides a starting point for the development of individual practice with the top tips and safety issues taken into account. Thank you. Thank you very much.
Thank you, sir, for explaining the principles and practice of TIVA and giving useful tips. Now the session is open for questions and discussions. So from audience, if anybody has question, can come forward. All the speakers are online.
Good morning, everybody. My question is for the Dr. Pragna Savan, madam. Madam, can you hear?
Yes, yes. Can you hear me?
Yeah.
Hello? Yeah.
During your lecture, we have seen that you are also using the tramadol. Have you ever encountered the hemodynamic changes with the tramadol?
No, tramadol, when you want to use, for this shivering mechanism, you use a 0.5 to 1 milligram. You don't have to use a 2 milligram. So if the child is quite stable, hemodynamically stable, with this tramadol, you don't find any hemodynamic changes. We don't give this tramadol in very small children, like less than 1 year old. There, the shivering mechanism is not there. So children who are above, definitely you can use a point. Initially you do 0.5, then you give 1 milligram. That suffices. Only thing problem with the tramadol is causes a lot of vomiting. The children keep on vomiting. So if you give some antiemetics before, or you can give an infusion of in 100 ml or 50 ml of normal saline, that gives a very good effect. But rather than tramadol, if you give a single dose of dexmedetomidine or clonidine, that also suffices. Then that the vomiting part is actually just taken care by not giving tramadol. So if you don't have, then you have to give a tramadol, because in most of the nursing home setups, you may not have a dexmedetomidine, or you don't want to open the, because that's quite a costly, just for a small procedure or to alleviate shivering. You don't want to use, these things. So both, whatever it is available, you can use it. But tramadol, actually, older children gives a very good effect. Actually, if you take a part of vomiting.
Yeah, in adults also it gives a very good instant result regarding the hypothermia severity.
Yes.
In adults also we have seen the hemodynamic changes in nausea, vomiting. Okay,
But
but in
you
low,
should be giving very fast. You don't want to give bolus. Bolus gives a lot of hemodynamic and vomiting.
I take the advantage of this bolus.
Yeah.
When the patient is taking out a hypotensive, we take the advantage.
Achha, okay. In children, we don't have such things.
So that's why I was asking. Okay,
yeah.
Thank you.
Dr. Anjuna Kundu madam is now with us. Madam, please unmute yourself. Good morning and welcome, madam. Madam, do you have your presentation, or you are just for discussion? Madam, you are not audible.
Okay. How about now? I have a presentation. Let me open it up.
Okay, madam. Thank you.
Sorry about that.
Now, madam will be presenting on mandatory monitoring for anesthesia. Over to you, madam.
Just a moment. Thank you so much for your patience. And while I also open this up, give me a moment and I should be back with you guys. All right. And I should be able to share my screen, right? There we go. Perfect.
Okay.
All right. You guys good? Perfect. Thank you so much for having me to this. It is the middle of the night over here. So if I am not myself, please forgive me for that. And also, I just had some miscommunication and I had no idea I was actually presenting this today, but I'm glad to be here. Thank you for having me as a guest. I will talk about mandatory monitoring for safe pediatric anesthesia with you all. I'm a pediatric anesthesiologist in practice for about 20 years. I'm in US. So a lot of my presentation and information comes from what is standard here. And of course, there are slight differences in different countries, different continents, what is considered as mandatory. However, I will recommend things that are based on the American Society of Anesthesiologists recommendations. And basically what is really needed for safer anesthesia in general for pediatrics. I also just want to share that I've actually had the fortune of working across the globe as a global health volunteer. So I've had the opportunity to work in less, or I should say more impoverished countries like Africa, South America, and even in India. I've been fortunate to work there for the past 13 years. Just, of course, I trained there my first time around. So I do have a little bit of sense of what exists in these countries. So first of all, what are the elements that will make for a safer anesthesia? In general, we know over the decades that anesthetics have become much safer. That's for adults and pediatrics, but specifically for pediatrics, we all know that the margin of safety for pediatrics is narrower compared to adults. So monitoring plays a big role in how safe our anesthetics are. But there are other elements, as you can see as I list them. Basically, the safety of anesthesia depends on who is administering the anesthesia, what are their levels of skill, training, expertise, years in experience. Where are they located in general? What's available to them? What procedure is being performed also will determine what the degree of risk is involved, which in turn determines the safety of anesthesia. And then where physically within the institution is the anesthetic, is it administered? Even in whether you're in a developed nation or a developing nation, what's the location of the anesthetic? Is it in the operating room? Is it in a emergency room setting? Is it in the, for example, we also administer anesthesia in the ICU units. We administer in radiology suites where you may not have the same degree of built-in layers of safety that you have in a dedicated anesthesia or operating rooms. So those will depend. But ultimately, what it boils down to is that monitoring is what has added to the safety of anesthesia over the past decades. And that is dependent on a lot of the technological development. So with the advent of technology, we've been able to deliver safer anesthesia. However, I do want to put this out, which is very obvious statement, that no technology can replace the diligence that a skilled and vigilant anesthesiologist will be able to provide. So everything else is a great tool to add to your armamentarium. It's the added layers of safety. It makes it more effective, more efficient, and just narrows the risk range for you, or I should say, narrows the chances of risks occurring if you have great technology. So the other thing is the devices and the monitoring is just as good as your information around it and your ability to use them, as well as the appropriateness of what monitors, what sizes, what locations you're using. So those are some of the things that go without saying. And now I will jump into what really is needed for pediatric anesthesia. So those elements I wanted to put out there so that we know that we will absolutely consider those as in the background, but now specifically narrowing in, honing in, or zooming into what is required for pediatric anesthesia. Peds anesthesia, specifically, we know compared to adults, there are many elements in pediatrics that are different compared to adults. So it requires a special degree of skills and knowledge. And one of those skills and knowledge is knowing that compared to adults in pediatrics, the biggest, the most important organ or organ system to be monitored is the respiratory system. So with that in background, there are two main factors we have to consider. One is the patient's condition and one, the type of surgery. Those are the two big elements, besides the fact that it's pediatrics, which is different than the adults. So for pediatrics, monitoring the breathing is paramount because we know the precursor to a cardiac arrest in children or any other complication is really a respiratory insufficiency and respiratory arrest. So respiratory arrest occurs first, and then, it takes the cardiac status down, as opposed to adults where the cardiac events or misadventures in cardiovascular system are way more likely compared to adults. So with that in the background, let's jump into what are the different kinds of monitoring we need. I think I skipped a slide, so let me get back to it. So the minimal standard of monitoring for all pediatric surgeries are respiratory monitoring, heart or cardiac system monitoring. And then in addition, according to the ASA, temperature monitoring, or at least the availability or capability of monitoring the temperature, is a very standard requirement. And then I've added the precordial stethoscope because that becomes pretty paramount in less resourceful areas. And I feel like areas like South America and Africa, and even in some of the situations in India, I found myself relying very heavily on precordial stethoscope for pediatric anesthetics. So those, I have asterisks there because those aren't necessarily standard for, especially precordial stethoscope here. We don't use it as a standard on all surgeries, but there are certain like prone surgeries, we will end up using that more commonly, or some of the more involved major surgeries. But I know in areas like Africa and India and South America, precordial stethoscope becomes a really great tool. So for you, I would say add that too. So for respiratory monitoring, we want to consider pulse oximetry, capnography. Those are the two most important elements. And then, of course, in addition, if you can have the airway gases and things like that, those are nice to have additional things. And especially if you're doing mechanical ventilation, so you've got a ventilator, then that is really, really important, good to have. If you can monitor the end-tidal O2 delivery, the end-tidal or inspired and expired O2, as well nitrogen, as well as nitrous oxide, as well as your inhaled agent, whatever you might be using. For cardiac monitoring, it's the heart rate, EKG monitor, non-invasive blood pressure monitoring. So these are the minimal standard monitoring requirements that in every setting, whether you're in the operating room, whether you are in a ER setting, a PACU or PICU setting, not necessarily PACU, PICU setting, or which is the ICU setting, or any other out of anesthesia OR setting. These are some of the minimal requirements. These are also requirements for whether you're doing a general anesthesia or a regional anesthesia. So even for regionals, again, airway and the airway monitoring, which with the gases and stuff, would be more for general anesthesia and mechanical ventilation. But for capnogram and pulse oximetry, for spontaneous, as well as nasal cannula or augmented oxygen delivery, you will need those for sure. So one by one SpO2 monitoring or pulse oximeter monitoring. For children, we want to remember, I said appropriate sizing is important. So what we're most commonly are using basically the infrared spectrometry, right? So these are the different sizes of the probes. So appropriate probe is important because you have to be able to monitor that for the size of the children. So smaller the child, smaller these are the disposable ones that we use. You can also have the clip-on ones, but again, you want to make sure that the size is appropriate for the child. And the clip-ons usually are basically one size fits all. So they are for bigger patients for the most part. The blue line that you're seeing is the one that you're going to get the pulse oximeter reading. That is on to the right side of your screen. And that's basically, you want to have that beautiful rhythmic sort of rhythm and a tracing. You can have interference from cautery when they cauterize or patient is moving or something, you're using some instruments that especially for a small child that's rattling, that's shaking them, that can cause interference. So things like that will have to be taken into consideration. Another consideration especially for pulse oximetry, besides appropriate size and the fact that it is actually presented on the nail beds, there are some other things that will interfere. Nail polishes, especially darker color nail polishes, will interfere with that, as well as if you've got really cold hands or fingers. So circulation would be really important as well. So keep that in mind. So again, temperature monitoring could be very important in that case, that you know your patient is cold. So that may not be covering it, that may not be recording it as well. And the last thing is sometimes the lights in the operating room, the direct exposure to them can occasionally, depending upon the types of lights, can interfere as well. So if you cover the extremity, then it might be able to pick up better. So those are some of the things you want to make sure. Basically, you want a nice rhythmic recording that, and then whatever the number is will give you a more accurate setting. Capnography, again, for us, we use it for nasal cannula as well as intubated patients. So regional and general anesthesia. So you want to make sure that it is your sampling line is connected as close as to your endotracheal tube connector as well. And then for the nasal cannula, the more closer it is to the site of the cannula insertion, the better it will be. All right, and then EKG monitoring that we use can be three lead monitoring or 5 lead monitoring. The 3 lead monitoring is most common in pediatrics because the benefit of 5 lead monitoring is that it monitors at 5 different sites and it can pick up the ST elevation a little bit better. For majority of the cases in children, that's not a risk factor that we deal with. We don't see a lot of coronary artery disease and a lot of ST elevation in these children. Even when we use EKG monitoring for test dose, which again is not necessarily thought to be the ST elevation is not the most reliable thing for test dose of a regional anesthetic or local anesthetic. So really what we're looking at the morphology of the EKG monitoring. So beside these leads give us a really nice electrical activity. And basically it averages out the input from the positive and the negative electrodes and gives us a nice little tracing. And basically what we're looking at the morphology, the QRS complex. For children specifically, those are going to be the biggest things. It's the morphology of the EKG that's going to be much more reliable when you're doing the testing. The increase in heart rate as well as the ST elevation is not really a very reliable factor for pediatrics. So just keep that in mind. That's why a lot of us in pediatric regional anesthesia don't necessarily use epinephrine as a test dose. Instead, injecting the local slowly and while you're watching the EKG for change in morphology and the QT interval and the basically morphology of the T or the entire QRS complex. Those are going to be a much more reliable information for you to know whether you are intravascular or not. So keeping that in mind, so you want to know the rate and rhythm, and of course the ST elevation, which is not so common in pediatrics, but occasionally we do have children with a compromised coronary circulation. In that case, it might come in handy, but it's not going to be the most common thing we see in children. The things that we need to know, as I said, rate and rhythm. So I just want to quickly go over, or you can just read this yourself too, but it's important to know the ranges, normal ranges, because pediatrics is obviously preterm neonates to 18 years of age, right? So we've got this wide range, and therefore we have a wide range of vital signs that are normal for them. So their heart rates, for a preterm or neonate child, 140 to 160 may be normal, whereas in adults, obviously, it's not going to be the same. And similarly for respirations, a respiratory rate of 50 might be okay. And we all know that under general anesthesia with inhaled anesthetics, your rate increases, right? So you have shallower and more rapid breaths compared to perhaps when you've given opioids, when it's going to be more deeper and slower. So those are some of the things that, as long as you know the ranges, you'll know what you're looking for. And any about 20% change is what you want to just pay attention to, whether it's related to volume, whether it's related to the stimulation that's your patient being light and being more stimulus, seeing more stimulus, or pain. So those would be some of the things that you have to see. Other things is rise in temperature will also lead, obviously, so malignant hyperthermia early signs could be, in addition to, of course, CO2 monitoring, you will also have the heart rate changes as well. Then the non-invasive blood pressure monitoring is commonly used blood pressure monitoring we see. The two important things there are how big, like what is the size of the cuffs, the appropriate sizing of the cuffs, depending upon the age and the size of the child. So in general, excuse me, a third of the the portion of the extremity that you're placing it on is, you want to put it on the middle third, would give you the most accurate reading. Third to a half, anything more than about half a size will definitely underestimate. Anything too small will overestimate the blood pressure. Cuff locations may make a difference, even if the size is appropriate. Just something to keep in mind is that if you change the location of blood pressure, you were monitoring it on the arm earlier, and then you've had to start another IV or an art line, and you don't have good enough access to your arm, and you've changed it to leg instead. And changing from the cuff from the arm to a leg will actually reduce the blood pressure in children a little bit. So you're going to have less blood pressure, lower blood pressure in children if you change the side from arm to the leg, even if the size is appropriate of the cuff. Whereas in adults, it's the other way around. And that's partly due to because they have more compliant arteries, they're more resilient, and the elasticity of their arterial walls is better. So those are some of the things to keep in mind. The other thing that we'll probably talk about a little bit later also is that for the most part, the estimation of non-invasive, we've got great monitoring or great reliability of the non-invasive monitoring when you compare it to the arterial or invasive blood pressure monitoring. It correlates beautifully. It's very much in concert with it. So you get a really good correlation between the two. So it's very reliable is what I'm trying to get at. However, there can be instances where even though it's a better measure of the diastolic and the mean arterial pressure, systolic pressure sometimes can be slightly underestimated compared to the arterial blood pressure or the invasive blood pressure monitoring. Just keep that in mind. Additional monitoring that is appropriate and helpful for long or major surgeries or specific surgeries, but not necessarily the minimal mandatory monitoring. But these are good, for additional surgeries are, of course, the invasive blood pressure monitoring. So big extensive surgery, sick patients, major surgeries, cardiac surgery, neurosurgery, or where you need to draw repeated blood samples. It's good to have that invasive blood pressure monitoring, which is slightly more reliable, slightly more accurate, as long as you keep the transducer and you zero the art line. Central venous pressure monitoring, great for volume status, but obviously, cardiac function, as well as a great tool to help with cardiac output as well, especially when we float in a Swan-Ganz catheter or PA catheter or something like that. That's the ultimate or most important way, most reliable way is the thermodilution of cardiac output monitoring. And we don't have any other invasive monitor as reliable as actually floating a catheter and doing that. but those are some of you'll only require those specifically in cardiac surgeries, sometimes in some big neurosurgeries as well. And we talked about if we have to monitor their arterial blood gases, it's good to have that invasive blood pressure monitor, and you can draw blood gases. Long surgeries, that's really helpful. It can, and when it's not just blood gases that we're monitoring, we can do the hematocrit and their electrolyte status as well. If you're doing massive transfusion, big blood loss surgeries, these will also be good monitorings to have as well. We already talked about the airway gases a little bit. Again, it's not necessarily standard, but it's really good to have in lung surgery, major surgeries, and mechanical ventilation. And of course, when you have mechanical ventilation, you want to know that you are able to monitor the peak airway pressures as well as the plateau pressures, and even and that will help you monitor. So we do see the end tidal curves, and those can also tell you about the airway resistance a little bit better, whether it's related to their lung disease, volume overload, or any other mechanical obstruction in the airway delivery. So those are some of the additional things we want to have. These are some images of where to do. So you can do a jugular or subclavian line. You can do, there's an arterial line that's inserted there. There's a central venous line you can insert as well. Procedure-specific monitorings. If you're using muscle relaxants, which I know in India and Africa, and in South America, I tend to use a lot more of neuromuscular agents compared to in the United States. We use them a lot less in pediatrics, unless it's a specific surgery that requires muscle relaxation. A lot of them, we don't use a lot of muscle relaxant. So in that case, use a peripheral nerve stimulator becomes unnecessary. But if we're using muscle relaxants, then you want to use that, especially the non-depolarizers and muscle relaxants. So then we talked about the cardiac output monitoring already. Then TEE, if you're specifically doing cardiac surgeries, you need specific training. The last time I did was in my fellowship about 20 years ago. So I don't do this routinely, but those of you who do cardiac anesthesia definitely do that. And now we know using TEE can be a really good non-invasive way of measuring the cardiac output as well. Motor evoked potentials are motor and somatosensory evoked potentials, EMG, and electroencephalography are the four things we use a lot in our spine surgeries. So especially for any spinal fusions for scoliosis surgeries. So those would be really important, more specific, surgery-specific monitoring. And those, again, we're not monitoring those. We typically have technicians that will, as an anesthesiologist, we need to know what agents interfere with that. So that's why we need to know what they're monitoring, especially if they're doing EMG monitoring or motor evoked potentials. We want to make sure that we have good communication about use of muscle relaxants, or we should avoid them when we can. All right, so this is what, there's usually a tech. This is what neuromonitoring looks like. I'm so glad I don't have to do it, and I'm glad these people are trained to do it, because I would have such a hard time trying to do that. However, what we do in terms of neuromonitoring, and again, nice to have, is a BIS or BIS monitor, or bispectral index monitoring, which is a non-invasive way of measuring the EEG. So it's just a little forehead probe that goes across. And that also for us, we specifically are monitoring that for depth of anesthesia. And it will tell you, whether your patient is, specifically when they're very sick, and you may tend to use lower inhaled agents or other agents, you want to make sure that their depth of anesthesia is appropriate, and BIS can be a really good monitor to help you with that. Now, we also have the nice to have, or like luxuries that we have, our continuous cerebral oximetry, which is basically it's a near infrared spectroscopy, or NIRS or NIRS. It's non-invasive. It can again go on the forehead, temporal, as well as temporal, even occipital and frontal areas. It can be done bedside, so ICU patients it can be really good for, neuro ICU patients. And then it's the best and most reliable regional measure of tissue perfusion oxygenation. So it's not only just good to measure the cerebral ischemia or any changes in cerebral perfusion or oxygenation, but it is also good even for peripheral monitoring. For example, as I'm a pediatric pain specialist, so I deal with a lot of CRPS patients, complex regional pain syndrome patients. So I've used some of it to actually monitor that, just their peripheral limb perfusion and oxygenation perfusion ratio. And especially if you're doing a sympathetic block, that can be a really good idea as well. So you can also use it to measure the efficacy of your stellate ganglion block, for example. So those are some of the things you can use. Another non-invasive, again, these are not things that we have routinely. These aren't things even studied very well in pediatrics. BIS is, NIRS now has been, but even a lot of this is information that we're using from adults. And about what we're looking for again here is about a 20% change in, so it's good to have a baseline and then you're looking for the change. The transcutaneous CO2 monitoring is another one on the horizon. It is a complement to your capnography, and if you have the invasive ABG or VBG monitoring, but it's not a replacement, but it's good to have when you don't have those things available, or if you want new toys to work with. For some reason, my slide isn't advancing. Let's see. There we go. So with that, I just want to summarize things that we need to keep in mind is, of course, safety for us as anesthesiologists is paramount. That's why we use monitoring as our extended eyes and ears. Really, they're not a replacement for who we are, how vigilant we are. The minimal standard monitoring should always be used, whether you are in operating room or in peripheral sites. So those, especially for the cardiac and the respiratory and the cardiac monitoring, those two are very, very important. Temperature is good to have, that you should be able to monitor those, because otherwise they'll interfere with our cardiac and CO2 monitoring as well. In general, an ideal monitoring should be easy to set up. It should be continuous. It should be non-invasive. It should be accurate. It should be reproducible. It should be real time, and basically a surrogate to tell us early evidence of end organ disease or end organ dysfunction. So those are some of the things. Keep those in mind. Whatever helps you identify those early and easily, that's what your standard monitoring should be. With that, thank you so much for having me as a speaker. It's been a pleasure to be here. Thank you. And
thank you, madam, for your very insightful lecture on monitoring in pediatric anesthesia. Sorry for the inconvenience, madam, and thank you for waking up late.
No worries.
Thanks for sparing your time. Thank you.
It's a pleasure.
Any questions in the audience? No questions? So we'll end our pre-lunch session here. Thank you, madam, and all the speakers. We'll gather here after lunch for the next session, after lunch at 2 p.m. Thank you.
Great. Thank you for having me. Enjoy your lunch.
Thank you. Thank you, madam. Thank you, sir. Thank you, madam, Indu, madam, and
आपका लेके आओ। मेरा नाम रणबीर है।
अभी हुआ Okay, so you can hear my volume and all. I'm going back.
Hello. Hello, is it Halsey?
Hello. Good afternoon, everyone. We are starting the post-lunch session. I invite the chairpersons. Dr. Abraham Cherian, HOD and Senior Consultant at Department of Anesthesiology and Critical Care, Med City, Kochi, Kerala. Dr. Trupti Shah, Madam, Associate Professor at Department of Anesthesiology, BJ Medical College.
Hello.
Hello. Dr. P. Saraswati Devi, Madam, Professor and Head of Anesthesiology at the Oxford Medical College Hospital and Research Center, Bangalore. Welcome you all. And I hand over the session to you, Madam and Sir.
Just a minute. I'm Dr. Saraswati here. Hello.
Yes, Madam.
Today I have that opioid availability panelist.
Okay.
2 to 3. Not in pediatric anesthesia.
Okay, Madam. Then you can switch to there.
Switch to, so Halsey only, no? Pediatric, opioid availability?
No, Madam. This is a pediatric anesthesia.
No. I am in opioid availability session. That is between.
There is no topic today. In Hall C, Madam, there is no opioid availability topic. All topics are related to pediatric anesthesia.
But you had put me as a chairperson there, but I am already as a panelist in opioid availability. Do you have the list? And they have sent me that today is between 2 and 3, Hall C, opioid availability.
Actually, Madam, I have the list and in that your name is not there.
But you had put my the photograph.
So there is some confusion. I think you need to be there in opioid availability session.
Yes. Which hall is it?
Let me see, Madam.
Just check, ma. Let me go to that session. Do you have that?
Good afternoon, all of you. Welcome to the pediatric session of Isacon 2021. We have 2 speakers today.
Excuse me, sir, 1 minute. Let me tell the Madam. It is in Hall F, Madam Saraswati Devi.
Okay, ma. Thank you. Thank you.
Okay, sir. Please continue.
Yeah. A hearty welcome to the pediatric session. We shall begin with the first topic for the pediatric session. Madam, you can start off.
Hello, Pragati Manda, madam. You
Hi,
can
ma'am.
start your lecture.
Good afternoon. Ma'am, the lecture audio has been sent already. I think they'll be playing that video.
Yes, people should start it. Huh? The lecture is about low flow anesthesia in pediatric practice.
Yes.
Computer people, technical people should start your video.
Very good morning, everyone. I am Dr. Pragati Nanda from Batra Hospital and Medical Research Center, New Delhi. I'm consultant there. And very warm regards to the esteemed faculty, respected panelists, and the dear audience. I'm very thankful to you all for giving me this opportunity to be a part of this gala academic event. So today I'll be talking on low flow anesthesia in pediatric patients. So low flow anesthesia in pediatric patients has been a challenge since long. The history goes back to 1850 when John Snow first described the closed circuit anesthesia with carbon dioxide absorption. It was in 1930 when Brainsworth described the circle breathing system and delivered closed circuit anesthesia. 1952 when Foles and co-worker, they first described the low flow and partial rebreathing anesthesia. So the definition of anesthesia and low flow are variously defined. It is basically the inhalational technique in which a circle system with absorbent is used with a fresh gas inflow of less than patient's alveolar minute volume, less than 1 or 1.5 liters per minute, or less than 0.5 to 2 liters per minute. So there was a lot of confusion. Okay, what is low flow anesthesia? Until we came to consensus, which was given by Baum and Etkin et al. From their hospital in Germany. They defined low flow anesthesia as the inhalational anesthetic technique via a rebreathing system in which rebreathing fraction at least amounts to 50%. That is, 50% of the exhaled gas volume is led back to the patient after carbon dioxide absorption in next inspiration. So using our modern anesthesia machines, this can be gained at a fresh gas flow rate between 1 to 2 liters per minute. So Baker's classified the flows related to anesthesia as a medium liters per minute, low flow, 500 milliliters to 1000 milliliters per minute, and then minimal flow, 250 mils to 500 mils per minute, and metabolic flow, which went down to as low as 250 ml per minute. So why we are running after low flow anesthesia? There are a lot of advantages and benefits of using low flow anesthesia. The first and foremost being the significant economic and ecological benefits. Ecologically, we all know it is very planet friendly. There's less oxy pollution, less air pollution, less amount of nitrous oxide and anesthesia gases are released in the environment. So ozone layer is not damaged. So regarding economic benefits, a recent study by Todd et al. In 2020, it was found that children were using low flow anesthesia. The bottles of sevoflurane used per month was lower by 20%. So this quality improvement initiative also concluded with at least 2 liters of fresh gas flow is a successful value-added enhancement to pediatric anesthesia practice. So in this study, Todd et al. Realized that using 2 liters of fresh gas flow with sevoflurane, which increases the safety margin in children, which gives us it. Okay? And still the economic benefits could be noticed to decrease up to 20% of the costs. Then intraoperative protective ventilation allows the reduction in incidence of post-operative pulmonary complications. Humidification and warming of respiratory gases happens, which usually our lower airways are accustomed to receive the air at the body temperature, that is 37 degrees centigrade, with a humidity absolute of 44 milligrams water per liter, or 100% of relative humidity is required. What happens when we put the endotracheal LMA, we directly bypass the nasal and all the upper respiratory passage, which is warming the gases and humidifying the gases. So that exposes the lower airway to cold and dry, non-acclimatized gas, which is definitely damaged. How it damages? The mucociliary clearance is impaired. Anesthesia. The reduced mucus transport and damage of respiratory epithelium can lead to more infections and atelectasis, to which children are already more prone. They have, they have certain changes in their lungs. We all know physiological and anatomical changes. Their ribs, their FRC is less. Their ribs are horizontal. They lack bucket handle movement. The respiration is mostly diaphragmatic. So we have very low margin of error in children. They desaturate very early. So we have to be cautious avoiding all these post-operative pulmonary complications. In a study, 39% of the damaged ciliated cells have been observed after 3 hours of ventilation with cold and dry gases. So that is what which happened. 39% of the ciliated cells could be damaged. So cold and dry respiratory gas is also considered responsible for increased release of inflammatory mediators. While humidified breathing gases, they reduce the release of inflammatory mediators like TNF-alpha, IL-6, IL-8, and thus reduction in the harming effects of inflammation. This becomes more important when the child is already sick or in shock or have exhausted. Children, it becomes an important factor. Then lastly, hemostasis of the body core temperature and fluid balance. This is more important in children as they have larger ratio of minute volume to the body surface area. So Branson et al. In their study, they demonstrated that loss of 0.75 degrees centigrade of body core temperature in children after 90 minutes from induction of anesthesia using non-acclimatized gas. So we should be using acclimatized gases at minimum of 2 liters per minute flow. So what is the principle behind low flow anesthesia? Excess of the minute volume provides readily predictable inspired gas concentrations and is unaffected by the agent uptake. This is clear. Now, as the carrier gas flow is reduced, low flow is ensues, rebreathing starts, the gas uptake by the patient increasingly affect the exhaled and hence the inspired gas mixture. So increasing deviation of the inspired gas mixture from that set at the rotameters means that these techniques are critically dependent upon the gas monitoring. We are not actually delivering what we are setting on the rotameters. So we have to be sure, like, okay, what is going inside the patient. In low flow systems where rebreathing is extensive, the higher inline vaporizer settings are usually necessary to maintain the desired inspiratory concentration. So I'd like to explain it a little later. So what are the basic requirements for low flow anesthesia? To deliver low flow anesthesia, you need to have a circle breathing system with carbon dioxide absorption, gas tight breathing system with leak of less than 150 mils per minute at 30 centimeters of water test pressures. Minimum components and connections should be there. Returning the exhaust sample gas back to the breathing system should be a facility. The continuous is mandatory. It's an obligatory mandatory monitoring in patients, especially children, when you are delivering low flow anesthesia. Flow meters are calibrated accurately to as low as 50 mils per minute. So this is how we need modern anesthesia machines, closed circuit system, soda line, proper monitoring, gas monitoring, oxygen analyzers, EtCO2, temperature, and we need to have a leak-free system from the patient's trachea to the machine and all the closed circuit. So this is how, this is the circuit. When the fresh gas flow is decreased, less fresh gas is going through the vaporizer and carrying these yellow vapors, saying sevoflurane, into the child. And the exhaled gas with CO2, which is here shown by this gray dots, the CO2 is exhaled, goes to the bag, APL valve, and to the soda line. In soda line, the CO2 is being absorbed, and all the other expired gases are being given again to the patient. So what happened initially, pediatricians were very reluctant to accept low flow, closed breathing circuit. Because of its so many hazards, the system appeared to be bulky. It had more resistance. It had more dead space. There were more chances of malfunctioning, disconnections, and the child had exerted breathing when they observed for spontaneous use. So regarding all those things, they were a little reluctant. So to enjoy the benefits of low flow anesthesia, the small closed circuit were designed for the pediatric patients. But later on, they realized that as the valve areas, inspiratory, expiratory valve areas were reduced, there was more of the resistance offered. So it was in 1980 when Smith and Makin's study came up. They realized that, okay, the adult system can be accepted for children. So they found that they decided that adult circle system can be accepted for pediatric patients with little modifications. What are those important modifications? We can switch that 22 mm breathing tubes to be replaced by 15 mm flexible lightweight plastic tubes. Smaller reservoir bags could be used, 800 mils to 1000 ml of volume. No leakage, absolute. If you're using a LME or an uncuffed tube, it should be well fitting. And if you're using a cuff tube, the cuff pressure could be, measured and decreased to 25 millimeters of mercury. And then ventilation, which is important. We cannot let neonates spontaneously breathe through this kind of system. So ventilation needs to be fully controlled in neonates and controlled or assisted in infants. So below 2 years of age, we need to be little cautious. Now, what is the minimal monitoring which is required? Minimal, I would say mandatory. It is monitoring to inspired oxygen concentration, EtCO2 and ideal carbon dioxide, airway pressures and minute volume, and anesthetic agent concentration in the circuit. What are you delivering? Apart from this, depth of anesthesia, temperature, these all things also needs to be monitored. But the most important being inspired concentration, inspired anesthesia agent concentrations, expired carbon dioxide. These all things are very, very important. A vigilant anesthetist is the most important monitoring here. So to recapitulate how we go about the low flow anesthesia, we have 3 phases, initial phase and then low flow phase and then recovery phase. In initial phase, we keep high flows for 5 to 15 minutes. The aims are to achieve alveolar concentration of anesthetic agent, which is sufficient for surgical anesthesia. Then we need to do denitrogenation. To fasten up this phase, we might increase the initial gas flows to 8 to 12 liters per minute using an inhalational anesthetic agent with low blood gas solubility and correspondingly low individual uptake can be done using an inhalational anesthetic with low blood gas solubility like sevoflurane or desflurane are compatible with low flow anesthesia. Stepwise reducing the fresh gas flow rate and inhalational agent. This is important. This is how we go about it. We have to do all the washing. We reduce the flow. We keep the flows high for initial 5 minutes. We'll keep the sevoflurane to 8% dial settings. We'll keep the fresh gas flow rate to around 6 liters per minute. And then some anesthetists decrease it after 5 minutes to 2 liters per minute, then 1 liter per minute after 10 minutes, correspondingly decreasing the dial settings. To decrease the dial settings, most commonly accepted thing is when expired concentration is 80% of the inspired concentration. FE-FI ratio comes to 0.8. That is the point when you can decrease your dial settings to 4 and then finally to 3 or 2. But definitely the dial settings needs to be higher on the low flow to maintain the depth of anesthesia. In low flow phase, whenever the lower fresh gas flow, greater the difference between the vaporizer setting and the inspired concentration of the agent. Time to reach desired concentration is prolonged. Oxygen and anesthetic agent monitoring becomes very essential during the low flow phase. There is a need to switch. There are situations when we need to switch back to the high flow anesthesia. Like if a rapid change in any component, the fresh gas flow should be increased. If the integrity of circuit is broken by any chance, we need to switch to high flows. It is recommended that high flows should be used for 1 to 2 minutes at least once in an hour to eliminate the gases accumulated like nitrogen, carbon monoxide. They need to be washed off. Then last phase is recovery phase. Some apply the charcoal filters at the end of expiratory limb, which absorbs all the volatile agent, and the recovery is fastened up by disconnecting and flushing the circuit with 100% oxygen. 100% oxygen facilitates the washout of anesthetic agent from the patient to the scavenging systems. So what are the pros? We are very happy about it. What are the benefits we are getting? Less wastage, less expense, safe, effective for the child, it's planet friendly, reducing OT pollution, heat and humidity conservation is being done, less danger of wear-off. So anesthetist is happy, the child is happy, institute is happy. So there are cons as well, which we need to be very much aware of, like accidental hypoxia can happen. Hypoventilation and hypercapnia can happen. We need to be very careful about what is the inspired oxygen concentration. 50% should be maintained in children. Hypoventilation and hypercapnia needs to be taken care of. There could be exhaustion of the absorbent. Soda lime might be exhausted, desiccated. Those things needs to be taken care of. In our institute, we have a constant practice of changing the soda lime on every Monday. Plus, whenever in between it's changed, it's labeled. The date must be mentioned. The color of soda lime should be one of the important considerations to check when we are using low flow. IM CO2 also we keep a watch on, like, okay, what is the inspired CO2 going? Then other under or overdosage of volatile anesthetic agents. Suppose you're giving a high flow or during low flow anesthesia, keeping a high dial setting, and suddenly you increase the flow. High concentration of anesthetic will be certainly killer for patient, may leading to hypertension also. So we need to be very careful about what we are giving. We have to understand the technique well. Then it requires intense monitoring and a vigilant anesthetist all the time. Inability to quickly concentration. So we need to switch to the high flows whenever we need a sudden change in the concentration. Then there's concerns about accumulation of toxic gases like carbon monoxide. Carbon monoxide is generated endogenously from breakdown of hemoglobin, or it can be from the reaction between the anesthetic agent and desiccated absorbent. So we need to be careful about because it accumulates in the circuit. Nasser et al. Found in their study conducted on 20 children with low flow anesthesia that increased exhaled as well as inhaled carbon monoxide along with carboxyhemoglobin in children less than 2 years of age. In their study, they were children till 7 years of age, but they realized that children less than 2 years of age, they accumulated carbon monoxide up to 14 parts per million. And corresponding raise in carboxyhemoglobin was also found, which has its own impact and causes tissue damages, which needs a little more further studies. But in sick children, it becomes really significant. So they found that exhaled and inspired carbon monoxide was higher. So they realized that switching to high flows for 1-2 minutes every 1 hour of low flow anesthesia does help. Or we should maintain the fresh gas flow roughly around the minute ventilation for some time, then it washes off the carbon monoxide. Then compound A accumulates if the sevoflurane is used with a fresh gas flow of less than 2 liters per minute. So 2 liters per minute with sevoflurane, low flow should be done. It is a safe practice. Due to inadequate denitrogenation or premature reduction of flows or fresh gas shortage, nitrogen also might accumulate. Then there are certain limitations of low flow anesthesia. It is not suitable for short-term anesthesia with face mask. Procedures with imperfectly tight airways cannot deliver. Equipment with gas leakage cannot be used for low flow, and inadequate monitoring. In absence of a proper monitoring, low flow anesthesia should not be delivered to children. Then there's specific consideration in pediatric patients. One is equipment. Since equipment is heavy, increased resistance, increased dead space, the anesthetist should be well aware of the technique and the skill, like when to increase the flows, how to decrease, change the circuit, change the tubing, smaller bag, minimum connections, and the weight of the equipment should be well taken care of. It should not be pulling on the tube. These all small considerations should be in mind. Then monitoring, standard monitoring, inspired oxygen, EtCO2, minimum alveolar concentration and temperature are a must. There should be skill, no margin of error in children, no harm is to be ensured. We have to be fully understanding the principle, technique, advantages and disadvantages of low flow anesthesia, and then deciding where to give, where not to. Longer the duration of anesthesia, more the accumulation of toxic gases. So intermittent high flows to get rid of toxic gases. Recovery, meticulous washout of the gases should be done and ensure complete recovery of the child. So I would say my take-home message is that with increasing knowledge, technology, skill, and technique, low flow anesthesia has become feasible and is being increasingly incorporated in pediatric practice. To enjoy its benefits, we must stay vigilant and ensure complete safety of the child. Thank you. Thank you so much. The session is now open.
Thank you, Dr. Pragati, for the wonderful talk on low flow anesthesia. So,
Thank you so much.
Can we take questions right away, or
Yes, sir.
Yeah. We'll have just a quick 3 minutes for winding up this topic. Questions are invited from the floor.
Anyone from the audience to ask any questions?
Ma'am, is there any preferred agent in pediatric neonate age group for CO2 absorption?
Ma'am, they say this time sevoflurane is the best inhalational anesthetic agent.
No, I'm asking about the CO2 absorber.
Ma'am, litholime is the new great venture which has come. It has a lithium as a catalyst.
Good afternoon.
So it takes off all the worries of the anesthetist actually. It has three major benefits. One being decreased CO production. Even with the desiccated, even when it is totally dehydrated and desiccated, they have found in the studies that zero carbon monoxide production, no risk of compound A generation with the litholime. And thirdly, since we know the absorption of carbon dioxide is an exothermic reaction. So the temperature of those soda lime canister could go up to 75 degrees of centigrade. But with this, they found that even after use for 2 hours, the temperature mostly raised maximum to 60. They found it is less exothermic, so causes furthermore less damage. And on top of it, the cost is equal to soda lime. So litholime and Emsorb, but litholime I would say is the best one. The Todd et al. In their study, which just published in Pediatric Anesthesia 2020, they used litholime. So it became safe for pediatric patients, and they could even go lower to 1 liter flows. So initially it was like 2 liters of flow is must with sevoflurane because people had worries about these compound A and carbon monoxide. But now they are also going down to 1 liter of flow, even less than 1 liter. And I would like to add, they also did in their study one good thing, which they incorporated a software on their anesthesia machine screens, which they called as a wizard, low flow wizard, which used to tell anesthetists like, okay, you can go on the low flows, you can decrease your flows further. So they use that to decrease the cost so much. And they're very happy, very interesting study there.
One question from my side. This is regarding how low flow, how much of it, to what extent you can go as far as low flow is concerned with the present workstations we have. Are all the workstations we have safe, or do we need an advanced version of any particular workstation to practice the real ideal low flow anesthesia?
Sir, we can go to even less than 1 liters of flow. That thing has been modified. Initially, FDA had approved that, okay, with sevoflurane, 2 liters of flow is best. Sevo still, bears the crown of being the agent of choice for pediatric anesthesia. So, but with that and using litholime and modern anesthesia machines, we can go even down than 1 liter of the flow for the children. But of course, in maintenance phase, once we have achieved that level of uptake is gone and washing has been done, in maintenance phase, we can go down even less than 1 liter of flow. In yes, sir.
Sorry, please complete.
So they went till 0.8 to 0.6 liters of flow for pediatric patients. So they say if your system is tight enough, you are monitoring everything, then you can even go down.
But as you said, every 1 hour, it's better to go to a high flow.
Yes, sir. That's a safety measure, actually, I would say. After 1 liter, for a few minutes, 1 to 2 minutes, 3 liters of flow, 2 to 3 liters of flow, the gas washing is being done.
Thank you, Dr. Prithvi.
Great, ma'am.
Thank you, madam, for a wonderful and knowledgeable topic on pediatric anesthesia. Thank you, madam.
Thank you, ma'am.
Thank you, madam.
Thank you.
Our next speaker is Dr. Geeta Singaria. And our third chairperson has joined. So I welcome Dr. Ashish Sethi, Professor and Head at Netaji Subhash Chandra Bose Medical College, Jabalpur. Welcome, sir. Our next speaker is Dr. Geeta Singaria. She is a Senior Professor at SN Medical College, Jodhpur, Rajasthan. She has 17 years experience as a faculty at SN Medical College, Jodhpur. Her area of expertise are obstetric anesthesia, neuro anesthesia, and airway management. She was Honorary Secretary of Rajasthan Society of Anesthesiologists, She was external examiner at various universities and member of ethics committee. She has 28 publications to her account. Welcome, madam, and over to you, Geeta, madam.
Good afternoon, Geeta Singaria. I'm the senior professor at the Dr. S. N. Medical College, Jodhpur. First of all, thanks to organizing team to give me this opportunity. The topic for presentation is anesthesia in the Siamese twin. In this presentation, I am going to include about the conjoined twins, history, classification, diagnosis, anesthetic concern and management, prognosis and ethical consideration. Identical twins whose bodies are joined in a body and may share a vital organs are the conjoined twins. They are identical because they are the monozygotic and monochorionic, means who develop from a single placenta or from a single fertilized ovum. It is a rare form of the twin gestations. It is result due to the incomplete division of the zygote between the 13th and the 15th day after the fertilization. The two embryos will remain attached, causing the baby to grow in one another. Incidence of conjoined twins are from 1 in 50,000 to 1 in 1 lakh, and 3 times more commoner in the female. They are always the same sex and the race. Of these, about 40% were stillborn and the 60% live-born. They are the poor compatibility with the life, as the most of the infants die either in utero or soon after the birth. Survival for more than 24 hours is only 18%. About the history, the first case of the surgical separation of conjoined Gyphophagous twin was reported in 5 AD from the Constantinople, where the one twin died and the other survived for the 3 days. First successful separation of Gyphophagous twins was performed by the Manuel Konings in 1689. An anesthetic management for the separation of conjoined twins was first published, Hall et al. From the Milan in 1957. Why we call the conjoined twin as a Siamese twins? It is because the famed twins Chang and Bunker were born in Siams in the 1811. While they are the first conjoined twins whose medical history was documented, they are not the first conjoined twins. As they travel all over the world, later they are known as the Siamese twins. Usually we classify the conjoined twins on the basis of the point at which they are the joined. There are been 3 dozen separate types of the identical twins in last century. According to the site of connections, they are divided in ventral union and dorsal union. In ventral union include rostral, like cephalophagus, thoracophagus, omphalopagus, caudal, in ischiopagus, and lateral, and the paraphagus, diaphagus, and dicephalus. In dorsal union, it is the craniophagus, rachophagus, and the pyophagus. In the conjoined twins, the most common are the thoracophagus and the omphalopagus. The rare form of the conjoined twins are the parasitic twins, where the asymmetrical conjoined twins, one twin being small, less formed, and depend on the other. And fetus in fetus is a situation in which an imperfect fetus is contained completely within the body of the sibling. The diagnosis of the conjoined twins begin in the prenatal care with the sonography examination. They are usually identified the twins interconnection around 9 to 12 weeks. It confirms by the fusion of the limb, abdomen, chest, or liver. Detailed assessment can be done with the fetal MRI. Identify the share organ and the plan for the surgical approach. obstetrical intervention plan around 36 to 38 weeks, and avoid a complicated vaginal delivery or an emergency cesarean section. So, elective cesarean section. And many other investigations by which we can evaluate, like echocardiography, radiography, Doppler, contrast meal, MRI, micturating ureterography, endoscopy, cardiography. So about anesthetic management, it is a multidisciplinary team approach which involves the extensive medical work, involvement of the parents, psychological counseling of the parents. Parents should make a final informed decision on the separation and discussion with all the involved facilities and the supporting staff. And for this, before going to the surgery, the rehearsal of the planned surgical procedure should be done. And what is the anesthetic concern? In conjoined twins, there may be different physiology, like the cross circulations, distribution of the blood volume, and the organ sharing with their anesthetic implications. An estimation of the circulatory mixing is useful to calculate the drug doses and the fluid replacement during the surgery. Massive fluid shift and the loss of the blood and blood component and the rapid replacement. And meticulous planning for the organized management for the long hours of the anesthetic administration in 2 pediatric subjects simultaneously. Also, there may be the difficult vascular access. So with the guide of the ultrasound, we can achieve the IV line. And difficult airway, as in the pediatric group, and repositioning during the surgery and the relative facing of the twins. The nasotracheal intubation is usually out. The tracheal intubation is challenging for the anesthetist due to the atypical position, and awake intubation is recommended due to the usually presence of the difficult airway. And the thermoregulation, for thermoregulation, the draping of the twins, fluid and the blood were pre-warmed before the transfusion. Before going for any surgery, we assess the conjoined twins. First of all, the airway, access to the mouth and the larynx, as it is difficult. And closed spaces leave little room to insert the instrument or intubation in airway. In cardiovascular system, the anatomy of the heart and the major vascular anatomy is crucial and may be the cardiac failure. And venous access may be challenging because of the chronic hospital. These conjoined twins may have the disability, so a full neurological examination is required before surgery, and bowel bladder function must be documented. In thoracovagus twins, the gastric are the most common, and so need the head-up position and use of the anti-reflex medication. For assessment of the circulatory communications, mainly done with the routine evaluation by using many methods like the titanium 99M microcolloid human serum albumin, injection of the indigo caramine, and the examination of its excretion in the urine of the other twin. And testing can be done by administering the anticholinergic drugs such as the glycopyrrolate or the atropine to one twin and detecting the response in the other twins. During anesthetic management, we need everything 2 in the set of 2 because the two child are conjoined, as each infant has to be separately monitored throughout the process. So they are required to team of the anesthesiologist, to workstation, operating tables, monitors, sections, everything is double. Oxygen saturation, electrocardiogram, non-invasive EP, capnography, temperature, and also need the arterial blood pressures, central venous pressures, respiratory variables like respiratory rate, tidal volume, pulmonary airway pressure, and ABG needed. Urine output measurement can be done by urine output by urinary bladder to be catheterized, temperature monitoring by the nasopharyngeal temperature probe, and neuromuscular monitoring should be done. In pre-medication, atropine in neonatal twins always given because the vagal stimulation is likely to be occur with the laryngoscopy and the bronchoscopy. Or whenever we give the ketamine, the atropine should be given along with the ketamine. Sedation or anxiolysis has been used successfully in the twin over the 6 months. They are not recommended twins with less than 6 months. During choice of the induction agents depend on the airway, availability of the intravenous line, and the state of the health of the each infants. Generally, we take as a difficult airway. So spontaneous respiration with sevoflurane or the IV ketamine prefer for inductions. Twin with the cyanotic congenital heart disease or the complex anatomy, IV ketamine is preferred or it is a safe. Rapid sequence inductions often not possible in ventrally conjoined twins. During induction of anesthesia, induction agent and the muscle relaxant given to the one and this may result in the sedation, airway obstruction, hypoventilation or apnea in other twins. So, muscle relaxant must not be given until the airway assist is assured. Which type of the tube or the which route we are determined by the type of conjoint. During intraoperative period, analgesia, amnesia, and muscle relaxation should be provided with the control of airway regulation. Cardiovascular depression, difficult ventilation, unpredictable drug absorption, and the uncertain degree of this cross circulation, all the necessity regular adjustments in the anesthetic agent. Vasodilation in result in the blood diversion from other infant, causing significant drop in the blood pressure in other twins. And blood loss may be massive. Like in craniopagus, there is a bony attachment. So more the blood loss in separation of the cranium. Temperature monitoring should aim at the normothermia. In post-operative management, there immediate post-operative period, there are the many consequences like massive blood transfusion, prolonged surgery, and tight closure may be the problem. Alternation in the pre-operative anatomy and ongoing volume losses, cardiac instability, and the respiratory impairment. These are the problems commonly post-operative period. Monitoring for the bleeding, hypoxia, hypercarbia, hypertension, and hypothermia, and electrolyte imbalance is mandatory. And weaning, whenever we weaning the infant from the mechanical ventilation, attention must be paid for the external insufficiency, diaphragmatic dysfunction, and the mechanics of the breathing. The twin will need to be managed in an intensive care setting after the separation. So continue elective ventilation and fluid management in ICU. And due to relative lack of the skin cover after separation, the skin closure will be with the synthetic material and requires stepwise closure over the several weeks. Fluid shift, blood loss, and the leakage from the intra-abdominal tissue means the fluid management can be difficult and replacement blood component therapy is usually required. In prognosis, the immediate and the long-term survival of the conjoined twins is extremely variable. Because of the hidden long-term morbidity and mortality occur with unresolved aspiration after the thoracovagal separation, bronchopneumonia, arrhythmia, and embolic cerebrovascular pathology. Some survivor will be disabled and required lifelong follow-up care. This article published in Annal of Surgery in 1988, where the author reported their experience with 13 conjoined twins over the last 30 years. Author highlight that the operative who was operated on the neonatal period, but the 90% in those who are of age of more than 4 years. This was a case of parasitic male conjoined twin, which was successfully separated at our institute, Dr. Hassan Medical College, Jaipur. And one twin is survived. This is another case of thoracopagus twin, which was successfully separated at the AIMS Jaipur. And they even with proper planning and taking care of anticipated problem. It is difficult to manage the unanticipated problem during the surgery due to the complexity of anatomy, surgical field access, and sharing of the physiology. This was the same case which was operated and follow-up after 3 years of surgery. At the time of reporting this case, both the children were 4-year-old and the thriving well. Twin second has a ventral hernia, which was planned for repair. The surgeon concluded that the most important decisive parameters of successful separation is the extent of sharing of organ between the twins, but the role of motivated multidisciplinary team is also indispensable. This is the case report of Ila of the craniopagus twin after unsuccessful attempt at separation. The author reported that the separation of craniopagus twin is fraught with technical challenges. Surgical separation of twin is not always possible without significant risk of devastating consequences to one of both twins. India's first craniopagus, which was operated at AIMS Delhi on August to October 2017. Almost 2-year twins were cared at AIMS Delhi, but after return to home, one of the twins died because of the septicemia. The simulation-based patient-specific multidisciplinary team training in preparation for resuscitation and stabilization of conjoined twins. In this, the healthcare professionals trained together as an intact team in the actual delivery room environment to probe for the human and the system weakness prior to the unique delivery and optimize communication, teamwork, and other behavioral skill as they prepared for the simultaneous resuscitation of the two patients who are physically joined to one another. And the conjoined twin, the actual consideration are the early prenatal diagnosis and the tracking of the conjoined twins allow better management of the pregnancy, including counseling of the parents, continuation of the pregnancy, elective mode of delivery with postnatal surgery, and in a selective cases, termination of the pregnancy. The decision of the separation is extremely complicated one. Separation is extremely risky, and parents should make the final and informed decision on separation only after examining the physical, ethical, and psychological aspects of a possible separation. So at the end, the conjoined twin is one of the most fascinating human malformations. Treating conjoined twins can be challenges for the surgeon as well as the anesthesiologist. Most cases, the separation are extremely risky and life-threatening. Dedicated team of anesthesiologists and intensivists for each child with duplication of all monitoring and equipment in the one OP, and intraoperative and post-operative ICU care needed. Thank you.
So actually, I joined a little late, so I didn't get your name,
Welcome all.
Myself.
Dr.
Yeah.
Geeta Singaria?
Yeah, Dr. Geeta Singaria from the SN Medical College, Jodhpur.
Okay. Dr. Geeta, it was a wonderful presentation on a technically challenging case from anesthesia as well as surgical point of view. And, I'm sure, you must have enjoyed your, presentation. It was really great. And if anyone has to have, I don't have much experience in, handling, such cases, but I must say you are, quite fortunate to have, managed such a challenging case at your institute.
Yes,
Because-
one participant was done at our medical college, and another is at AIMS Jodhpur.
All
Both
right.
are taken, but I am not the part of that team. But
I know it's a team approach basically. You need a team of two anesthesia teams and 2 surgical teams and things like that.
Yes.
With unique neonatal physiology, as such is very, very challenging. I'm sure, such scenarios add to it actually. So,
Yeah, but
so if anyone has any questions for her, she'll be happy to answer. And then, and madam, how did you calculate the maximum allowable blood loss in such cases? How do you do that? How do you know the blood loss is happening from which twin and how to replace? Any comments on that?
sir, it is very difficult to calculate.
Because,
Hello.
yeah, exactly. Yeah,
very
exactly.
blood loss. It's just on experience based. We were not able to calculate the
All right.
exact amount lost, but we say it's
Objectively, you weren't able to calculate. All right. And any comments on the long-term outcome of these things at your institute? Did you keep a follow-up?
Yeah, the parasitic twins that were
on the outcome.
So the patient is still healthy because he is having not any deformities. And what the done at the AIMS after the follow-up and both child was follow up in their department, and still one of having the ventral hernia.
All right.
So ventral hernia, I think due to COVID, it is postponed, and it will be done as early as possible.
Okay, ma'am. So congratulations on the wonderful presentation. You really did well. And if anyone has any questions for her, she'll be happy to answer. Or we'll move on to the next speaker.
So we can move on to the next speaker.
Sure. Thank you, ma'am. Thank you so much.
Thank you. Thank you, sir.
Our next speaker is Dr. Avula Muralidhar, sir. He is a professor at Nilofer Hospital, Hyderabad. He is having 14 years of experience in exclusive pediatric anesthesia. He is a WFSA safe pediatric anesthesia trainer and ASPA BPLS trainer. He is regular faculty in pediatric anesthesia conference workshops at CME. And he is Telangana State first pediatric anesthesia CME he has hosted, and difficult pediatric airway workshop in 2018 as a part of conference. He has 7 original pediatric anesthesia research publications and 9 pediatric anesthesia paper presentations in various conferences. Over to you, sir.
Thank you. Is it okay? Your screen is okay there?
It's your screen is okay. Perfectly fine.
Okay, sir. Thank you, sir. Good afternoon to all. Today our topic is pediatric difficult airway. Before going to difficulty, we'll go for routine airway management. Other than pediatric anesthetists, other anesthetists will think that it's a very difficult. But I'll say that it's not difficult. It's very different from the adult. As a pediatric anesthesiologist, I will say it is very easy to intubate within 15 to 20 seconds. So one should know first unique aspects of the pediatric airway, anatomy and physiology, and routine airway management, and then go to the difficult airway management. What are the differences between pediatric and adult? The main difference is larynx is anterocephalad placed mainly, and vocal cords are with anterior angulation and with prominent alternate cartilages. Epiglottis is larger and flappier. This flappier epiglottis makes a lot of difference. And pharynx is very small, narrowest cricoid level, trachea is narrow and less rigid, and especially neonates, large tongue in proportion to the mouth and large occiput with different shapes, especially neonates. See so large and floppier epiglottis. And one more important thing is airway resistance comparatively to the adults. Neonates have a very high airway resistance because of a very small airway diameter. As you know, airway resistance is inversely proportional to the radius to the power of 4. See, for example, in infant and in adult, we add 1 mm of circumferential edema. There is 16 times increase in resistance.
Excuse me, sir. Your slideshow is probably not done, so we are not able to see different slides.
Slide is not coming?
Your
No,
slide
sir.
is not, moving, It's just fixed at your initial slide, your first slide.
No, sir?
No, not yet.
And Dr. Chetna, the front screen is also something, it is different from other lectures.
Pardon, madam?
The screen also shows a different configuration is different compared to previous lectures.
Yes,
Okay,
yes.
I will share it again, madam, please.
Yes, sir.
Yeah.
सर आप शेयर स्क्रीन में स्लाइड शो वाली चूज करना, आप जो दूसरी सिलेक्ट कर रहे हैं ना उसके बजाय स्लाइड शो वाली सिलेक्ट करना, शेयर स्क्रीन.
Yeah, that's right. Your cursor is at the right spot. You just have to click.
सर स्लाइड शो करें आप.
Yes, I'm doing.
Yeah. सर आप पहले स्लाइड शो करें और फिर शेयर स्क्रीन.
Slide show. Okay. Wait.
पहले हाँ.
Yes, I understood. Is it okay now? Is it okay?
No, sir. Still, slideshow is not working.
I shared already.
Yes, but slideshow is not done. So पहले slideshow करें फिर share screen करें sir. Yes, sir. Now it's yes,
It's
sir.
coming?
Yes, sir.
Okay. Okay, which slide is that?
Pediatric airway management.
Okay, sir.
Unique aspects of pediatric airway anatomy, respiratory physiology.
Is it okay, sir, now?
Yeah, it's okay.
Yes, sir. Now we'll go to the airway resistance. If you add 1 mm circumferential edema to the infant and adult, there is a 16 times resistance increase occurs in infant, but whereas in adult is only 3 times. And what are the difficulties unique to pediatric airway management? One is cephalothoracic disproportion, large occiput, cephalo-anterior position of the larynx. And here one more important thing in neonates especially is very delicate sensitive structures of the neonate. You have to remember that to be gentle during intubation process. And frequent upper airway obstructions under anesthesia occurs as the pharynx area is very small. And there is faster desiccation due to higher metabolism, small FRC, lower oxygen levels. Here, one more thing, important thing is awake.
The slides are not moving again. It's again stuck at the same slide. Are you changing your slides? Sir, are you changing your slides or you're at the same slide?
No, I'm changing, sir. I'm changing the slide.
But we can't see. We can. We are stuck up at the same slide. The slideshow is not working, I think, here.
Yesterday only I did here one more thing.
I think I think Mr. Muralidhar, you can Dr. Muralidhar, you can go ahead and talk because we are running out of time. Your slot.
Yeah, you can just talk. You can just talk.
Just give me 1 minute, sir. 1 minute.
Yeah, that's it. That's it. That's it. That's it. Now we can see that slide.
Now it's changing, sir?
Yeah, it's changing. Fixed.
Okay, sir. Okay, thank you. So in neonates, fiber optic intubation is usually not an option because of the size of the scope. And during neonatal airway management, you have to put roll towel to stabilize the head and roll towel to elevate the shoulder. So it's not changing now? So slides are changed?
So it's still stuck. It's still stuck at the airway resistance slide.
Yeah, but you can keep on speaking so that at least here.
Yeah. Okay, sir. It's changed now?
No. I suppose you can just carry on with your talk because otherwise you'll run out of time.
Yeah, it's changing now.
Yes, sir. Yes. No, it's not changing. Okay, sir, I will continue. Sorry for this problem, technical problem. Okay. Okay, sir. Have you seen this figure, sir?
Yes, we can see this picture.
Yes, sir. This is how to hold the head. It's the wrong method. Routinely, for adult, what we are doing, whenever you go for the infant, also we'll put our palm on their head. For the neonate, which are unfused bones are having. So it's better to change the position to this position. Change. So maybe there is transmission, sir. There is a lag period. This is how to hold this head from the side of the head. That is better one. And how to hold the mask also important. Put two 2 fingers on the mask and 1 finger for jaw thrust. And use how to use laryngoscope, use OELM, optimal external laryngeal manipulation for the intubation, ET2 fixation. To one video, sir. There is some lag period in between. Yes, little bit delay in transmission. Fix the tongue in the center. No extension is needed, sir, for neonatal intubation. Use OELM. Just as one of the assistant to pull the cheek. Go on the angle of the mouth. So you can put the tube. Let's discuss the wide variety of difficult airways occurs that can extremely challenging as well as nerve-wracking for the pediatric anesthesiologist. Nothing could be worse than severe airway obstruction after induction and paralysis in a child who could not mask ventilate. To avoid trouble, one must be prepared to tackle the trouble. Should have experienced a trained anesthesiologist with difficult airway call. So what is the definition of difficult airway? As the ASA suggested, when sign of inadequate ventilation could not be reversed by mask ventilation, or oxygen saturation could not be maintained above 90%, or if trained anesthesiologist using conventional laryngoscope takes more than 3 attempts or more than 10 minutes, are required to complete the tracheal intubation. So why does it happen? Exaggerated idea of personal ability, not requesting for experienced help, no discussion with colleagues about proposed management of the case, ill-conceived plan without backup plan B. Even poorly conducted plan is sticking extra time to the same plan, otherwise delaying the rescue plan late. Last but not the least, not involving the surgical friends. What are the causes of difficult intubation in pediatrics? Inadequate assessment, inadequate equipment, experience not enough in pediatric anesthesia, poor technique, malfunctioning of equipment, inexperienced assistance in patients, causes and acquired causes. But what are the important things we have to do is pre-anesthetic visit, take the history of past anesthetic exposure and any medical therapy. Assessment, see for adverse anatomical features, mechanical limitations, poor dentition, lateral view of patients, view and palate, and range of the neck movements. And also see for signs of patient. Limited mouth opening, micronausea, tongue, and noisy breathing. And difficult airway and congenital syndromes based on anatomical site, especially polysaccharidosis, involves a lot of structures in the body. It's a very difficult airway. What are the various options for difficult airway intubation? The first choice for the management is potentially difficult airway to maintain spontaneous ventilation. That is important. Whenever you are anticipating difficult airway, maintain spontaneous ventilation, whether the child is sedated or under general anesthesia with inhalational or intravenous drugs. In neonates, we can go for awake look, especially neonates, if you are having any anticipating difficult airway. And tracheal intubation using ILME or fiber optic bronchoscopy, awake blind nasal intubation also one of the basic thing, and retrograde intubation. And you should have a plan 1, 2, 4, always. So IDA 2016 guidelines for the management of unanticipated difficult tracheal intubation in pediatrics. Step 1 is laryngoscopy and tracheal intubation. Step 2, SCAD to maintain oxygenation. Step 3, rescue face mask ventilation. Emergency surgical airway access. These are the given by IDA. So let's discuss a little bit briefly. Unanticipated difficult airway, if mask ventilation is possible, yes. Yes, if you go proceed, it's not possible, pursue other intubation techniques, change head position, and go for OELM and different techniques, intubating LME. If succeed, good. If fail, awaken the patient and then plan for awake intubation technique. Final option is establishment of the surgical airway. So let's discuss about fiber optic intubation. Predicted difficult airway with adequate oxygenation, ventilation, distorted upper airway anatomy, C-spine injury, contraindications for fiber optic intubation, excessive blood and secretions, inadequate oxygenations. So cases, pediatric difficult airway management, cases briefly, identify the problems and what actions we have to take. So these figures will show PD Robbins sequence. There is a time lag little bit. PD Robbins sequence. It's mainly it's a congenital syndrome characterized by retronathia is the main thing. It's a very difficult airway. This is also. And another thing is bilateral cleft lip. Just sir, just few seconds. Yes, sir. P. Robbins sequence. Retronathia is the prominent feature. And bilateral cleft lip. Very low birth weight baby with bilateral cleft lip and palate and ARM. Lymphangiomas, especially in pediatrics, we regularly will get lymphangiomas, which are soft, very soft cystic tumors. This case is extending from the bilateral lower eyelids to the surrounding total neck to clavicle. In this patient, you can have a awake look to see whether intubation will be difficult or not. This large lymphangiomas. This is one more lymphangioma extending from the occipital, neck, scapula, axilla, and shoulder joint dislocation. The head is totally, neck is totally distorted, and right shoulder also. Here we'll see the necrosed skin, and CT scan also shows it's not extending into the pharynx area. And here we aspirated the fluid and we stabilized the head. We did intubation. The next lymphangioma, sir. This is what lymphangioma you're seeing. We go for awake intubation. This is after in post-operative period. This one the gangrenous skin, sir. So after post-operative period, this gangrenous skin, just we aspirated the fluid after doing transillumination test. It's totally water inside. And this solid lymphangiomas also there. If for solid lymphangiomas also you have to go for maintaining spontaneous respirations, and or if you are having fiber optic intubation, it's always well. And tongue tumors. In tongue tumors, we have to go for investigations, CT scan, whether it is extending inside the base of the tongue into the pharynx or not. You have to see by CT scan, or clinically also you can do the examination whether it is inside or not. It's a tongue tumor. So other thing is TMJ ankylosis. We did this last 10 years back. Yes, sir, seeing this, just holding the tongue, you are saying that the tumor is only in the anterior part of the tongue. you can go for easy intubation with sevoflurane. Next slide is showing TMJ ankylosis. This is a traumatic ankylosis. For this, we did blind nasal intubation. Okay, if we are having fiber optic, it's the best option. If you are not there, you learn the basic things about blind nasal intubation also with the help of sevoflurane. So we intubated. So other conditions where stiff neck also we'll see in neonates and infants. Extension and short neck without extension also will be seen in some conditions. And we'll regularly see occipital tumors or occipital meningomyelocele. For this, you can place some rings or something to elevate that. If you're not doing that, another option also you have to think. So try to learn lateral intubation. Just turn the head to the lateral side, intubate it in lateral position. This blind nasal intubation we did with inhalational. This is short neck. Extension is limited. For this slide, I am showing why means you have to learn the lateral intubation also. It will help you in intraoperative period. Sometimes in thoracotomy cases, it's better doing lateral intubation for these type of cases. So one more regular cases we are getting is hydrocephalus. Large hydrocephalus we'll see. Most of the times weight, almost 2/3 of weight is with the head only. With this large hydrocephalus, everybody thinks that intubation will be difficult. No, but intubation is very difficult. The position is the main problem. If you place proper position for hydrocephalus case, then intubation will become regular intubation only. So these are the hydrocephalus cases. 2 hydrocephalus, very big head. And very, very rarely we'll see nasal agenesis, not choanal atresia with nasal agenesis totally. Those type of cases also we'll see. For these type of cases, we have to basically in our hospital, we basically will depend on inhalational induction intubation here for any difficult airway cases. We'll put the oral airway and try to give 100% oxygen with sevoflurane and go for maintaining spontaneous respirations. We go for intubation. Nasal agenesis. This is the case, nasal agenesis. And regularly we'll see cheek tumors and buccal tumors. Here the problem is how to mask ventilate. For these type of cases, we'll put very adult mask, big mask, and try to do mask ventilation. And here we have to take care of bleeding, any injury to the tumors, buccal tumors and cheek tumors. So this is the cheek tumor. Also, we'll see tumorous growth of the jaw. Mandible growths also we'll see in some of the infants, very rare conditions. Here also difficulty in bag mask ventilation. difficult cases in pediatrics, difficult airway is mucopolysaccharidosis. Total joints are involved, cervical spine is involved. There will not be no extension of the head. It's a very difficult airway. For these cases, will come for inguinal hernias and umbilical hernias, regular surgeries. If the baby is good enough, go for spinal or caudal block while maintaining spontaneous respirations. And here we can use subglottic airways also after giving regional anesthesia. So supraglottic airways and the difficult airways early in a can't intubate, can't ventilate situation while also getting prepared for the surgical airway. Subglottic device, supraglottic device not suitable if the airway difficulty is due to laryngeal problems. Use supraglottic airway has revolutionized the difficult airway management, especially in pediatrics. Before supraglottic airways, if neonate is not breathing, we always go for face mask ventilation. But if it is easy with the supraglottic airway. Why this approach? This approach, supraglottic airway approach, avoids excessive airway instrumentation and minimizes the risk of trauma and further airway obstruction by bleeding or edema and circumvents the can't intubate, can't ventilate scenario. And it can be used as the definitive airway for a short procedure in a child with difficult airway in experienced hands, example, feeding gastrostomies, like surgeries in Piri Robbins patients. When endotracheal intubation is not possible in a difficult supraglottic airway, acceptable for experienced providers. In between difficult airway intubations, instead of face mask ventilation, if you can use supraglottic airways like Isacon to maintain the oxygenation. Sometimes it's difficult to maintain with face mask.
Sir, we are running late, so please conclude your.
Last few slides.
Thank you, sir.
In between attempts, we can use supraglottic airway to maintain the oxygenation. So case of supraglottic stenosis, we did one case 20 days old, not able to pass even 2 mm OETT in post-operative period. Its case came for post-op wound gapping, not able to pass 2 mm ET tube also. Then how to proceed that emergency case? If elective, we can postpone it, but it's an emergency case. We did with Isacon, we placed Isacon and maintained, and we kept ready for tracheotomy and tracheostomy with the ENT surgeon after talking with the ENT surgeon. But we finished that with Isacon only, without any morbidity. We'll summarize the management of difficult pediatric airway. Careful history taking and physical examination. Difficult airway parts should be wheeled into the induction area. Difficult algorithm you have to follow. Precautions during attempts, mandatory to monitor SpO2 with audible pulse signal, and avoid halothane, ketamine, which causes exaggerated reflexes, ketamine. And propofol with topical lidocaine spray and sevoflurane can be used. And OPI like fentanyl, dexmedetomidine also use it as an adjuvants. Don'ts in the management of difficult airway. Do not produce deep plane of anesthesia. Don't use technique that you are not familiar. Avoid multiple attempts. Don't render the patient apneic unless you are certain that mask ventilation can be maintained. Do's in the management of difficult airway: use anti-silogogue in premedication, aspiration prophylaxis, endotracheal tube assorted size, supraglottic airway of assorted size, tracheostomy set, check special airway equipment, keep help of senior anesthesiologist, pre-oxygenate patient, use ETCO2 device. Conclude that strict adherence to the protocols of the anticipatory difficult airway would certainly help one avoid operative mortality and morbidity. Inhalational induction and intubation remains the technique of choice in pediatric anticipated difficult airways in hands of expertise. Thank you. Sorry for the technical issues. I'm extremely sorry.
So, beautiful presentation, Dr. Muralidhar, in exhibiting, as also an impressive body of work that you showed us. You know, and the range of conditions having difficult intubation in neonates and pediatric age group.
Sir.
So it was really nice. And if someone has any questions, they have, Dr. Muralidhar would be happy to answer.
Sir, do you recommend the use of choline, succinylcholine, in infant in cases of difficult predicted airway?
No, madam. In pediatric, we would recommend schooling.
In predicted difficult airway?
Yes, madam. Predicted, we are having sevoflurane. Comfortably, we'll use sevoflurane after using premedication of anti-sialogogue and opioid.
So, you
Comfortably, we'll use with sevoflurane. There is no need of schooling.
Okay.
Basically, we follow. If you are anticipating difficulty, don't give any muscle relaxants. Maintain spontaneous respirations.
Okay.
Yeah, that's basically the golden rule is that to maintain spontaneous respirations and
yes.
After successful mask ventilation, that is what I want to ask. If you are able to mask ventilate and it's a predicted difficult airway, then do you recommend use of muscle relaxant?
In adult, but in pediatrics, the pharynx area is very small.
Neonate, infant.
If you will anesthetize, immediately that collapse. If you're anticipating, it's a better way is go for with sevoflurane. There's no need of scoline. Scoline side effects also in pediatrics, little bit to have concern of that side effects of the scoline.
We only use choline in rare setups where we are unable to break the laryngospasm by CPAP and by gentle IPPV. If you're not able to break the laryngospasm, then gentle use of small dose of choline is recommended with prior premedication with atropine. That we do in our practice.
If you are suspecting any spasm like that,
yeah, that's the only condition in which it's recommended.
Yes. Before putting laryngoscope, we will give 1 mg per kg of propofol to blunt the intubator response. Right. As sevoflurane is very rapidly recovered from sevoflurane, we'll give a little bit propofol.
One can do that. And also, I wanted to, as far as supraglottic airway device in children is concerned, you insert it backwards and then turn it by 180 degrees, right?
So, sir, please.
That's how you insert it backwards and then turn it by 180 degrees so that to have it in place. In small children, is that what you do actually with your supraglottic airway devices?
In normal intubation, sir, routine intubation?
No, supraglottic airway devices, talking about LMAs and stuff like that.
So, supraglottic airway devices.
You insert it backwards and then turn it by 180 degrees?
We use iGel, sir. We directly put it, we'll touch the hot palate, we'll go directly. We won't turn it, but we're turning, there's no space at all for neonates. Okay. It's a very small space.
Sometimes it's recommended that you put it backwards and turn it a little bit. So that
we'll go directly, we'll touch the hot palate and we'll go inside.
Yeah, that's what we do in adults actually. All right. So if someone has any more questions, Dr. Muralidhar would be happy to answer as well. Or we can move on to the next speaker.
Yes, sir.
Thank you, sir. Thank you.
Our next speaker is Dr. Nidhi. She is assistant professor at Department of Anesthesia, Rohtak. She has 7 years of clinical experience in anesthesia care. Her interests are pediatric and obstetrics anesthesia, and she has 8 international and 6 national publications on her account. Over to you, Dr. Nidhi.
Welcome all to Isacon 2021. First of all, I would like to thank Indian Society of Anesthesiologists for giving me this wonderful opportunity to be part of this academic feast. Today, I will be speaking on anesthesia in radioimaging suits. Anesthesiologists are increasingly participating to provide anesthesia care to patients undergoing procedure outside the traditional main operating room settings, and radiological suits are one of those areas. Number of imaging and intervention done have been exponentially rising in susceptible age group in the past decades, and the credit for their success lies on the implementation together with good anesthesia and analgesia, which has dramatically improved the patient outcome. Practice advisory given by ASA defines anesthetic care for radiological procedures like MRI as moderate sedation, deep sedation, monitored anesthesia care, general anesthesia, or ventilatory and critical care support. Sedation and general anesthesia are continuum of the CNS depression states, which have been categorized into the 4 major categories: minimal sedation, moderate sedation, deep sedation, and general anesthesia. In minimal sedation, the patient gives normal response to verbal stimuli. In moderate sedation, the patient gives purposeful response to verbal or tactile stimulation. In deep sedation, the purposeful response following repeated stimulation or painful stimulation is present. In general anesthesia, the patient remains unarousable even with painful stimulation. The potential for loss of protective area reflex increases as we increase the depth of the sedation, and the risk is particularly high in deep sedation and general anesthesia. So deep precaution should be taken during these techniques. As far as pediatric population is concerned, apart from normal anatomical and physiological concern, sedation techniques are really challenging as it is difficult to predict the depth of sedation, particularly in neonates and infants. So imaging under general anesthesia is becoming routine and preferred technique in this age group, as it provides patient in comfort and more controlled environment to acquire high quality images. Most of the adults, they tolerate these radiological procedures very well, even without sedation. But as far as sedation in children is concerned, a more deeper level is required not only to elevate their anxiety, but also to modify their behavior for the safe completion of the procedure. Because a child's ability to control his or her behavior is to cooperate for a procedure depends not only on their chronological age, but also on their cognitive and emotional development status. The depth of sedation is a concern in pediatric age group, as they are more vulnerable to the sedating medications effect on respiratory drive, airway patency, and protective airway reflexes. So we have to be very careful to combat these issues in children. It is common that the children easily progress to a deeper level of sedation without easily recognizable signs. For these reasons, patients who require more than conscious sedation, they must be provided with the same level of safety and monitoring as in the operating rooms. Dial et al. In their study, they also highlighted the fact that pediatric sedation results in unpredictable depth. So they have to be very carefully monitored. In these situations comes the role of rescue sedation, which means that the practitioner who are providing sedation, they must be able to recognize the various level of sedation, and they must have skills as well as age and size appropriate equipments necessary to provide appropriate cardiopulmonary support if required. For example, if the intended level of sedation is minimal, the practitioner must be able to rescue the child from moderate, and if the level is moderate sedation, the practitioner must be able to rescue the child from deep sedation, and so on. Now, the big dilemma which arises is how much sedation is sufficient? A very tough question to answer. Well, the target level depends upon the not only on the depth of sedation, but also depends upon the imaging procedure or modality, as well as the individual patient characteristics. For example, CT scan can be done in moderate sedation, and prolonged investigations like MRI, nuclear imaging techniques, which involve the child to keep still for around 1 hour, they may require deep sedation to general anesthesia. Whatever may be the desired level of the sedation, there must be some universal goals which should be kept in mind. And American Academy of Pediatrics has clearly defined them as ability to guard the patient's safety and welfare, to minimize physical discomfort and pain, to control the anxiety, to minimize psychological trauma and maximize amnesia, to control the behavior and movement, and to return the patient to a state in which safe discharge from the medical supervision is possible. Various medical professionals have been providing this sedation, like pediatrician, trained nurses, but there are certain scenarios which mandates the presence of anesthesiologists. As stated by ASA guidelines, these conditions are medical problems like ASA status 3 or 4, respiratory and airway problems, prematurity, less than 60 weeks post-conception, systemic disorders, procedures requiring deep sedation in full stomach patient, management problems like severe developmental delay, patients who are difficult to control, severe attention deficit disorders, and history of failed sedation like over-sedation, inability to educate the child, or hyperreactive response of the child to the sedation. Broadly, the techniques for sedation are categorized into 2 limbs. First one is non-pharmacological method, and the second one is pharmacological. The potential for long-term effects of anesthetic exposure on the subsequent neurodevelopment outcomes based on the various preclinical models and some of the retrospective clinical data has raised an issue of concern in the recent years. So the radiology department all over the world have developed innovative techniques to decrease the use of sedation and general anesthesia in pediatric population, if possible. The various techniques are feed and swaddle, fast exposition techniques, certified child life specialist, mock MRI, dog therapy program, etc. Among these, feed and swaddle technique, they are particularly useful in children and infants. The success rate of sleep induced by feeding term children younger than 3 months may be up to 75%. Until now at all, they have performed a retrospective review of feed and wrap technique in infants 3 months or younger, 79% efficacious. Pre-scanning familiarity with the MR system through the use of various prototype educational videos, even small scale models like Lego brick demonstrated in the diagram. These kind of prototypes, they help to elevate the anxiety level of the child, and the child becomes more comfortable during the scanning procedure. This is a diagram showing the child life specialist demonstrating how IV cannulation is going to be done during the imaging procedure. Whenever we kind of demonstrate mock MRI, the situation, these procedures, they help to make the situation more comfortable to the children. Environmental modification and virtual reality goggles, they act as distracting agents to elevate the anxiety. As far as pharmacological therapy is concerned, there are a wide, very large variety of agents available, like pentobarbital, midazolam, chloral hydrate, dexmedetomidine, ketamine, propofol. Among the inhalation agents, Entonox and sevoflurane are the most preferred ones. For analgesic purpose, fentanyl is one of the most preferred agent as it has rapid onset, short T-half, and fewer side effects. Due to time constraint, I cannot go into the much details of the pharmacodynamics and kinetics of each of them. But the thing which should be kept in mind is administrating them whether by oral or IV route or inhalational route. We must keep in mind that we should provide incremental doses or by infusion so that to titrate the desired endpoints. And sufficient time should elapse between the doses so that the peak effect of each dose can be assessed before subsequent drug administration. These agents, these sedation techniques, they are having some of the risk. If majorly they are categorized as over sedation and under sedation. Under sedation, it leads to inadequate image quality owing to the motion effects, repeated study and associated additional radiation burden, psychological negative impact on the children due to repeated imagings, family bearing forcing parents to take additional leave, and cost of the procedure. Over sedation is associated with complications like respiratory insufficiency, cardiocirculatory depression, aspiration, and vomiting. There are certain scenarios where the role of GA is crucial as sedation alone cannot assist to get the radiology. And Arkelov et al. Has described these conditions as broadly into three major categories. Condition, first of all, the condition in which airway management is likely to be difficult, like in abnormal airway, history of sleep apnea, nasal blockade. Disorder failure like neuromuscular disease, decreased conscious level of the patient, respiratory failure, cardiac failure, lobar emphysema, pulmonary cysts or bulle, severe pulmonary hypertension. Thirdly, the abnormality with the increased likelihood of pulmonary aspiration like raised eyes. Irrespective of the technique of anesthesia used, patient protocolized assessment is of paramount importance. Sedation-related aspects of the patient medical history should be appropriately evaluated. They include abnormalities of major organ system, previous adverse effect with sedation or general anesthesia technique, drug allergies, current medication, drug interaction, time and nature of oral intake, birth history along with developmental history. Apart from this, a focused physical examination, including vital signs, auscultation of the heart and lungs, airway should be appropriately done. Adequate fasting in pediatric age is crucial as it is difficult to predict the level of sedation in which airway reflexes will be lost and the child becomes prone to the risk of aspiration. Sufficient time should elapse before a procedure to allow gastric emptying for elective procedures in healthy children. As per ASA guidelines, minimum fasting interval of 2 hours for clear fluid, 4 hours for breast milk, 6 hours for infant formula milk, non-human milk, and a light meal, and 8 hours for fatty food is recommended. However, if there is urgent, emergent, or other situation which impair gastric emptying, the potential for pulmonary aspiration of gastric content should be kept in mind. NICE guidelines, they advise that fasting is not required for inter-nocturne sedation, in which less than 50% concentration, around 50% concentration of nitrous oxide is used in minimal sedation, and moderate sedation during which the child will maintain verbal contact with the healthcare personnel. It must be kept in mind that information regarding monitoring should be appropriately recorded and it should be adequately done. As per American Academy of Pediatric guidelines, all the patients undergoing sedation and analgesia, they should be monitored by pulse oximetry with appropriate alarms. ECG monitoring should be done in children during deep sedation and during moderate sedation in those in which there is presence of significant cardiovascular disease or those who are undergoing procedure in which dysarrhythmias are anticipated. ETCO2 monitoring of those sedated patients at moderate and deeper level of sedation should be done. The guidelines recommend that blood pressure monitoring should be determined before the sedation and whenever possible and at regular intervals during the procedure unless such monitoring interferes with the procedure. For example, in very small pediatric population in which stimulation of the BP curve could itself arouse the child. NICE guidelines for monitoring in these aspects they recommend the monitoring of depth of sedation, respiration, oxygen saturation, heart rate, and pain. In deep sedation, apart from these, monitoring of 3-lead ECG and tidal ECG-CO2 and regular blood pressure monitoring and monitoring of pain is required. Before proceeding for anesthesia sedation, availability of appropriate size equipment for establishing a patent airway and providing positive pressure ventilation with supplemental oxygen must be done. A well-known acronym SOAP-ME must be kept in mind. Apart from these things, the drug naloxone and flumazenil, they should be available in radiological suits for adequate safety of the patient. Procurement of anaphylactic pack, including adrenaline, chlorpheniramine, and steroid, is also another safety precaution. Again arises in our mind which agent is better and which agent should be used in which condition. Well, this is not easy, not at all a simple question to answer. Choosing appropriate drug for a radiological procedure is essential, and it depends on the age of the patient, associated comorbidities, as well as the kind of intervention required. The use of traditional sedative agents like pentobarbital and chloral hydrate has decreased due to their long onset and long recovery. Midazolam and ketamine are preferred as an adjunct rather than a single use to counterbalance adverse effect of other sedative agents. Currently, the use of propofol with high effectiveness and rapid recovery and dexmed with the respiratory drive preservation feature has increased as a single agent for deep sedation and general anesthesia in children undergoing ambulatory MRI and other radiological investigations. Among the general anesthetic technique, inhalation agents like sevoflurane, IV anesthetic like propofol, combination of them are most commonly used. While providing inhalation anesthesia, it must be kept in mind that MRI safe conditional machine and vaporizer should be used. And if intravenous agents are used, it should be administered via MRI safe conditioned infusion pumps and specialized tubing. After providing general anesthesia, the patient airway should be properly secured. The airway management technique can include natural airway spontaneous breathing and supplemental oxygen via nasal cannula, or more invasive gadgets like laryngeal mask airway, endotracheal tube. They can be used depending upon the child comorbidities and fasting status. Complex airway management techniques for video laryngoscopy, they should be done in outside of the zone 4 because these advanced airway equipment are usually not MRI compatible. The anesthetist should have an advanced plan in their mind to deal with instrumentation of the airway and common airway problems like obstruction, secretions, laryngospasm, apnea, hyperventilation. NICE guidelines, they particularly for the painless radio imaging, they recommend that we should not use routinely ketamine or opioid for painless imaging procedures. Whenever the procedure is painless, try to provide midazolam or chloral hydrate to the children, which has a wide margin of safety. However, if this child is unable, we are unable to sedate the child with these, they recommend that agents with greater, which have a greater margin of safety, like propofol and sevoflurane, should be used. The radiological investigation, they are not only confined to the imaging. Nowadays, there is advancement in intervention radiology, and sedation and anesthesia techniques are required for them also. Decision tree is crux in intervention radiology as well. If the clinical status of the patient is good, then minimal or moderate sedation will work, which may be provided by pharmacological or non-pharmacological measures. However, if the clinical condition of the patient is poor or the procedure is painful, then provision for deep sedation or general anesthesia is essential. Recovery care is also of paramount importance, and the practical guidelines issued by ASA as well as ACB, they strongly recommend monitoring of the consciousness level, monitoring of the oxygenation status of the patient, monitoring the ventilation circulation, and keeping a watch on the complications like nausea, vomiting should be done. And the discharge criteria should be appropriately designed to minimize the risk of complication after the discharge of the patient from the recovery area. There are various hazards, risks in radio imaging suits like remote location, inadequate space, movement-related hazards, communication hazards, all of these, they should be kept in mind while providing anesthesia in these remote locations. At last, I would like to conclude that safe practice is the key to the successful and uneventful sedation or general anesthesia technique, and it will help in acquiring high-quality image, good image interpretation, and an efficient pediatric imaging services. And in order to acquire or to practice these techniques, one should keep in mind and one should observe appropriate guidelines in the pre-sedation assessment, during the choice of sedation delivered, and provider of the sedation, and the sedative agents. Thank you all for your patience listening.
Thank you, Dr. Nidhi, for the extensive and instructive talk on anesthesia in radio imaging, in the radio imaging suite. Since we are running short of time, we would like to wind up with one or two quick questions from the audience and from the chairpersons. Dr. Nidhi, most of the time we get a call from the MRI suite telling us that they have started the MRI, but the child is very restless, child is moving, we are not able to proceed. So in such settings, the child would, would not be, NPO as per the guidelines. So we may have to intervene in such situation. What is your experience in managing such emergency calls from MRI suites?
Actually, sir, it depends upon the condition of the child, like for which radiological procedure the child is posted, and whether the planned investigation is emergency or it was an elective thing, kind of elective thing. Sometimes it's elective also. So we should keep in mind that the child is inadequately fasting and try to secure the airway if the process is urgent. Otherwise, we can think of trying to give, usually when we get calls, the child is only given with some kind of oral medication only. We can supplement it with another anesthetic agent also, if required.
Would you like to defer the procedure and call the child back the next day with the proper NPO guidelines?
So that's what I was saying, sir. If the procedure is emergency, I would like to proceed. And if the procedure was kind of elective, then I would like to reassess the patient, and then I would, it depends on case to case basis. What was the ASA status of the patient, and what was the, why was the radiological procedure was required for the patient. So depending upon all the scenarios, I will like to proceed if possible.
Right. Thank you.
There is one question from audience. Please come here.
According to you, hello.
You can come here also.
Madam, according to you, in MRI, which agent do you suggest?
See, sir, there is no, I won't say only a particular agent is, I will say yes, sure, this agent should be used. It depends upon the case to case, like what is the age of the child, what is the ASA physical classification of the child, and for how much duration the procedure is required, whether only we are doing diagnostic or some kind of therapeutic or intervention thing is done. So it depends on the various factors.
In MRI, it is running for the half an hour.
Okay.
And can we use a ketoprol? Ketamine?
Probably we can use.
Any sedation supported by?
Most of the times, ketofol alone will provide adequate sedation as well as analgesia, because ketamine also have analgesic potency. So this will suffice in most of the cases.
Can we add in any narcotics in smaller dose?
Routinely, it's not required. See, I have mentioned the guidelines that typically NICE guidelines that they clearly state that we should use opioids only when a painful procedure is anticipated. So if the procedure is painless, and since MRI is entirely painless, avoid opioids because they have additional respiratory depressant potential.
Thank you.
I think we have come to the final presentation in the pediatric section. So thank all my colleagues, Chairperson Dr. Ashish Sethi, Dr. Siti Shah, and all the faculty who presented in this session.
Thank you, sir. Thank you, sir. Thank you, sir. Thank you.
Thank you.
And thank you, Dr. Nidhi, for a wonderful presentation. It was nice.
Thank you, sir.
Okay.
Thank you all. We are concluding the session.
Okay. Thank you. Thank you, organizers, for inviting a chairperson.
Yeah. Thank you, Madam Shah.
Thank you all.
Thank you.
Our next session is sir is online. Okay. On case-based discussion about pediatric laparoscopic surgeries. Dr. Ramesh sir, he's the moderator. Consultant pediatric anesthesiologist at Chennai, and he is at present affiliated with PGI Chandigarh. He qualified from PGI Chandigarh. He is practicing exclusive pediatric anesthesia from year 1990 and representing India for the Children of the World Anesthesia Foundation. He visited various children hospitals in USA, UK, Australia, Switzerland, Hong Kong, and Singapore. Organizing chairperson for the International Congress of Pediatric Airway in Chennai in 2011. We welcome you, sir. Over to you for the session. Our panelists are Dr. Sudarshan. He is consultant and head of Department of Anesthesiology at Canadian Medical Center, Kuwait. Dr. Anita Nahate. She is consultant anesthesiologist, vice president of Maharashtra State Branch ISA, Vedant Hospital, Nashik, Maharashtra. Dr. Sandhya. She is professor of pediatric anesthesia and resuscitation research methodology. And Dr. Anju Gupta. She is assistant professor at AIIMS, New Delhi. We welcome you all.
Good evening, everyone. This is a panel discussion on pediatric laparoscopy, and we will be able to review some of the important points in the pediatric laparoscopy along with eminent faculties in our country. When you talk about pediatric laparoscopy, about 25 years ago, when we have not done any pediatric laparoscopy, probably the father of endoscopy and surgery from United States, Kirti Georgeson, come to our hospital, did a workshop. That's the first time we did pediatric laparoscopy workshop. That was a 3-month-old child for a pull-through. I didn't know that there's so much of difficulty and so much of hypothermia coming and temperature going.
Yes.
Actually, I feel that when the surgeons and me feel that when you open you do a laparotomy, touch the bowel, touch the omentum, if you have the feel of the tissues, but in the laparoscopy you are only equipments. That's what the surgeons are telling. What's your input in this? Thinking.
Yeah. Sorry.
Yeah.
Okay.
Sandhya, Dr. Singh.
Yeah, the tactile feedback is not there during laparoscopic surgery, but as the surgeons gain experience, they get better at it, and gradually they are developing instruments which do give some amount of feedback to the surgeon. So new equipment is being done. There is a grasper which does give some feedback to the surgeon's hand. But these things are still in experimental stage. We really do not know how good they are going to be. But it's basically the experience of the surgeon with which they improve, don't have a direct feel. The other thing is that they get a better view of the organs. They get a better magnified, closer view. So that helps them. And for the lack of the feedback, the tactile feedback they get.
I think benefits are much more in laparoscopy than the open. I think that has taken over, and I think if I think back, it is some similar to like what we are having at about 30 years ago with bag ventilation for the whole day. Now we put on a ventilator. We are not sure whether attached to the patient. Similar to that, I think we are happy and we are doing that. I think similar to that. But Anjut, I remember about when we started laparoscopy in children, I don't know about your All India Institute, but most of them, the adults were trained very much more than the pediatric surgeons. So what they say is that adult surgeons, once they put a hole into that, put in all the ports, whether it's a child or an adult, it looks the same. Why should be a pediatric surgeon to do all this thing? Do you think there's any difference doing a pediatric surgeon? I feel that pediatric surgeons, the organs are small, but once you put your ports and see in the monitor, there is no difference between an adult and a child. But if a good pediatric or safe pediatric anesthesia come for that, everybody looks the same. What's your input in that?
Thank you, sir, for the question. I would say that the pediatric surgeons are definitely instrumental in making the progress in this field because the children, the viscera, the anatomically, physiologically, everything is different in children. So anatomically, the chances of the viscera being compactly packed in a small peritoneal cavity. So the chances of visceral injury are much more if the care is not taken. And the pediatric surgeons are much more well versed with the physiology and anatomy of the small structures, and they are a better person to judge many things. And the physiology, like they need a smaller intra-abdominal pressure to counter the changes which occur. So these things, they are better understood, the physiology as well as anatomy. They are better understood by the surgeons, pediatric surgeons especially. So I think it is essential to have pediatric surgeons to do the procedures, along with obviously a very trained and well-trained pediatric anesthesiologist. That is also very instrumental, because these procedures, in addition to the pediatric age group, the challenges which are there in the pediatric age group, the challenges are added by the endoscopic procedures, because the laparoscopy itself has a lot of repercussions on the physiology of the child. So these things need to be taken care of very well by a vigilant pediatric anesthesiologist. So I think that is very important.
I agree completely. I think there's a lot of difference from the adult surgeon, the pediatric surgeon, and pediatrics understand much about the anesthesiologists, and you are more friendly and you are happy and you know your reactions than they do. I think that's quite, slowly the pediatric surgeons will take over and do I think they're doing a very good job now in all parts of the country, not only in the metro.
Yes, sir.
Okay, Dr. Anita is keeping quiet. I just want to ask her, what are the physiological changes do you expect? Why we are worried? What are the, like what Anju Gupta said, that a lot of physiological changes which surgeons will understand and all these things. Is there a difference of physiological changes that are happening in the adults and the children?
So basically, the physiological changes that are occurring in laparoscopy are because of three things. It is one, first because of the pneumoperitoneum, the second because of the Trendelenburg or the reverse Trendelenburg position, and the thirdly because of the effects of the CO2 that is getting absorbed after some time. So not very much different from adults, the changes are similar, and only few differences are that in very small children, when there is of pneumoperitoneum, the children can suddenly have a bradycardia and even arrest because of sudden increase in the intra-abdominal pressure. And there is already increased vagal tone in children. So this is a possibility of sudden bradycardia. And required in children are less. So if the pressures are moderate, around 10 millimeters, then in fact there is a good cardiac output because of a good venous return. The splanchnic circulation is squeezed and there is good venous return if there is a Trendelenburg position. But if the pressures go on increasing, then there is pressure on IVC and the venous return decreases, cardiac output decreases. So overall, in adults as well as in children, because of the institution of pneumoperitoneum, there is increase in central venous pressure, heart rate, the systemic vascular resistance, and even the pulmonary vascular resistance is increased. In respiratory system changes, in pediatric patients, the closing volume and the FRC relation is different. So there is a reduction in FRC because of the institution of pneumoperitoneum. Basically, there is a splinting of diaphragm. And if the FRC falls below the closing volume, which is a possibility in small children, then they can have atelectasis. So these are the main differences.
I think this is probably the principles of the adult and the pediatric is going to be the same, but it is very, very more exaggerated in children than the adults. That's what I find you should be careful in doing it. We'll come back to you. Actually, Dr. Anita Negate said that when you're putting inflation, there will be some bradycardia and things like that. So I'm not sure. But Sandhya, do you have any opinion about any pre-medication you want to give for the child? And especially a lot of people are giving anticholinergic to prevent the bradycardia for laparoscopy. Do you advocate, and what is your role of anticholinergic and any difference in pre-medication in these children?
Yeah, a lot of people recommend giving anticholinergics, but I do not give anticholinergic prophylactically because that increases the heart rate tremendously, and then it. What I prefer to do is keep Petropin ready and monitor very closely, and be prepared to deal with bradycardia when it occurs or when the heart rate starts decreasing. But I do not like to give anticholinergic pre-medication because it will increase the heart rate, but it may still not prevent the incidences of bradycardia. So it's better to be aware that such a thing can happen, more so in neonates and small infants, and be ready to deal with the situation.
We have talked about a little bit of pediatric. I think that Anju Gupta is much interested in neonatal anesthesia. I just want to know, is there do you do, what are the places where you do neonatal laparoscopic procedures, and what is the percentage of you do in laparoscopic procedures in neonates? Let us not talk about thoracoscopy and other things. I think let us stick on to laparoscopy. Do you do any of the neonatal procedures laparoscopically, and which you feel that advantages, and you are happy to do that?
Yes, sir. Thank you, sir. Sir, we are doing diagnostic procedures. Some of the diagnostic procedures like necrotizing enterocolitis, the surgeons, they do diagnostic laparoscopy, and if there is a single perforation, they repair it laparoscopically only. And if there are multiple, they would open up. So that is one very advantage of laparoscopy, that we can just know what is happening inside. Then another procedure which is commonly done is pyloromyotomy in IHPS cases, idiopathic hypertrophic pyloric stenosis, those cases. So then some lap-assisted procedures are done, like lap-assisted pull-through is done sometimes, not very frequently. And lap-assisted anorectoplasty is also recently being done. So these are advanced procedures which are done only by a few consultants, not very frequently. So these are the main procedures. Sometimes duodenal atresia also is repaired directly, laparoscopically.
I think slowly when the expertise increases, they become very, and they slowly the age of the surgery, I think in neonates and preterm, they keep on coming, I think so.
Yes, sir. Yes, sir.
No, they have told about pediatric and little neonate. Dr. Anita, do you have any idea? I'm not sure where you can say that I don't want to do this under laparoscopically, like any contraindication to do any child for on a broad outline. I'm not telling you maybe individual differences may be there. On a broad outline, do you have any idea that what are the contraindications? You can tell them this cannot be done or this should not be done. I'm not sure whether there's any specific contraindication for this.
So actually, it is a relative contraindication. There are no absolute contraindications. Only certain anatomic abnormalities, like suppose there is difficulty in accessing the abdomen because of maybe adhesions or because of a severe kyphoscoliosis in a child where it is not possible to look at the organs laparoscopically. So anatomical difficulties or another limiting physiological limitations may be the patient who is having very poor and cardiac reserve, who will not tolerate the pneumoperitoneum. So very severe myocardial disease, right to left shunts or such patients. So these are all relative contraindications. Only these two I can think of.
I think so. This is a little relative and depends upon the experience of surgeon, institutional practice, how the child is, how expertise you are to manage. I think that's a little bit of your own. You decide which is best for the particular child. Is okay.
Yes, if the child needs surgery, then laparoscopic surgery will be much better for the child than the open surgery because of the other respiratory problems, the pain.
Post-op pain.
Yes.
Okay, you have talked about little about introduction, then what are the things can be done on broadly. Is there any change in the induction? See, you have to do IV and inhalation induction is probably it's a preference for that particular anesthetic choice. But I'm not sure whether, see, I used to do a little bit of a nitrous initially so that it will put, because we are old people, so we used to do nitrous. To take off nitrous is going difficult. Dr. Sandhya, are you during the induction to put the child, do you think that nitrous initially for induction will be of any problem, or you can start for the induction inhalation, then put in an IV, or you want to put in IV, then you can do your, so what's you are thinking, Dr. Sandhya?
Yeah, some children already have an intravenous cannula when they come to the OT. So in those cases, we can straight away go for intravenous induction. But if there is no IV cannula, we can go for inhalational induction. But nitrous oxide can be avoided, and for induction as well as maintenance, because that does increase the gas in the bowel, and bowel may get distended. Though there have been some studies which have been done in adults, and they have blinded the surgeons and asked them to tell us without telling them whether nitrous was being used or not, and they could not tell. But most of the times we do avoid nitrous oxide just in case it does distend the bowel, and just to ensure that the surgical field is much better.
I think that's okay. I think better when now the things are that nitrous oxide is going off even generally to every surgeries. I think that question come, except we have used sometimes that some people after about 10 years, they want to even see nitrous oxide being used. Some of the centers, they don't have a central supply of a nitrous also, but it's only the young people may not even like what they are not or ether, they may not even now, soon they may not even use nitrous oxide. And one of the practical thing I found is that when they are having a difficulty, they look at the flow meter, the surgeon, and once the nitrous oxide is there, they blame everything only on the nitrous oxide. So at least for that, better avoid and don't give nitrous oxide. That's why I'm just giving you this is a practical thing which is quite okay. Yeah, you're induced by and induced whatever it is. And Dr. Anjigupta, there is a lot of this one. We'll come back to the supraglottic little later, but I just want to know whether you intubate. If you intubate, and is there any precautions you must do, especially for laparoscopic procedures? And you prefer a cuff tube or uncuffed tube? And do you have a laxant? Or you want to induce with the spontaneous intubations? And tell me on what the precautions you will take. This is a little bit of a specifically for let us not talk about the thoracoscopy. I am talking about laparoscopic procedures.
So the main precaution which should be taken during intubation is that we should be very careful in avoiding the tip of the tube should always be mid-tracheal, because the carina will move up, peritoneum will be induced, the carina will move up, and there is possibility, because the trachea is very short in children and infants, it is very small. So it can the tube will easily become endobronchial when the pneumoperitoneum will be induced. So one important precaution is keeping the tube mid-tracheal very carefully, and be very carefully positioned. The tube should be carefully positioned. Regarding the cuff versus uncuffed, sir, in our institute, in general, though it is consultant-based practice, but in general, everyone is using cuff tubes nowadays. So cuff tube has a lot of advantages in pediatric patients, recently recognized, and especially with the availability of the microcuff tubes, the few disadvantages which were considered earlier to be important in this age group, they have also been negated by the use of this microcuff tube. So the main advantage being that there is less need of change of the tubes, frequent change of the tubes for the tube sizes, the tube replacement and exchange is now less common with the use of cuff tubes. Then the theater pollution, then low flow anesthesia, and inhalational economy with the use of low flows, all the advantages come in play with the use of cuff tubes. So these are a few advantages. And with microcuff tube, we can avoid the cricoid area damage because the cuff is distally placed. So that disadvantage is also countered. Regarding controlled versus uncontrolled, so that was the third part of it. So we are always using controlled ventilation, though it has been mentioned that for some superficial procedures, small procedures, and lower abdominal procedures like hernia and orchidopexy, it is possible to use spontaneous ventilation also, especially in cases where controlled ventilation, because controlled ventilation has its disadvantages. It increases the ventilation perfusion mismatch and all, which can be better preserved. So in patients who have a pulmonary disease pre-existing, it will be better for the sake of the child to maintain in spontaneous respiration, but definitely for very short lower abdominal procedures.
Yeah, I think it's all the choice what you want to do. But the only thing I found that it must be very important that as a small baby, the tracheal length is small. The tip of the tube should be very, very careful. Otherwise, it will go to endobronchial. Like what it's okay. So we are talking about endobronchial intubation. Going with I found the supraglottic airway is a better choice because you don't have to bother about it, about the tube going down and the cuff tube and all this. Sudarshan, what is your opinion about supraglottic airways using for this laparoscopic procedures? There are for and against, but I think what is your take home of supraglottic airways?
Yeah, supraglottic airways definitely, as you said, plays a very important role in laparoscopic these days. Again, my experience, I would say, in the past 20-25 years, we're using supraglottic devices and also combining it with laparoscopy in careful. First, you should gain experience in using it in adults for a laparoscopy. That itself is a big challenge for many. But, in adults, acceptance of the supraglottic devices, second generation works wonderfully well by sort of allowing you to access the stomach with a gastric tube and then deflating it and then placed well and with a nice design of the cuff with the second generation device, supraglottic devices gives a wonderful control compared to endotracheal tube. A lot of studies support that. But then extrapolating that into the pediatric laparoscopy experience of using the device primarily. First use that in adults and then gain experience doing it for laparoscopy, then transfer that to children The ProSeal is one of the remarkable supraglottic airway device. I think it seats so easily well and then gives you a good control over the airway very easily, especially in children. If you're a regular pediatric anesthetist, you would certainly accept with me that introducing a ProSeal LMA is much easier than intubation. Definitely, yes. But then keeping it in place during laparoscopy is a big challenge because smaller children, any change in positions of the head, the surgeon is moving around, the increasing pneumoperitoneum, the pressure exerted on the stomach, on the abdomen, and then splinting effect. All that mitigates. You need to sort of experience and then adjust your technique according to that. Somebody who is trying the supraglottic device new for a laparoscopy in a child, I wouldn't recommend that. So gain your experience first, use it in adults, use for laparoscopy, then transfer that into children, use that for laparoscopy in children, the second generation. Definitely they are wonderful devices, but then there's no, I wouldn't say, what is against is your expertise and experience. Play a significant role negative, giving you a rather poor outcome, both for yourself, the surgeon, and the child. So that's my what I have seen over the several years. We've seen a lot of people who get into trouble by putting in a supraglottic device for a laparoscopy and then say that they have to convert that into individual tube during the procedure. That shouldn't happen. If you choose your right patient, right procedure, and then the right size, everything comes with experience. Do that. I think you will not fail. Thank you so much. Does that satisfy you?
I think that's all right. Just to reiterate, I think the short procedures, whatever it is, I think it's okay. But I feel that to tell the people who are listening that there's a difference between a pediatric anesthesiologist, occasional pediatric anesthesiologist. If you have doubt, please put in a tube. I think that will be safer. Because if you're in doubt, please put in the tube. I think that will be safer. Doesn't mean that this work can be used, but you should have like Sudarshan will be an expertise. But changing the in case that you are a doubt, even in the middle of this one, if you think that there is a big change, it's not a failure of supraglottic airways. You can always stop them and change the tube for the safety of the patient. I think with that, just want to tell Dr. Anita, what are the monitoring you like to do for this particular child? I just want to tell 1, 2, 3, 4, 5.
Yes, sir. The routine monitoring like pulse oximeter, NIBP, ECG, then precordial stethoscope for detecting the endobronchial intubation. And if you have, then the transesophageal echo is advisable for detection of the gas embolism, if your center has. And the temperature, very important because the cold gases and the child can easily get hypothermic. So the pulse oximeter, NIBP, ECG, temperature, a precordial step, and a TEE, if there.
Practical aspect, I'm thinking, I think it's a good idea to have a TE for the project to find the laparoscopy, but I think the learning curve, TE and the expensive, the cost and looks little, well, I feel, not that it's ideal is different, but I think the ETCO2 will be fairly good idea at exactly.
I think I forgot to mention.
That's okay, that's all right. I'm just, ETCO2 is quite okay, but I think it's good to have a TE.
Yes, on ETCO2, the gas embolism is detected late, but still it gets detected on ETCO2.
That's absolutely right, but it's very important. But you must think about the anesthesia is actually it's an art as long as it is economical. But I think it's important to think of that, and it's okay. I think I think she has re-insisted that air embolism is a major problem in laparoscopy. That's what she has insisted. Dr. Sandhya, what are the I feel of all the monitors, the main problem I had is the temperature. It's really going down to 30, 31. They don't bother. They keep on, and the surgery is very prolonged. They are exposed. And what are the methods to prevent hypothermia, especially for laparoscopic procedure? There are a lot of recommendations. What is your take home for that to prevent hypothermia?
Like I mentioned, temperature monitoring is the most important, so that we know what is happening. So place a temperature probe in to measure core temperature and keep track of it. Before the child is handed over to the children, to the surgeon, wrap the limbs properly. You can use cling film or we can also use convection warmers for the child. what we generally do is we use a convective warmer or a heating mattress. If there is a heating mattress, that is very helpful because the whole surface, lower undersurface of the child is heated. In addition to that, we can use heated and humidified gases for ventilating. And of course, we use warm intravenous fluids. Now, as the surgery gets prolonged, there are chances of more and more hypothermia to occur. So we must keep a watch on the temperature, and if it starts going down, despite our efforts to keep the child warm, we must inform the surgeons, and they can maybe convert it to open and finish it quickly. In addition to hypothermia, we have also seen hyperthermia in many children. That probably occurs because the child is completely covered and we are providing external heat in, and in addition to that, there is the light source inside the closed abdominal cavity which generates heat, and some small children do get hyperthermic. So we need to monitor the child carefully regarding the temperature continuously, and keep the child covered before the surgery starts, because once the surgery starts, we won't have access to the child.
Do you think warming of the gases are very important, especially the insufflating gas? Is it? I'm not sure all this availability of that.
This may not be available, but it does help. We actually do not get warm air; we get cool air only. So that does. Higher the flow, higher the leaks from the ports, more gas is used, and more gas means more hypothermia.
I think that's a very, I think even important point. Doesn't even on hypothermia, it will cause hypothermia. So without temperature monitoring, please do not warm any of the children, not only for laparoscopy, for bronchi. Dr. Anju Gupta, do you think what will be the pain? I see this. They are talking about pain is less and pain is less, but what is your I think what is the pain relief? Do you give any regional blocks or do you give any other fascia plane central neurological blocks? What type of blocks you like to give for the laparoscopic procedures?
But for pediatric laparoscopic procedures, we are generally not using central neurological blocks. We are using facial plane blocks. For major procedures like pyeloplasty, laparoscopic pyeloplasties and all, I am using it with a very good result. In fact, I have a thesis, given my thesis to my candidate. So the patient is pain-free for at least 24 hours post-op, and there is no need of any opioid post-op. So that I have found very good for this pyeloplasty and any nephrectomy kind of procedures. And I have seen the recovery, the difference between the recovery where the patient is solely maintained on parenteral analgesics versus when we add a regional block to the multimodal analgesia blocks. Then, sir, for lower abdominal procedures like orchidopexy and hernias, I'm using classic TAP, and that is also provides a very good pain relief. Obviously, everything has to be combined with the multimodal analgesia, including dexamethasone at induction, then ketorolac and PCM at the end. So all these things are combined together, and then the NSAIDs are routinely given around the clock to the patient along with this regional blocks, and this provides a fairly good amount of pain relief to the child. So we are happy with it. Interfacial plane blocks, I think, answer.
I understand all the facial blocks like TAP and this one is all these facial blocks. I think they will not. There's the petroleum is distended and viscera has been distended. There's called visceral pain. So Sudarshan, what is your? I think I'm not sure. There's a erectrospinal block might cause a little less of a visceral pain, but I'm not sure. Do you manage anything else with the visceral pain?
Yeah, visceral pain is a big challenge to treat, especially in children, because you don't know why the child is crying. When particularly you have no control over what went on into the tummy while the surgeon is operating. It's purely the surgeon's domain to sort of make efforts to control this visceral pain, especially those recent articles in 2017 that while doing the dissection of gallbladder in children, the glisson's capsule has to be taken into account. Don't contrast that. It was published in 2017, and then a big publication saying that all these difficult dissection, electrocauterizing the tissues inside at the very closer to the nerves causes a significant visceral pain. But there have been a lot of suggestions to control the visceral pain by in terms of locally infiltrating before they do the dissection at the bed of the gallbladder, especially when they're doing a gallbladder surgery, or infiltrate a local anesthetic around the area of the viscera to overall reduce the possibility of the postoperative visceral pain, especially in children. In spinal block, definitely there are a lot of studies which is suggested that it mitigates the possibility of reducing the severity of the visceral block compared to other superficial plain blocks. And then, of course, you have other armamentarium of other drugs. But I think visceral pain is the one thing which is definitely the surgeon needs to keep in mind. And anesthetists need to warn them that the careful, the guarded dissection at the surgical area really helps the child to recover easily, quickly. Because especially if you have seen the difference, I have seen so many. We have so many laparoscopic surgeons in the center, and there's a definitive difference between some surgeons doing the laparoscopy on a child and the other person. You will see the difference, the pain especially. So it means that how much respect they give to the tissues, how they dissect, how careful they are, and then how comfortable they reduce the usage of cautery at the places where it can worsen the pain. All these outcomes is definitely comes out with their repeated performance and expertise. I think we should be in a position to support them to overall have a better outcome.
So can I add something here?
Yeah, please.
Sir, one more thing which I would like to say is that we should always get the CO2 fully expelled out of the peritoneum, because that is also one irritant to the nerve endings. So we should carefully get it out. Sir, then regarding the visceral pain, recently, like today itself, there was a nephrectomy case, and I gave a costal block. So it is like a interfacial plain block, but it doesn't control the visceral pain. So the child had opioid requirement in the post-op, and the child was in pain. Whereas a few days back, I did a pyeloplasty under erector spinae plain block, which provides some amount of visceral pain, and the child was completely pain-free for more than 24 hours. So I think that is the main thing about visceral pain. So I think we should go for.
There's a lot of research going on. I think erector spine is because it's okay. Dr. Sandhya, do you find, is there any, talking about the pain, talking about the CO2, hypothermia, you have any situation where you had a crisis situations happen, then you have to stop the procedure, not for surgical indications, for any of the anesthetic indications, you have to stop it and then open up the procedure. Have you remembering any crisis situations happen that you have to stop it, or have you met any complications, not blood loss and all these things? Where you have to stop. Just think what you can think of, what can happen.
Yeah, it's mainly for the respiratory problems. If the CO2 is going very high, then we may need to ask the surgeon to stop. It mostly happens if it has been going on for a long time, or if the child is a small infant. So if despite the changes that you make in your ventilatory parameters, if the CO2 is still increasing, say if it is going above 50, 55, in that case, you may need to ask the surgeon to stop the surgery, laparoscopy, and open up the abdomen.
Now, if you have done the ET CO2 is high, can you stop the inflation and ventilate? Then again, you can inflate. Does it help you to proceed with the laparoscopy, or you have to open up?
Yes, we generally go in steps. First, we ask them to reduce the flow rate and then decrease the pressures. If that doesn't help, then we need to open up.
Ranita, we have told about all the pain relief. What type of mode of ventilation you like to do with these patients? What type of, you're on a workstation, everything, what mode of ventilation you like to do in children? Probably intubated one. I'm not talking about LMA, you intubated the child.
The controlled ventilation only, sir. Controlled ventilation, because it is too difficult for very small procedures, only spontaneous though we know that the ventilation V2 mismatch is more on controlled ventilation, but for the removal of the CO2, the excess CO2, we need to control ventilation and give a 20% extra minute volume to this patient, so that and we are monitoring the ETCO2 anyway.
Dr. Sandhya, do you use a pressure control mode or a volume control mode, Dr. Sandhya? Do you have any preference in that, or both are okay?
We generally use pressure control mode, but we need to keep a watch on both the tidal volumes which are being generated and the pressures that we have set. So, and add PEEP also. And in case we have put in an arterial cannula, then we can also do an ABG analysis and see what the PaCO2 is like. Because the problem here is because of pneumoperitoneum and raised diaphragm and atelectasis, the difference between arterial and end-tidal CO2 is going to be high. So what CO2 we are seeing on the monitor, PaCO2 may be much higher than that.
I think Dr. Sandhya has given on another point that during the monitoring, if you think it's going to be a little complicated or prolonged, I think arterial line, because already dead, I think arterial line might help you to exactly see the pressure changes, necessary blood gases, and you want to do an base excess and things like that. Maybe have some help, and if you're an arterial line and for complicated procedures, which is okay. This is the last question, Dr. Sudarshan. I don't know what you put on a control. At the end of it, they're only the junior resident, and they are closing the port, and the child is spontaneously, breathing a little bit. Do you want to give a relaxant, or you want to change the mode? Any mode which will be of some help. Muted.
Yeah, the pressure control mode is a preferred choice. I won't allow the child to be breathing against your ventilation during the time of recovery. If they have completely released the pneumoperitoneum, yes, you can try and change over, you can try and give some propofol and tide over time. But they still have some more time to complete the port closure and other things. You can try using alternative modes of your ventilatory strategies. Your SMV can be tried, and also this pressure support can be increased, so that overall the child doesn't fight. The concept, the idea is not to allow the child to fight against your ventilation. But then, in spite of all these things, a little bit of propofol here and there will help you. But in spite, I've seen a lot of children, they do nothing wrong giving a small dose of relaxant and then ventilate nicely and then come out at the end of the day, very comfortably waiting for that particular time for the relaxant to go out of the system. Yeah, you can try all the change of modes and things like that, but surgeons are not going to be happy, to be honest to you. I have seen a lot of surgeons, if the child is coughing around, if the child is breathing towards the closure, they are not happy at all. So you can try changing the mode, but particularly I have seen the comfort is to give a small dose of relaxant and get out of the situation at the end of the day. Yeah.
I think it's come to a particular point. Just want to highlight that if it is coming and it's a short procedure as a child, we can put him on a pressure support if you've given a good pain relief and you all the blocks. I think I just want to give you, it's all that what happened that particular time. You can't give a rule that you do this or do that. If you have pressure control, you can always put on the pressure support.
Additional pressure support, yeah.
Pressure support, because just one that if we can use other modes, so you just have to synchronize as well with the flow cycling, and it will be quite okay with that. I think we almost come to the end about the pre-op assessment, whether you want to put a tube or this one, then nitrous oxide to be avoided. Better you give probably a electrospinal block that will reduce your visceral pain. Be careful with the visceral pain. Nitrous oxide to be avoid monitoring, especially temperature is a must. If necessary, even you can put an intraarterial line. And the mode of ventilation, you do a pressure control mode and or volume control. Mostly pressure control mode will be better, because your collapse of the lung is a little different in each lobes during the laparoscopy, and then you can, in the end of the surgery, you can also either deepen it or you can put on pressure support depending upon that. And we have covered almost most of the time. It's very difficult to cover the whole thing in about 40 minutes. But the last question is to all. One of them is can put the side with. The last question is, they're all talking about robotic. What is the main problem of a robotic laparoscopic surgery? I I feel it is common. They say they all robotic. I just wanted to tell you, Dr. Sandhya, what is your robotic surgery problems?
Robotic surgery is laparoscopy with more problems. That is what I would say, especially for the anesthesia. It takes much longer time. The child is completely far away from us. So once the robot is docked in, there is no way we can reach the child. So all the monitoring, all the intravenous lines, our airway, everything very nicely secured and functioning.
I think that's a very important. I say robotic surgery is laparoscopic, but you cannot. This is a minimal access surgery, but no access anesthesia is robotic surgery because you can't access anything. I think that's a whatever monitor you put, extra monitor also you can put it because you cannot reach and you put more lines than what usually you put it. And I think that's how and that's also learning curve as you do laparoscopy. I think another about 4-5 years and people will be doing more of laparoscopic surgery. I think we are finished. We have about 5-10 minutes. That's okay. I don't know. They can edit my first 5 slides so that the panel can go on and don't have to have introduction slides. Let the organizer decide to cut off and all these things, but that's a good way. Thank you, Dr. Sudarshan, Dr. Anju Gupta, Dr. Sandhya, Dr. Anita Nigate. And I just want to probably conclude that laparoscopic surgery may be a minimal access surgery, but it's a maximal risk and maximum physiological changes which happens. Don't take simple that laparoscopic surgery is much simpler than open surgery. It has got its own fors and against. I think, thank you very much for joining us. I'm sure the organizers will be happy and it's a big expert. Everybody has done their input. Thank you very much.
Thank you.
Thank you, sir.
Thank you.
Thank you very much, Dr. Ramesh, sir, for moderating that panel excellently. And now I will ask if there are any questions. Are there any questions in the chat box?
No. Only comments are there in the chat box.
Okay.
Thank you, Dr. Anita. It was good.
Thank you, sir. As it is got very late and there are no questions here.
No problem. Thank you.
Thank you, sir. Have a good day.
Thank you, sir, and all the panelists. So we are concluding the session. Thank you.
गालियां इन्होंने दी है ना,
किन्ने?
मैं होटल वालों को गालियां निकालता हूँ, सबको फोन कर हो रहा था, नेट की स्पीड बिल्कुल डाउन हो गई। मैं होटल वाले को पैसे दे रहा हूँ तो बात हाँ, नेट की स्पीड बिल्कुल डाउन। 5 MB का अपलोड स्पीड दे रहा है, वो हाथ पहुंच हो रहा है, दो के दोनों लाइन डाउन हो गई। अब उनको थोड़ी पता कि नेट
लेकिन वो बाहर जो कोई नहीं था
लेकिन यहाँ पे भी दिक्कत आप देखेंगे थोड़ी डिस्टर्बेंस आ रही है। जब आपने मैंने बोला अब एज ए टेक्निक पे भी मैंने आपको उस टाइम तो बोल दिया, एक कंप्लेन मेरे दिमाग में था, फिर मैंने कंप्लेन किया, मैं जाके अब
पहले वाले लेक्चर में भी यही हो रहा है। हाँ, वो बोल रहे थे ना कि वे स्लाइड्स आगे नहीं हो रही है, वो बोल रहे थे डॉक्टर मुरली थोड़ा लैग हो रहा था, वो लैग बोला उसके बाद स्लाइड्स तो हो गया ना आगे तो स्लाइड्स आगे नहीं जा रही थी, स्लाइड्स उनके आगे नहीं जा रही थी, वो उनके सेट में
वहाँ
हाँ हाँ अच्छा हमेशा वीडियो पहले आ रहा है, ऑडियो बाद में आ रहा है।
तो आपने मुझे डाउट के पहले आपको करके निकलना, उसके बाद भागता हूँ, फिर भागा, फिर तब से भाग देगा दौड़ रहा हूँ कोई लगता है मैम कहेंगे यस सर। कौन सी मीटिंग खत्म हो गई? आ गया तुम सब आ रहे
तो आपसे एक हेल्प चाहिए।
यस यस सर।
कल कोविड पे लेक्चर था ऑल एम में। अच्छा, दिल्ली का कोई स्पीकर था एम्स के, उसका नाम ही मुझे, उसका रिकॉर्डिंग चाहिए मुझे।
ऑब्वियसली सर, जो हम लोग पास रिस्ट्रिक्शन होती है कि हम लोग किसी का भी लेक्चर किसी और को शेयर नहीं कर सकते, ये वेरी कॉन्फिडेंशियल पार्ट होता है। जैसे जस्ट लाइक आपने मुझे वीडियो रिकॉर्डिंग दिया।
सर आपको पता कैसे मिलेगा? आपको जूम लिंक है?
मेरी बात सुनो, मेरे लेक्चर सुना है तो मेरे पे रिस्ट्रिक्शन नहीं है, समझे? सही बात है गलत बात? आप मुझे या
उस
उसका
क्लाउड पे मिल जाएगा।
मैं डॉक्टर लेक्चर है ना, मैं उनका अगर नंबर दे देता हूँ, आप बात करिए, अगर वो अप्रूव करते हैं तो
ठीक है, मैं आपको उसका उनका डिटेल देता हूँ।
मैं उस हॉल के हॉल में, माइक बंद करो सर, माइक बंद कर दो।